Good morning, all of you. Good morning. Welcome to Pediatrics Crash Course. Good morning, all of you. My name is Siddharth Sethi, and what we'll do is, let me tell you the plan of the day. Our plan of the day is that till 9 o'clock today, we will be discussing all the important topics which you need to know. And I will also be, discussing important questions also which came in the last NEET PG questions, and you should know what should be your approach. Okay, so all of you, am I audible? Let me check myself. Yes, I can check myself. I'm audible. So what we'll do is, let us start with neonatology. And neonatology, what is important is that in the last few years, a lot of guidelines have changed. So all of you should know that, especially if I talk about the 1st of July last year, 1st of July last year, the new neonatal resuscitation program guidelines came. So 1st of July last year, we had the new textbook of neonatal resuscitation. This is called the 8th edition. So last year, they came with the new guidelines. So let us talk in the next 15 minutes. So first of all, you should know that now, even before a child is born, all of you, we ask yourself 4 questions. So even before a child is born, you anticipate. Okay? So you should anticipate. Okay, so anticipate that a sick baby or whatever baby is going to be born. So ask yourself 4 questions: gestational age, amniotic fluid is clear or not, any risk factors, and the cord management plan. So all of you, you should know what you're looking at. Okay, the gestational age of the child, amniotic fluid, risk factors, and the cord management plan. Okay. Okay, remember this. Now, when a baby is born, once a baby is born, remember, you have to ask yourself 3 questions. Remember, when a baby is born, you have to ask yourself 3 questions. And what 3 questions you have to ask? Term, good tone, breathing or crying. Term, good tone, breathing or crying. Okay, term, good tone, breathing or crying. Okay, term, good tone, breathing or crying. So if the answer to all of this is yes, transfer to the mother. Okay, so I'll just take you step by step. Over the next 15 minutes, I'll take you step by step. So term, good tone, breathing or crying, transfer the baby to the mother. Okay. Now all of you, if the answer is no to any of these, baby is not term, baby is not having good tone, baby is not breathing, so now what do? Now you do TABC. So remember, in newborns, our sequence is TABC: temperature, airway, breathing, circulation. Okay, temperature, airway, breathing, circulation. So remember, in newborns, our sequence is TABC. So if the answer is no, you look at the temperature, warm the baby, dry. Now remember, dry is kept right in the front. So last year on the 1st of July, the new American Academy of Pediatrics guidelines said dry should be right in the front. Dry the secretions, wipe out all the secretions, stimulate by rubbing the back or the soles, position the airway, neck should not be hyperextended, neck should not be hyperflexed. Okay. Suction. So all of you, I will make this class very interactive. So I want all of you to interact. Okay. So my question to you is, what would you suction first? Mouth or nose? So let us make it interactive, guys. And my question is, what do we suction first? Mouth or nose? Yes, class is till 9 o'clock. So what do we suction first, mouth or nose? So what is the best, stimulus for respiration? So best stimulus for respiration is a catheter in the nose. So as soon as you put a suction catheter in the nose, baby starts to breathe. So if I suction nose first, he aspirates the mouth secretions. So all of you are right. It is, the sequence is MN. All of you are right. I can see a lot of questions, students telling this. Yes, all of you are right. It's mouth followed by nose. So we suction the mouth followed by nose. Alphabetically also, guys, someone wrote alphabets. I don't know who wrote, but he also said, beta, M always comes first. So students, now let's take you to the second situation. I'll take you to 4 clinical situations. First is this. Second is, after the initial steps, baby is not breathing. What do I do? Guys, after the initial steps, baby is not breathing. What should I do? If the baby is in apnea or gasping after the initial steps, I start him on bag and mask ventilation. So all of you, number 1 indication of bag and mask, baby is in apnea or gasping after the initial steps. Baby is in apnea or gasping after the initial steps. Or T, A, B is fine. You look at the C. C is heart rate. So T dekha, A dekha, B dekha. Now I look at the C. So if the baby is completely breathing but heart rate is less than 100, you start the baby on bag and mask ventilation. What is bag and mask ventilation? It is a positive pressure ventilation. Bag and mask ventilation is a positive pressure ventilation. Okay? Bag and mask. Ambu nahi bolte. No, don't say word ambu. Ambu is anesthesia. In pediatrics, we say positive pressure ventilation, which is called bag and mask ventilation. So remember these 2 indications of bag and mask. Apnea or gasping, heart rate is less than 100 per minute after the initial steps. Now all of you, all of these steps, whatever I am telling you, 1, 2, 3, they are all important. Now you put a pulse oximeter. So remember, once you start bag and mask ventilation, you should start pulse oximetry and consider cardiac monitoring. So you may think of, putting a ECG probe. So you may think of putting a ECG probe. Okay. So remember this, think of putting a ECG probe. Let's go further. Now all of you, my question to you is, what oxygen would you like to use in a bag? So all of you, what I'll do is I'll just show you a bag, how a bag is. See, this is how a bag is. Okay. This is how a bag is. So there is a bag. There is a apparatus here by which you can increase the pressure. There is a, here you can attach a reservoir bag. Ek bada sa, you can put a reservoir bag here. And this is the connection of oxygen. So my question is, how much oxygen do you give in positive pressure ventilation? So remember now, according to the guidelines, if a baby is 35 weeks or more, so according to the guidelines, if baby is 35 weeks or more, room air. So according to the guidelines, if baby is 35 weeks or more, room air. If baby is less than 35 weeks, we use 21 to 30% oxygen. So remember, in preterms, don't use 100%. Remember, if you use 100% oxygen in preterms, it can cause ROP, retinopathy of prematurity, blindness. So remember, in babies less than 35 weeks, we should go for 21 to 30% oxygen only. Okay. Okay, cool. Noted? Noted? All of you, can you just write noted in the chat box? Now, all of you, what I'm doing is, I'm doing bag and mask, positive pressure ventilation for 30 seconds. Okay, I'm doing positive pressure ventilation for 30 seconds at a rate of 40 to 60 breaths in a minute. I'm giving breaths at the rate of 40 to 60 breaths in a minute. Now, all of you, my question for you, and I want all of you to answer this question. All of you in the chat box, answer this. What is the best indicator of adequacy of ventilation? Anyone in the class? What is the best indicator of adequacy of ventilation? Is it improvement in the heart rate or chest rise? What is the best indicator of adequacy of ventilation? Is it improvement in the heart rate or chest rise? Improvement in the heart rate or chest rise? What is the best indicator of adequacy of ventilation? Improvement in the heart rate or chest rise? Maybe, I will also name whoever answers first, okay? Improvement in the heart rate or chest rise? And Varun is right. Improvement in the heart rate is the best indicator of adequacy of ventilation. Improvement in the heart rate. Now, if heart rate is not improving despite your ventilation, you do ventilation correction steps. So if heart rate is not improving despite your ventilator corrective steps, you go for ventilation corrective steps. Mr. Sopa. So my mnemonic is Mr. Sopa. Who is Mr. Sopa? Who is Mr. Sopa? This is a mnemonic for ventilation corrective steps. Adjust the mask, reposition the head, suction the mouth followed by nose, suction the mouth followed by nose, open the mouth, okay, open the mouth, lift the jaw forward, open the mouth, lift the jaw forward, increase the pressure. So in this bag there is an apparatus to increase the pressure. You can increase the pressure in increments of 5 to 10 centimeters water. So remember, you can increase the pressure in increments of 5 to 10 centimeters of water. And now if nothing is working, heart rate is not improving still, you put an endotracheal tube. So nothing is improving, you go for endotracheal tube or laryngeal mask airway. Okay. So if nothing is improving, you go for endotracheal tube or laryngeal mask airway. LMA is laryngeal mask airway. Okay, all of you, fine? Noted? 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 Noted, everyone? Now I'll take you to the next clinical situation. All of you have to write, note it, so that we go further. Now the next clinical situation is, I will see this child after every 30 seconds. Now after 30 seconds of positive pressure ventilation, heart rate is less than 60. All of you, after 30 seconds of positive pressure ventilation, heart rate is less than 60. What do I do? Anyone in the class? Heart rate is less than 60. What do I do? I will start him on chest compressions. So all of you remember, if despite 30 seconds of bag and mask ventilation, heart rate is still below 60. Remember, despite 30 seconds of bag and mask ventilation, if heart rate is still below 60, I will start him on chest compressions, a favorite question of your examiners. Start him on chest compressions. Okay? So start him on chest compressions. Okay? So what are the indications of chest compressions? After 30 seconds of bag and mask ventilation, is heart rate is less than 60. You start chest compressions. Now this is the time to start 100% oxygen. Believe me and remember this, we only give 100% oxygen when we start chest compressions, even in preterms. Okay, we start chest compressions. Then only we start them on, okay, then only we start them on chest compressions. Okay. Now put a endotracheal tube or a laryngeal mask airway. Now when you start chest compressions, remember you put them on laryngeal mask airway or endotracheal tube. Start a UVC. Start a UVC. What is UVC? Umbilical venous catheter. So put them on a UVC, which is umbilical venous catheter. Okay, because you may need to give him epinephrine in the next step. Now, so remember all these 4 points. Intubate, chest compressions if heart rate is less than 60, 100% oxygen, and umbilical venous catheter. Now, how do you do chest compressions? What should be the site? Let's talk about what should be the site of chest compressions. So all of you make an imaginary line between the nipples. Now midway between the internipple line and the xiphoid process is the compression area. So midway between the internipple line and the xiphoid process is the compression area. Okay? Midway between the internipple line and the xiphoid process is the compression area. Okay? Remember this. Okay, noted? Now, how do you do chest compressions? So remember, in newborns, the chest compression is always done like this by 2 thumb technique. In newborns, it's 2 thumb technique. So we encircle our arms around the baby and we do 2 thumb technique. Okay, so we encircle our arms around the baby and we do 2 thumb technique. Okay, using 2 thumb technique, we do chest compressions using 2 thumbs. Now, how deep do we go? How deep do we go? Remember, we compress at least 1/3 of the AP diameter of the chest. We compress at least 1/3 of the AP diameter of the chest. I remember, so all of you in my institute, in my hospital, I have to clear these resuscitation program every year. So in our programs also we have MCQs in our hospitals. So you know we are supposed to answer at least 1/3 of the AP diameter of the chest. At least 1/3. Now how much? What is the ratio of chest compressions to positive pressure ventilation in a newborn? What is the ratio of chest compression to positive pressure ventilation in a newborn? 3:1. Okay. Okay. 3:1. 1 and 2 and 3 and squeeze and 1 and 2 and 3 and squeeze and. Okay. So in 1 minute, 90 chest compressions and 30 positive pressure ventilation. Okay. Okay. So they may ask you in 1 minute how many events? 120 events in 1 minute. Okay. So in 1 minute we do 120 events in 1 minute. Okay. 120 events in 1 minute. Okay. Remember this, 120 events. Okay. So all of you, this was about a newborn, but what about older children? Can you tell me what is the ratio of chest compressions and mouth-to-mouth respiration in older children? What is this ratio in older children? So remember, in older children, the ratio is if you are all alone. So when I was driving today, there was someone on the road. I did not stop. You know, we Delhi walas are very bad. You know, we are always on the run. We are always late. Yes, Delhi walas are not good. But suppose you're not from Delhi, then the people outside Delhi are very good. They help. So if someone helps, older child, the ratio is 15:2. So in older child, the ratio is 15:2. If you're all alone, it's 30:2. Okay, so remember this. Okay. Okay, remember this. Now let me see if I can show you a video. Remember, when you are all alone, it's 30:2. Remember, when you are all alone, it's 30:2. Okay, when you're all alone, it's 30:2. When someone comes, it becomes 15:2. So let me show you a video, if I can show you, of an older child. Okay, she's a lady, and she's all alone. First, let me just check my audio also. Give me 1 second. I'll open my audio, and I'll show you a video.
Hey kid, you okay?
No.
Kid's on.
No, not this one. Sorry, I'll show you another. This one.
Baby, baby. Greg, she's not breathing. Activate emergency response.
Got it.
Activate emergency response.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. One, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30.
The cart's on its way. Let's start 15:2.
Start compressions.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15. 1, 2, 3, 4, 5, 6.
So did you see, when she got a friend to help her, and now they are doing 15:2. Now all of you, heart rate is not improving. Despite chest compressions, heart rate is not improving. Remember, when we do chest compressions, after this we see the baby for after 1 minute. So remember, after you start chest compressions, you see the baby for complete 1 minute. Complete 1 minute. So if heart rate is not improving, you go for epinephrine. So let us talk about epinephrine. Let us go for epinephrine. So when do we give epinephrine? If heart rate is below 60, despite 1 minute of chest compressions. Okay, if heart rate is below 60, despite 1 minute of chest compressions, despite 1 minute of chest compressions, okay, we go for epinephrine. So 1 minute of chest compressions, 30 seconds of bag and mask, we go for epinephrine. Okay, remember this. Okay, okay. Now all of you, last year the dose of epinephrine has changed. All of you should remember, the dose of epinephrine has changed. The IV or intraosseous dose is now single, 0.2 ml per kg. IV or intraosseous dose is single, it's 0.2 ml per kg of 1 in 10,000 dilution. So it's 0.2 ml per kg of 1 in 10,000 dilution. Okay, so in your exam they can ask you, what is the dilution of epinephrine we use? It is 1 in 10,000, which is equal to 0.1 milligram per ml. 1 in 10,000, which is equal to 0.1 milligram per ml. So 0.2 ml per kg is equal to 0.02 milligram per kg. So 0.2 ml per kg is equal to 0.02 milligram per kg. Okay. Now endotracheal dose is now, it has changed. Remember, endotracheal dose has now changed. It is 5 times now. It is 5 times. 1 ml per kg. Okay. 1 ml per kg. 1 ml per kg, which is equal to 0.1 milligram per kg in 1 in 10,000 dilution. Okay, 1 ml per kg, which is equal to 0.1 milligram per kg. Okay. So remember this. Okay, please remember this. Noted, all of you? Can you please tell me noted? Then I'll go further. Noted? Have you noted? Can I take you further? Okay. So now when do we say death? When do we define death? When do we define death? So now all of you, now we say 20 minutes. Now we say 20 minutes. So if there are no signs of, life, okay, if there are no signs of life despite 20 minutes of active resuscitation, okay, 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 no signs of life despite 20 minutes of active resuscitation. Now all of you, I can see a question in the chat box. Sir, how long can we repeat epinephrine? So before I take you to death, all of you remember that you should always flush epinephrine. Always flush epinephrine with 3 ml of normal saline. Okay, always flush epinephrine with 3 ml of saline. Whatever the weight, whatever the gestation of the child, always flush epinephrine with 3 ml of normal saline. You can repeat epinephrine every 3 to 5 minutes. You can repeat epinephrine every 3 to 5 minutes. Okay. You can repeat epinephrine every 3 to 5 minutes. Okay. Repeat epinephrine. So if despite all of this, at 20 minutes, there is no sign of life, we discuss with the parents that your child, even if he survives after 20 minutes, he will be vegetative, bedridden. We declare him dead now. Okay. Now I would like to tell you 2 more things. Remember, all of you, that nowadays, there's a lot of emphasis on pulse oximetry. Remember, nowadays, there's a lot of emphasis on pulse oximetry. So I will also discuss some NEET PG questions with you. So let me ask you this NEET PG question, all of you. My question is, which limb is used for saturation monitoring in a newborn? Can anyone in the class tell me which limb is used for saturation monitoring in a newborn? Yeah, for every time epinephrine, the dose is same. 0.2 ml per kg of intravenous or intraosseous. 1 in 10,000 dilution. Which limb, anyone, is used for saturation monitoring in a newborn? So remember, we use a limb which is preductal. कौन सा limb use करना है? Preductal. So now what I'll do is I'll just stand here and I'll show you. See, this is aorta. This is aorta. This is pulmonary artery. And between aorta and the pulmonary artery is the ductus arteriosus. Now, right subclavian is the first branch of aorta. Right subclavian is the first branch of aorta. So right subclavian is always the first preductal before the ductus. So right upper limb is always preductal. So our convention is right upper limb. So remember, left is variable. Sometimes left arises before the adductors, sometimes it arises after the adductors, but right upper limb is always preductal. Okay, lower limbs are postductal. Remember, lower limbs are postductal. So yes, most of you are right. Yes, this is a convention that we always use right upper limb for saturation monitoring in a newborn. Excellent. Now all of you remember that now there are some guidelines for targets. So if you have a child who is not doing well, you are doing resuscitation. Now you have some targets. So all of you, if I ask you, what is the 3-minute target for saturation in a newborn? Anyone? Anyone? What is the 3-minute target for saturation in a newborn? So remember, now we have some targets defined, and these targets, remember, are for preductal. For right upper limb के target से, for the preductal. Okay. So for 1 minute, the target should be 60 to 65%. For 2 minutes, the target of the right upper limb is 65 to 70%. 3 minutes, 70 to 75%. 4 minutes, 75 to 80%. 5 minutes, 80 to 85%. Okay, 5 minutes, 80 to 85%. 10 minutes, 85 to 95%. Okay. Okay, noted. Noted, everyone? Please write noted so that we can go further. The faster you write, more we do. Okay, note this down. Yeah, thank you, Dr. Chaudhary. So you're right. The answer of this question, 3-minute target, was 70 to 75%. Most of you were right. Thank you. So what I'll do now is I will be talking about prematurity. I will be talking about prematurity. So all of you, if I ask you, can anyone in the class tell me what is the most common cause of neonatal mortality all over the world? Can anyone tell me what is the most common cause of neonatal mortality all over the world? This is a very common question asked in the INICT exam. Okay, what is the most common cause of under 5 mortality all over the world? Anyone? What is the most common cause of under 5 mortality all over the world? It is prematurity. So all of you, you must have seen Kaun Banega Crorepati. Amitabh Bachchan ji is back with Kaun Banega Crorepati. And in Amitabh Bachchan ji's Kaun Banega Crorepati, he always says, put them in order. Kram anusar lagaye. Okay, fastest finger first. Kram anusar lagaye. So if I ask you to put these in order. So all of you, what I'm doing is on your screen, I will be showing you this under 5 mortality. Okay. And all of you, can you see this? The biggest pie out of this is prematurity. So the most common cause of under 5 mortality all over the world is prematurity. Okay, most common cause of under 5 mortality all over the world is prematurity. Now let us, classify these children into neonates. So under 5, so this is on your screen. What is this on your screen? Under 5 mortality. Under 5. And let us classify this into neonates on my right side and 1 month to 59 months on my left side. neonates on my right side, 1 month to 59 months on my left side. So can you see, all of you? Number one, the most common cause of neonatal mortality all over the world is prematurity. Number two, intrapartum events. Number three, infections. Number four, congenital. Okay, prematurity, intrapartum events, infection, congenital. Prematurity, intrapartum events, infection, congenital. Okay, prematurity, intrapartum events, infection, congenital. Okay, prematurity, intrapartum events, infection, congenital. So answer of this question, which came in your INICT exam 1 year back, was again prematurity, intrapartum events, infection, congenital. Coming back to older children, pneumonia after 1 month of life, pneumonia is the most common cause of death. After the first month of life, let me check if I know this is a busy pie. Let me see if I can see it on my cell phone. I can see it clearly actually on my cell phone also. It's not too bad. If you just remove the chat box, you can see this nicely on the cell phone also. It is visible. Okay. So after 1 month of life, prematurity, injury, malaria. I'm sorry. So after 1 month of life, it's prematurity, diarrhea, injury, malaria. This is very important. Prematurity, diarrhea, injury, malaria. Okay, prematurity, diarrhea, injury, malaria. Okay, noted all of you? Prematurity, diarrhea, injury, malaria. Okay, noted. Can you please tell me noted? Then I'll go further. Noted. So let's talk about why do preterms die? They die because of RDS. All of you, let me know if you have noted this under 5 mortality all over the world. It's prematurity, Rishika. Overall prematurity, Dr. Rishika. Neonates, prematurity. But after the first month of life, look at the left side, Dr. Rishika. After the first month of life, it's pneumonia. Okay, after the first month of life, it's pneumonia. Okay, so this is very important trend. So all of you, what I'll do is I'll take you to prematurity over the next few minutes, and in prematurity what we'll do is we will start with RDS. So preterms die of RDS. So let us talk about RDS. You have a baby who has fast breathing, a preterm who has fast breathing, and this baby is having fast breathing. So let's talk about this baby. RDS. So I'll show you a baby who has respiratory distress. I'll show you a baby who has respiratory distress on your screen. This is grunting. Okay, so you have a baby who is having fast breathing. So let us talk about RDS, the most common cause of respiratory distress, mortality all over the world in newborns and overall under 5. Dr. Shelja, Dr. Prafulla, all over the world under 5. So on your screen are the components of surfactant. All of you should know the components of surfactant on your screen. So 50%. So remember the most important component. Okay. Okay. All over the world, saturated phosphoridylcholine. Okay. All over the world, saturated phosphoridylcholine is the most common, the most abundant component of surfactant. Okay, surfactant का most abundant component, saturated phosphoridylcholine, 50%, followed by unsaturated phosphoridylcholine. Then there are some neutral lipids, phosphoridylglycerol, and there are some minor components as well, like surfactant protein A, B, C, D. So there are some minor components as well, like surfactant protein A, B, C, D. Okay, so there are some minor components like surfactant protein A, B, C, D. Cool. Cool. Can we go further, all of you? Okay, so let us see how and when is surfactant formed. So let us see how and when is surfactant formed. So remember, surfactant is formed in the lamellar bodies of the type 2 pneumocytes. So let us talk about surfactant. Surfactant. Surfactant is formed at 20 weeks of gestation in the lamellar bodies of type 2 pneumocytes. Of type 2 pneumocytes. Okay? Type 2 pneumocytes, remember. Okay? In the canalicular stage of the lung development. In the canalicular stage of the lung development. In the canalicular stage of the lung development. Okay? In the canalicular stage of the lung development. Remember this? Now you can see surfactant in the amniotic fluid after 28 weeks of gestation. You can see it in the amniotic fluid after 28 weeks of gestation. Now remember, after 35 weeks, we get the mature levels of surfactant. So after 35 weeks, we get the mature levels of surfactant. Okay? After 35 weeks of gestation. Remember this. So which child has a risk of RDS? Let's talk about which child has a risk of RDS. It means preterms, babies who are born early. So it means babies who are less than 28 weekers, the risk of RDS is as high as 60 to 80%. So it means the babies who are less than 28 weeks, the risk of RDS is 60 to 80%. Okay? And after 37 weeks, the risk is less, it is less than 5%. Remember, RDS is rare in IUGR babies. It is rare in IUGRs because, IUGR babies are exposed to stress in utero. They have stress in utero. So whenever they have stress, cortisol is liberated. So whenever they have stress, cortisol is liberated. So, steroids help in the formation of surfactant. So RDS is rare in IUGRs. Remember, RDS is common in infants of diabetic mothers because of two reasons. Okay? 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 Because infants of diabetics are preterms. Number one, infants of diabetics are preterms. Number two, infants of diabetics have hyperinsulinism. Infants of diabetics have hyperinsulinism. Okay? Okay? Infants of diabetics have hyperinsulinism. So remember, insulin, hyperinsulinism prevents the lung surfactant development. Hyperinsulinism prevents the development of the surfactant. Okay? Okay? Okay, all of you? Hyperinsulinism prevents the lung surfactant development. Okay, so now here is a baby who is having fast breath, fast breathing, respiratory distress. So before, I even go to this, let me first talk about prevention. Can we prevent RDS? Let's talk about prevention of RDS. Can we prevent RDS? Let's talk about prevention of RDS. And we prevent RDS by एंटीनेटल स्टेरॉइड्स. सो मां को क्या देंगे हम? डेक्सा टू द मदर. So this, remember, it reduces the risk of RDS. Antenatal steroids reduces the risk of RDS. It reduces the overall neonatal mortality. In the brain, babies, preterms get periventricular white matter injury. They get periventricular white matter injury. Periventricular leukomalacia. Okay? Okay, periventricular white matter injury. Okay, so we are talking about, right from the Dr. Upadhyay, we are talking about, right from pregnancy. So सबसे पहले तो आएगा antenatal steroids. It reduces the risk of periventricular leukomalacia. It reduces the risk of intraventricular hemorrhage. IVH means intraventricular hemorrhage. Okay, remember it also reduces the risk of NEC in the preterm. Preterms get gut necrosis. This is called necrotizing enterocolitis. Necrotizing enterocolitis. Okay, so antenatal steroids are very important. They reduce the risk of necrosis of the gut also. Necrotizing enterocolitis. Okay, noted. Now after birth, now Dr. Upadhyay is in the chat box and he told you about something. Now after birth, what can we do of prevention of lung injury? So let's take you after birth. Once a baby is born, even before a baby gets any problems, even in the delivery room, if you have a baby who is at risk, who is less than 28 weeks, you put the baby on nasal CPAP, nasal continuous positive airway pressure. Nasal continuous positive airway pressure. Okay. Okay, nasal continuous positive airway pressure. This is what we do in the labor room, in the delivery room. Okay, so this is, even before a baby gets distressed. So remember, this is prophylactic CPAP. Prophylactic, even before he gets distressed. And guys, we all learned about this in COVID. हमने COVID में सब सीखा. हमने COVID में क्या सीखा? What did we learn in COVID, all of you? In COVID, all of you, we learned BiPAP. We used to put patients on CPAP, on BiPAP. So we were all told this in the newspapers that early non-invasive ventilation reduces the risk of invasive ventilation. We learned, in COVID, patients who were on ventilator, they used to die. So early non-invasive ventilation reduces the need for invasive ventilation. It reduces the need for surfactant. Okay. 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 So let me show you what we exactly do in CPAP. Basically, we put the baby on nasal prongs. Okay, nasal prongs. I'll just show you a video from the AIMS NICU. I'll just show you a video from the AIMS NICU and how we put a baby on CPAP. See.
In this video, we shall observe how a newborn is connected to a ventilator CPAP. The nasal prongs and the fixation of nasal prongs is very similar to that in bubble CPAP. However, the ventilator is set in CPAP mode with appropriate pressure and FiO2. The air and oxygen mixture at set FiO2 the air and oxygen mixture
Can you see this? This is the setting which we use. So all of you, CPAP means baby is spontaneously breathing. We are just giving you a positive nasal pressure. We are giving him a positive nasal pressure. Okay. So we start with a PEEP. What is the function of surfactant? Surfactant prevents the collapse of the alveoli. Surfactant prevents the collapse of the alveoli. So we give a PEEP, a positive pressure at the end of the expiration. So if surfactant is not there, the alveoli are collapsing at the end of expiration. So we give a PEEP, a peak end expiratory pressure of at least 5 centimeters of water. We start with oxygen of around 40% or so. We don't give more than that. Okay. So remember, in CPAP, we give a PEEP of at least 5 centimeters of water. So we said it's a peak end expiratory pressure. It's a peak end expiratory pressure. So we give a PEEP. Okay. Okay. And we give a oxygen, fraction of inspired oxygen of around 40%, and within 2 hours we will reduce and come to room air. So remember that preterms don't need oxygen. Preterms need PEEP. They need a positive end expiratory pressure. Okay. Positive end expiratory pressure. Remember this. Now remember, CPAP reduces, or I would say CPAP improves the lung compliance. It improves the functional residual capacity. It improves the lung volume. Remember, CPAP improves the lung compliance. It improves the FRC of the lung. It improves the lung volume. And CPAP also improves the ventilation perfusion mismatch. It improves the ventilation perfusion mismatch in the lung. Okay. Okay. Ventilation perfusion mismatch in the lungs. Okay. Okay. Ventilation perfusion mismatch in the lungs. Okay, all of you, cool? Chaliye, let's take you to the treatment of CPAP. Before I take you to the treatment, I would show you the typical X-ray of RDS. So all of you, let's show you a typical X-ray of this baby with RDS. Remember, on your screen, number 1, I will show you an X-ray showing ground glass appearance. So this child has ground glass appearance of the lungs, white out lungs, ground glass, white out lungs, ground glass. Okay, white out, ground glass, lungs are ground glassing. And can anyone tell me, if I show you this X-ray on your screen, can you tell me what can you see here? What are these arrows showing on your screen? Can anyone tell me what are these arrows showing? You can see the bronchi dividing here. Can you see this bronchus dividing here? So air bronchogram is a very specific X-ray appearance of RDS. Okay, remember, air bronchogram is a very specific X-ray appearance of RDS. So remember, all of you, in RDS, air bronchogram, you can see the bronchi dividing is a very specific X-ray appearance. You can have ground glass lungs, white out lungs, reticulonodular shadows, In early RDS, X-ray is normal. So remember, ऐसा भी हो सकता है, X-ray is normal. Yes, remember, in early RDS, X-ray is normal. Okay. Okay. Now remember, when do we get RDS? The onset of RDS. Remember, RDS always happens within the first 6 hours of life. This is very important. The onset of RDS. शुरू कब होता है? It always happens within the first 6 hours of life. Okay, within the first 6 hours of life. It happens. ऐसा नहीं है, the onset doesn't happen after 6 hours. If it has to happen, it happens in the first 6 hours. Okay, remember this. Let's talk about treatment of RDS according to the AIMS protocols. Let's talk about the treatment of RDS. How do we treat RDS? How do we treat RDS? So here is a preterm with fast breathing and respiratory distress, use of accessory muscles of respiration. So remember, the first step should be ideally nasal CPAP. The first and the best step should be ideally nasal CPAP, and I told you, with a PEEP of at least 5 centimeters of water, with a PEEP of at least 5 centimeters of water, FiO2 of 0.4, the fraction of inspired oxygen of 0.4. Only if he is very sick, we'll go for mechanical ventilation. Only if he is very sick, we'll go for mechanical ventilation. Now, within the first 2 hours, you should be able to wean off his oxygen. You should be able to, wean off his oxygen. He should be fine. But if you fail, you're not able to increase his oxygen. Oxygen is going 100%. He needs a lot of PEEP. Then you go to ensure, early rescue. So then you should go for ensure, which means early rescue. Okay. Okay. Ensure matlab early rescue. So remember, early rescue is always better than the late rescue. So you should try to rescue this child with surfactant administration as early as possible. Okay, all of you noted? All of you noted this? Noted? Okay, so let me ask you a question, all of you, and all of you will have to answer this. Okay, just put your fingers on the chat box and we'll ask you a question. A very important question for all of you. My question is, a 32-weeker baby is born by cesarean section. The baby is grunting. The baby is grunting. Respiratory rate is 70. What is the best and the first management? If a preterm is grunting, what is your best and the first management? Anyone? What is the best and the first management? And I'll announce the name of the first fastest finger. And Dr. Ankur is right. CPAP. So remember, nasal CPAP will be the first and the best management. Okay, cool. So let's go further and let us talk about some other. I'll just tell you some other causes of fast breathing in a baby. Let me also tell you some other causes of fast breathing in a baby. So remember, in a term baby, if you have a term baby with fast breathing, you should think about TTNB, transient tachypnea of the newborn. Transient tachypnea of the newborn. Transient tachypnea of the newborn. Okay, so what is the important risk factor for transient tachypnea of the newborn? So see, all of you, most of us were born by normal vaginal delivery, isn't it? We were born by normal vaginal delivery, most of us. Now suppose you have a term baby who is born by cesarean section. This is the most important risk factor. A term baby born by cesarean. See, all of you, see, when we are passing through the birth canal, all of you see, when we are passing through the birth canal, what happens is that, you know, all the water in our lungs is squeezed off. All the water in our lungs is squeezed off, all the secretions. Okay, all the water in our lungs is squeezed off. All the secretions are squeezed off. But in a term baby with cesarean section, these secretions are not squeezed off. Lungs are full of water. So remember, lungs are full of water. Okay, lungs are full of water. So this is the risk factor, all of you, remember. So the other name is wet lungs. So the other name is wet lungs. So there are some other risk factors also of transient tachypnea, like macrosomic babies are at risk of transient tachypnea. Then remember, if you have excessive maternal sedation, mother is not able to push well, precipitous labor, again precipitous labor, lungs are full of water, again this baby has fast breathing. Now lungs are full of water, guys, lungs are full of water. So what will you see in the X-ray? What will you see in the X-ray, all of you? So all of you, I'll show you an X-ray, typical X-ray on your screen, and you tell me what is this X-ray showing on your screen. This is the X-ray on your screen. Can you tell me what is this X-ray? What are these red arrows showing on your screen? When lung is full of water, what do you see first? When lung is full of water, what do you see first? This water gets deposited in the right horizontal fissure. So remember, a prominent horizontal fissure on the X-ray is the most specific X-ray appearance of transient tachypnea. A prominent horizontal fissure on the X-ray, okay, is the most specific X-ray appearance. Okay. Okay, of transient tachypnea, prominent horizontal fissure. Now remember, like the name, it's transient, so all the water of the lungs is absorbed. As soon as we are born, our respiratory epithelium becomes absorptive. So remember, this condition is a transient condition which resolves in 48 to 72 hours. It is tachypnea, so it is not much of a distress. It is tachypnea, it is fast breathing. Okay, so the oxygen requirement is also less than 40%. So the FiO2 is also less than 40%. So the oxygen requirement is also less than 40%. Okay? Remember this. It's a benign self-limited condition. So remember, it's a benign self-limited condition which resolves in 48 to 72 hours. Okay, let me show you some more children who can have fast breathing. Remember, meconium aspiration can have fast breathing. So remember, meconium aspiration can have fast breathing. Okay, remember, meconium aspiration can have fast breathing. And chaliye, let's show you an X-ray. Tell me, what is this X-ray showing on your screen? I'll show you an X-ray, all of you, on your screen. On your screen, this is a chest X-ray of a baby with distress. This is the left, this is the right, this is the left, this is the right. What is this X-ray showing? Anyone? What is this X-ray showing? This baby is having fast breathing. What is this X-ray showing? Can you see? Anyone? What can you see here? No one is answering? Beta newborn hai. So you can see loops of intestine in the chest. So remember 85% of the diaphragmatic hernia, this is diaphragmatic hernia, is left posterolateral Boschardellix diaphragmatic hernia. It's left posterolateral Boschardellix hernia. Okay? It's left posterolateral Boschardellix hernia. Okay? So remember, most of the times diaphragmatic hernia is on the left. So remember, when do we suspect diaphragmatic hernia? It can also cause fast breathing. Diaphragmatic hernia can also cause fast breathing. So when do we suspect diaphragmatic hernia? Okay, when do we suspect diaphragmatic hernia? When do we suspect diaphragmatic hernia? So if a baby has scaphoid abdomen, so you know abdomen is scaphoid, it is looking empty, you know, it is looking empty. So scaphoid abdomen, barrel chest, so you know the chest is, everything is, chest is full of gut, it's barrel chest. There's a medial sinus shift. So did you see in the X-ray the trachea was shifted to the right side? So could you see in the X-ray the trachea was shifted to the right side? So trachea was shifted to the right. Okay, trachea was shifted to the right. Okay, so there's a medial sinus shift to the right. Heart is pushed to the right. So it is not a real dextrocardia. Heart is also pushed to the right. It's apparent dextrocardia. And remember, if you can auscultate well, you can even feel the peristalsis on the left side of the chest. So you can even feel the peristalsis on the left side of the chest. Okay? You can even feel the peristalsis on the left side of the chest. Remember, all of you, bag and mask ventilation is absolutely contraindicated in this child. It is absolutely contraindicated because you know what will happen in bag and mask ventilation. You know your mouth, mask is above nose and mouth both. So now air goes from mouth also. Air goes from mouth also to the gut. So in bag and mask ventilation, air goes from mouth also to the gut. It further distends the gut and causes respiratory embarrassment. So remember, bag and mask is absolutely contraindicated. You should electively intubate the baby. You should electively intubate the baby. Bag and mask is absolutely contraindicated. Planned, you see this baby and straight away intubate. Don't do bag and mask here. Okay, straight away intubate the baby. Okay, chaliye, let's go. Remember, the most important implication in diaphragmatic hernia is that this baby is hypoxic. And hypoxia can ultimately cause irreversible changes in the lungs, which is called PPNP. PPHN, persistent pulmonary hypertension of the newborn. Okay. So hypoxia causes persistent pulmonary hypertension of the newborn. Persistent pulmonary hypertension of the newborn. Okay. Pulmonary hypertension means irreversible changes in the lungs. So remember, that is why you should electively intubate, so that this child does not become hypoxic. Okay. Okay, so that this child does not become hypoxic. Electively intubate. Okay, noted all of you? Noted? Have we noted all of this? Noted? Okay, so let me show you another cause of fast breathing, and all of you, you'll have to tell me the diagnosis. On your screen is an X-ray of a baby, and this baby has got fast breathing. Can anyone tell me the diagnosis? This is a baby who has got fast breathing, and this is the X-ray. Can anyone tell me the diagnosis? This baby has fast breathing. We have put a nasogastric tube here. The tube has coiled in the upper esophageal pouch. Diagnosis? Diagnosis, all of you? And I'll announce the name of the winner of the fastest finger. Whoever tells the answer first. The correct answer first. This baby has fast breathing also. Okay. So none of you is correct till now. Yes, Dr. Priyanka is right. This is tracheoesophageal fistula. So the correct answer is, this child has the most common type of tracheoesophageal fistula, which is called type C. Type C. What do I mean by type C? It means that the upper end of esophagus is blind. So you can see here, upper end of esophagus is blind, and the lower end of esophagus is joined to the trachea. Okay. And the lower end of esophagus is joined to the trachea. Okay. Okay, so why is he dribbling saliva? Because he cannot swallow saliva. He aspirates the gastric juice into his lungs. He aspirates the gastric juice into his lungs. Okay, he aspirates the gastric juice into his lungs. Okay, he aspirates, so he gets pneumonia. Now this juice comes to the mouth, and it is, he's frothing from the mouth. And I've seen these children many times in my hospital. They come frothing to our hospital, frothing and, dribbling saliva. So remember, a baby with frothing and fast breathing, you should think about tracheoesophageal fistula. Okay, so those who said esophageal atresia in the chat box, no, you're not completely right. You should have said esophageal atresia with a distal fistula. That was my answer, type C. Let's go further, all of you. Let's go further. And now I'll switch gears, and what I'll do is I will be talking about torch infections in newborns. Torch infections is very important topic, and I'll show you every exam of yours has a question on torch. So let us talk about torch for the next few minutes. Torch. Let us talk about torch infections. And let us first start with toxoplasmosis. Toxoplasmosis. Now I'll just tell you what is important, what are the catch points which will tell you how to identify this. Now remember, in toxoplasmosis, what is important is that the calcifications, they get calcifications in the brain. These calcifications are ideally in the choroid plexus, in the caudate nucleus, in the subependyma, and remember, these calcifications block the aqueduct. They block the aqueduct, and this can cause hydrocephalus. These calcifications can block the aqueduct, and these calcifications can cause hydrocephalus. So that's the crux, the most important point. It can cause hydrocephalus. So students, everyone in the class, I'll ask you a question which came in NEET PD 2020. Yes, these babies can also have chorioretinitis. These babies can also have chorioretinitis. 2020. What is specific for toxoplasmosis? Chorioretinitis, calcifications, hydrocephalus. Anyone in the class? What is specific for toxoplasmosis? Chorioretinitis, calcifications, or hydrocephalus? Chorioretinitis, calcifications, or hydrocephalus? No. Calcifications are seen in many. All of you are wrong. No. All of you in the chat box are wrong. And this is what you marked in 2020 NEET PG. Remember, hydrocephalus is classic of toxoplasmosis. Calcifications, there are many causes. I'll show you 3 causes of intracranial calcifications. So everyone in the chat box is wrong. I'm sorry to say this. So remember, all of you, if in your exam you get a CT like this, in which you can see calcifications right in the center. There is hydrocephalus. You see calcifications right in the center. So think about toxoplasmosis. You can see hydrocephalus here, calcifications in the center. Okay, so this is called toxoplasmosis. Okay, hydrocephalus is more specific for toxoplasmosis. So if in your exam you see a CT like this, calcifications right in the center, large ventricles, hydrocephalus, think about toxoplasmosis. Okay. Okay, let's go for it. So what I'll do is I'll ask you a question also, a very important question for your exam. My question to you is, a pregnant lady had no complaints, but she had some cervical lymph nodes in the pregnancy. So she had some cervical lymph nodes in her pregnancy, and her doctor gave her a drug called spiramycin. She was not compliant with this drug called spiramycin, and her baby was born with hydrocephalus and calcifications. So can anyone in the class tell me the answer of this question? Dr. Varun is right. This is toxoplasmosis. Remember, spiramycin is a drug given during pregnancy to reduce the vertical transmission of toxoplasmosis. Spiramycin is a drug given during pregnancy to reduce the vertical transmission of toxoplasmosis. What is a drug of choice for congenital toxoplasmosis? So drug of choice for congenital toxo is pyrimethamine with sulfadiazine with folinic acid. So drug of choice for congenital toxoplasmosis is, okay, pyrimethamine with sulfadiazine with folinic acid. Okay. 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 Okay, cool. Chali, let's go further. And what I'll do is I'll show you another torch infection, intrauterine torch infection. I'll show you another intrauterine torch infection, and all of you, here is a CT scan on your screen. Can anyone tell me what is the CT scan showing? Here is a CT scan on your screen. Tell me what is the CT scan showing? You can see some calcifications here. Can anyone tell me where can you see the calcifications here? These are periventricular calcifications which are seen in CMV. So these are periventricular calcifications which are seen in CMV, periventricular. And along with this, you can see atrophy of the brain. There is atrophy of the brain. So this is not hydrocephalus, everyone in the class. This is not hydrocephalus. The brain is thinned out. So it is looking like hydrocephalus, but it is not. There is atrophy of the brain. So remember here, there is atrophy of the brain. Okay, there is atrophy of the brain here. So let us talk about CMV now. Let me write to you for CMV now. So remember, all of you, please remember, in your exam you can have CT scan in two ways. You can have CT scan in two ways. Number one, I showed you toxo. On your right here, what you can see is periventricular calcification. So remember, in CMV the calcifications are periventricular, ventricles ke aaspas. So in CMV these calcifications are periventricular, ventricles ke aaspas. Okay, so in your exam you can have these two kind of CT scans. There is a difference which you should be able to appreciate. Okay. So let's talk about CMV. So we told you what is specific for CMV is, number one, that the calcifications are periventricular. They are periventricular calcifications, ventricles ke aaspas. They can cause seizures. Now it leads to cortical atrophy. This is important. So there is atrophy of the brain. So actually the head is small here. So actually the head is small here, microcephaly. Okay, actually the head is small here. There is microcephaly here. Okay, very important. And please remember, okay, but please remember, and the most important point, CMV, okay, is the most common cause of non-syndromic sensory neural hearing loss. So remember, CMV is the most common cause of non-syndromic sensory neural hearing loss? This question came in INICT exam also 3 weeks back. Okay. Okay. Most common non-syndromic sensory neural hearing loss. Remember, 90% of CMV is asymptomatic. So symptoms are only seen in 10%. And remember, deafness is seen in mostly symptom wala CMV. 30 to 40% of symptomatic CMV. 30 to 40% of symptomatic CMV have deafness. So remember, CMV, 30 to 40% of symptomatic CMV have deafness. This is very important. Now, if I ask you, if I ask you, CMV is a problem of what? It is a problem of what? India or America? Anyone in the class? CMV is a problem of what? India or America? Anyone in the class? India or America? It is a problem of America, because in America females get primary infection in the pregnancy. Okay. 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 So remember that transmission, so it is a problem of America. So remember, transmission of CMV is more in primary infection. Okay. It is more in primary infection during pregnancy. Rather than in India, you know, we are all exposed to CMV, rather than in India where we get reactivation. Okay. 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 Where you get reactivation. So transmission is more in primary infection. Okay. So this is a question which came in INICT exam. So if mothers whose IgG is positive, if mother her IgG is positive, okay, they transmit less. Remember, the drug of choice for CMV is intravenous ganciclovir. Okay. Remember, intravenous ganciclovir is the drug of choice for CMV. Remember this. Okay, remember this. Okay, intravenous ganciclovir. Chaliye, let's go further. And since we are talking about calcifications in the brain and children who have torch infections, who have calcifications in the brain, let me show you another child. Okay, just give me 1 minute to open a slide. And I'll show you a child who, one more torch infection which can have calcifications is Zika virus. So remember, one more torch infection which can have calcifications is Zika. Okay. Let's talk about Zika. Let's talk about Zika virus. So first of all of you should know that in your all exams, they always show you a infection, a life cycle of. So in fact, in NEET PG in 2 years back, they showed a life cycle. And what was the life cycle? Okay, there was a pregnant lady. She had a mosquito on her shoulder. Now, many students said, sir, oh, sir, we did not even notice the mosquito. So actually there was a mosquito. Remember Zika virus, the vector is a mosquito, Aedes. Aedes aegypti in the tropical areas. Aedes aegypti in the tropical areas. And albopictus in the temperate areas. And albopictus in the temperate areas. Okay, Aedes aegypti in the tropical. Okay. 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 Remember, and then remember this virus infects the placental half-boiled cells. Okay, and then it affects the baby's brain. Then it affects the baby's brain, and there is a brain who is completely atrophied brain, atrophy of the brain. Okay. 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 Okay, all of you remember this. So Zika is very important. Remember, what is Zika? All of you should know. Zika virus. Remember, Zika is a single-stranded flavivirus. Okay, so please remember, all of you, Zika is a single-stranded mRNA flavivirus. Okay, and the only main problem, all of us can have Zika. It just looks like dengue. There is no problem at all. It just looks like dengue. But if it affects a pregnant lady, the baby can have generalized brain loss, ventricomegaly. Okay, single-stranded RNA flavivirus. Okay. Okay. Generalized brain loss. Okay. Ventricles. So ventricles are looking large. Now remember, even Zika can have calcifications. Calcifications in the basal ganglia, juxtacortical areas. Okay. Calcifications in the basal ganglia, juxtacortical areas. Okay. Okay. Calcifications in the basal ganglia, and can you see here in the juxtacortical areas? So around the cortex, in the juxtacortical areas, you can see calcifications. Now in the eye, Zika can cause pigmentary retinal mottling and chorioretinal atrophy. So again, in the eye also it can cause chorioretinal involvement, chorioretinal atrophy. Okay, students, please note this down. Okay, noted all of you? So I am discussing Zika here because here we are also talking about calcifications in the brain. Noted? All of you? Can you please type in the chat box, noted, so that we can go further? Okay, so we are talking about torch infections in this session. So we started with toxoplasma, we talked about CMV. Let us take you to R now. Congenital rubella infection. Congenital rubella. Remember in rubella, remember number one point which you should know is that rubella is usually a triad of sensory neural hearing loss, microcephaly mental retardation, and PDA. Okay, so remember it is a triad of sensory neural hearing loss. Okay, okay, some people say it's also a triad of deafness, PDA, and cataract. Mostly this is the most common triad: deafness, PDA, cataract. Okay, remember this. So in the heart, PDA is the most common manifestation of rubella, and in the eye, salt and pepper fundus. In the eye, salt and pepper fundus. Okay, so in the eye, salt and pepper fundus is the most common eye manifestation. So all of you, I am a pediatrician, and as pediatricians, we all get emotionally involved with our patients, and I also click pictures. I know some of you are clicking pictures here. This is one of my patient of congenital rubella syndrome, and these are my hands. So I used to take my digital camera with me, and in my PG days, and I clicked this picture. So in fact, I was so emotionally involved with this child and his mother that she asked me that why don't you go to the OT for my child's eye surgery. So for this child, I remember the name of the mother of this child also, and for this child I went to the ophtho OT also for the eye surgery. I just chatted with the anesthetist, that's it. Okay, okay, so let's come back to rubella. In rubella, cataract, glaucoma, microphthalmia in the eye, glaucoma, microphthalmia in the eye. In heart, PDA, peripheral pulmonary stenosis. So remember, this stenosis is peripheral. Peripheral branches of the pulmonary artery are stenosed. So it's peripheral pulmonary stenosis, ventricular septal defect. Okay. Okay. Remember this. So we have done rubella. So we talked about T, R, C, H. So let me talk about H. So in a newborn, which herpes will be more common, all of you? HSV1, involves the brain. HSV2 involves the genitalia. So in a newborn, which herpes will be more common? Anyone in the class? HSV1 or 2? Two, you're right. So remember, you're right, Dr. Varun, that HSV2 is more common in a newborn. So let us talk about herpes in a newborn. Let's talk about neonatal herpes in a newborn. So all of you remember, I told you that mostly, torch infections are, they are mostly symptomatic. But remember, herpes is never asymptomatic. We said mostly torch infections में symptom नहीं होते. They are asymptomatic. But herpes is never asymptomatic. Classically occurs at 5 to 11 days of life. Okay? Classically occurs at 5 to 11 days of life. 5 to 11 days of life. Okay? So this is classic, and all of you, this is a very common question of your NEET PG, that a patient has pustules or vesicles, especially vesicles over the medial canthi. Can you see these vesicles? So a baby has vesicles around the medial canthi. Okay, so these vesicles are classic of herpes. This is the classic time of herpes, 5 to 11 days of life. A baby comes to you with 5 to 11 days of life with pustulo-vesicular lesions. With pustulo-vesicular lesions. 75% of herpes have pustulo-vesicular lesions. So इसका मतलब 100% don't have vesicles. Okay? Okay, so remember, it means 100% don't have vesicles. Okay, 100% don't have vesicles. Remember this. Okay, so vesicles are seen in 75%, not all. Okay, remember this. They may have encephalitis, bleeding from everywhere. So remember, these children can have encephalitis, bleeding from everywhere. They may have thrombocytopenia, bleeding from everywhere. The liver SGOT PT may be high in this 7-day-old baby. In this 7-day-old baby, SGOT PT may be high in this 7-day-old baby. So why are we talking about herpes is treatable? Acyclovir is the drug of choice. Intravenous acyclovir is the drug of choice. So remember, herpes is treatable. We can treat this by giving intravenous acyclovir. Remember this. Okay. Okay, noted all of you? Noted? Noted? Can I take you to the next torch infection? Noted? Okay, cool. So all of you, let me show you the last torch infection of the day. And let's show you the last torch infection of the day. और आपको बताना है, all of you have to tell the diagnosis. So all of you, a baby was born in our hospital, and this is the photograph of a baby. Maybe I'll show you in a different way. So a baby was born in our hospital. This baby was born with a scarring rash. This baby was born with a scarring rash and has this hypoplastic limb. One leg, one arm is not well formed, has a hypoplastic limb. Diagnosis. His mother was suffering from which torch infection? His mother was suffering from which torch infection? Anyone? His mother had which torch infection during pregnancy that a baby got a scarring cicatricial rash and hypoplastic limbs? Lovely. And Dr. Coyle, good to see you. First in the fastest finger first. Yes, you're right. Chickenpox. Mother had chickenpox. So the last torch infection of the day, which we'll be talking about, is called varicella embryopathy. It's called varicella embryopathy. Now, all of us usually think that, the torch infections are more problematic in the first trimester, but the teratogenicity of chickenpox is maximum at 13 to 20 weeks. So, teratogenicity of chickenpox is maximum at 13 to 20 weeks. In the eye, varicella can cause optic atrophy, hypoplasia of the optic nerve, optic atrophy, hypoplasia of the optic nerve. Okay. Lumbosacral plexus, limb aplasia or hypoplasia. Limb aplasia or hypoplasia. A cicatricial skin rash. And in the brain, again cortical atrophy. So in the brain, again there is cortical atrophy. Okay. In the brain, again there is cortical atrophy like CMV. Also in varicella, there is cortical atrophy. Okay, cool. All of you noted? Noted, all of you? Noted? Okay, so all of you, I'll just ask you one more question. Today, a baby is born in your hospital and mother has chickenpox. What will you do? Now, baby can have chickenpox from the mother. Mother has chickenpox during delivery. So what will you do? So remember, if mother has got chickenpox at this specific time frame, this is a very specific time frame, 5 days before to 2 days after. If mother has got chickenpox in this specific time frame, 5 days before to 2 days after delivery, we give a very specific immunoglobulin to the baby called varicella zoster. So we give a very specific immunoglobulin to the baby called varicella zoster immunoglobulin to the baby to prevent chickenpox like illness. Okay, so to prevent chickenpox like illness, we give very specific immunoglobulin to the baby. Okay, varicella zoster immunoglobulin, so that baby does not get chickenpox. Okay, Noted, all of you? Can I take you to the next topic of the day? 5 days before to 2 days after. So remember this time interval, these 7 days. Okay. So all of you, those who joined late in the class today, see, this is our plan of the day. Our plan of the day is this. We talked about neonatology in the initial half, and now all of you, I will take you to COVID-19 first. I'll take you to COVID-19 first in children. So let's talk about COVID-19. So all of you, before I talk about COVID-19, I would like to talk to you about hand washing. Hand washing is very important. Okay, so all of us learned about hand washing, and even your examiners want to ask you about hand washing. So let us talk about hand washing. So can anyone tell me what are the steps of hand washing? Let us talk about what are the steps of hand washing. So all of you, when you'll get a PG, you'll earn lot of money. I'm joking. So guys, you're not doing PG to earn money. If you wanted money, you could have started a business, way back. We all are sitting here in the class today because maybe we want to earn money from our passion. Like I'm a pediatrician, and that's my passion. I like to see children. Okay, so I want to earn money through this medium. Okay, I don't want to open a shop to earn money. So okay, so when you earn money, you submit income tax, and you submit income tax return in a PDF format. So these are the steps of hand washing: palm to palm, dorsum of palms, interlocking of fingers, interlocking of knuckles. So interlocking of knuckles. Then T stands for thumb. By rotational rubbing, you clean your thumb. And lastly, by rotational rubbing, tip of fingers. I'll again repeat it for you. Palm to palm, dorsum of palms, interlocking of fingers, interlocking of the knuckles, rotational rubbing thumb, rotational rubbing tip of fingers, and then you can clean your arm also. So all of you, this is on my, in my clinic. This is the poster on my clinic, and this is what I do every day of my life. So remember, for hand washing, this is what you have to do: PDF ITR. Noted? So let's talk about COVID-19. Let's talk about COVID-19. So all of you, what happened in COVID is basically, when adults get COVID, children in fact get COVID after adults get COVID. So children do not get acute lung COVID. Pulmonary COVID is very rare in children. Okay. So in fact, in children, the peak, suppose this is the adult peak. So suppose this yellow is the adult peak. Suppose this yellow is the adult peak. Now when the adult peak goes away, the children peak happens. So this is what we saw in COVID. We saw a lot of Kawasaki-like illness in children in COVID-19. And we call it as MIS-C. MIS-C, multisystemic inflammatory syndrome in children with COVID. Multisystemic inflammatory syndrome in children with COVID. So it is like a delayed cytokine response. So in my life, in my last 2 years of my life, I saw many children dying because of multisystemic inflammatory syndrome in children with COVID. So there is a guideline for this. So all of you should know, how do we define multisystemic inflammatory syndrome in children with COVID, and how do we treat that? And how do we treat that? So let us talk about this. Let us talk about this. So remember, according to the WHO, we define MIS-C as a child less than 19 years with fever 3 days or more. A child less than 19 years with fever 3 days or more. Okay, this is the definition: child less than 19 years with fever 3 days or more. And Remember, and any two of the following. It's multi-systemic, so two systems should be involved. Okay, two systems should be involved. A rash or bilateral conjunctivitis. So it was looking like Kawasaki disease. We saw many children like this. Two systems. Okay, by the way, I'll speak about this in the DVT also. I'll see you in DVT also this week. If any, are you coming to DVT, guys? So rash or bilateral conjunctivitis. So two systems, hypotension or shock, features of heart involvement, myocardial, pericardium, valvulitis, or elevated troponin. Pro-BNP is also a marker of cardiac stress. So involvement of the heart, features of coagulopathy or GI involvement. Okay. 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 ठीक है, written. Two systems should be involved. So I said rash, hypotension or shock, features of cardiac involvement, coagulopathy, acute GI problems. So diarrhea, in fact, was the most common presentation of Missy. Okay. Okay, noted. All of you, please tell me when you note this. Okay, noted. Okay, so you have a patient like this, and all of you, there is elevated acute phase reactants, ESR, CRP, procalcitonin. Okay, ESR, CRP, procalcitonin. Okay, and there is no evidence of infection, and there is evidence of COVID-19. Okay. Okay, and elevated ESR, elevated acute phase reactants. There's no evidence of infection, and there is evidence of COVID-19. Okay. Okay. Noted? Noted, all of you? So this is the definition of multisystemic inflammatory syndrome in children with COVID. Noted, everyone? So let us talk about how do we treat Missy. So, COVID came suddenly and we had learned all about Kawasaki disease. So we saw a lot of Kawasaki-like illness all over the world. So we treated it just like Kawasaki. Okay, so remember misuse of three types: mild, Kawasaki disease phenotype, shock or MODS. Okay, so misuse of three types: mild, Kawasaki like phenotype, shock or MODS. Okay, so it is of three types: mild, Kawasaki phenotype, shock or MODS. So in mild MISI, we give low dose steroids. So in mild MISI, we give low dose steroids like IV methylprednisolone 1 to 2 milligram per kg per day for 3 to 5 days. Okay, so remember, it's a mild MISI. We give low dose steroids 1 to 2 milligram per kg per day for 3 to 5 days. Okay. Okay. Now, if you have a Kawasaki like picture, so remember, so someone in the class today just now told ki sir IVIG dete hai. So I said Dr. Nazir is asking a question. So see, for mild MISI we give low dose steroids. Okay, so I treated many patients in the clinic only by giving low dose steroids. But if they had a Kawasaki like illness, we give IVIG. So remember, in multisystemic inflammatory syndrome in children with COVID, if they look like Kawasaki, they have a rash, okay, lymph node. Why am I talking about all of this? Because these children can have coronary aneurysms. Because these children can have coronary artery aneurysms. So we are giving IVIG to prevent coronary aneurysms. Okay, 2 gram per kg is the dose, along with low dose steroids. Okay, Dr. Nazir. So if there is a Kawasaki disease like phenotype, we give IVIG 2 grams per kg with low dose steroids. Okay, noted. Definition, Dr. Nazir, I said it's a child less than 19 year, fever 3 days or more, and 2 system involvement. And there is elevation of acute phase reactants and evidence of COVID, and there is no infection. तो यही है सारी बातें. Age less than 19, fever 3 days or more, 2 system involvement, and there is elevated acute phase reactants like ESR, CRP, procalcitonin, and there is COVID-19, and there is no other cause for it. Now, if a child comes in shock or MODS, so if you have a multisystemic inflammatory syndrome who comes with shock or MODS, then of course you will give high dose steroids. So yes, the drug of choice for high dose multisystemic inflammatory syndrome is high dose steroids, 10 to 30 milligram per kg per day for 3 to 5 days. Okay, for 3 to 5 days with IVIG. Okay, so we give high dose steroids for severe MISI with IVIG. Okay, with IVIG. Okay. Okay. Noted? Okay, noted all of you. So we talked about COVID-19, all of you. So let me tell you my plan of the day again, all of you. My plan of the day is that I will talk about COVID, and then what I'll do now is I will talk about some important points about diarrhea and malnutrition. So let us talk about diarrhea and malnutrition for the first this part of the class. So let's talk about diarrhea and malnutrition. So let us talk about diarrhea first. So remember in your exam, and I can tell you this is the pattern of your exam, they will always ask you about how to assess dehydration. What is the most common cause of diarrhea in children? Rotavirus. The most common cause of diarrhea in toddlers is rotavirus. Most common cause of diarrhea in toddlers is rotavirus. Okay, rotavirus. So what they'll do in your exam, you know, even in the last NEET PG also, there was a question on how to assess dehydration. How to assess dehydration in the last NEET PG also. So you look at the child. Let me see if I can put it on the screen here. Yeah. So you look at the child. Feel the skin pinch and decide. So according to WHO, let us talk about how do we classify dehydration. Let us talk about, according to WHO, how do we classify, okay, dehydration according to WHO. It is classified into no, some, or severe. Okay, no, some, severe. Okay, no, some, severe. So look at the child, all of you. So if this child is completely well alert, his hydration is normal, he's not thirsty, he's drinking water normally, turgor goes back quickly, this is no dehydration, for which we give plan A. So this is called no dehydration, for which we have plan A. Now in your NEET PG 22 guys, NEET PG 22, they asked about a child who was irritable, sunken, thirsty. He drinks water eagerly. So he's very thirsty. He drinks water eagerly. Okay. So what is plan A first of all? Plan A is ORT, oral rehydration therapy. So basically we give him more home-based fluids, ORS replacement. Now this question came in NEET PG 22. A child is restless, irritable, he is thirsty, turgor goes back slowly. So if there are any two of these signs, we go for plan B. If there are two or more signs like above, we go for plan B. What is plan B? So in your exam, you know, they may ask you what is your next step. So plan B is to give ORS 75 ml per kg over 4 hours. So plan B is to give ORS 75 ml per kg over the next 4 hours. Okay, so we give ORS 75 ml per kg over the next 4 hours. Okay. Now, what is plan C? So plan C matlab this child is in severe dehydration. He is completely comatose. So now we go for plan C. So if there are two or more above signs, we go for plan C. which means giving intravenous ringer lactate 100 ml per kg, which is intravenous ringer lactate 100 ml per kg. Okay, giving intravenous ringer lactate 100 ml per kg. Okay, noted? Intravenous ringer lactate 100 ml per kg. Okay, noted? Can I go further, all of you? How do we give ringer lactate? Noted? Can you please write noted in the chat box? So plan C is intravenous ringer lactate for severe dehydration urgently. So this is how we classify dehydration according to WHO. Okay, thank you, Dr. Coyle, for telling. You have noted. So how do we give intravenous ringer lactate in severe dehydration? So remember, if you have a child who is an older child, so for an older child, you can give it faster. So for an older child, you can give ringer lactate faster. So it's total 100. So initially you give 30, then you give 70. So it's total 100. Initially you give 30, then you give 70. So in a child more than 1 year, you can give 30 over half an hour and the rest 70 ml per kg over the next 2.5 hours. So in an older child, you can give it faster. In a smaller child, you give it slowly. 30 ml per kg over 1 hour and the rest over 5 hours. Okay? Noted? So let us talk about what is the composition of ORS. So students, our passion and for pediatricians, our passion is basically ORS, zinc. So this is what we'll ask you in your exam. So all of you would in fact, you cannot pass without telling the examiners what is the composition of ORS. So on your screen, I bring you here the composition of ORS. So on your screen, I'll try to bring it in the let me see if I can bring it nicely. Just trying my best to put it here. Just give me 1 second. Yeah, here it is. So on your screen is 3 different types of ORS. On your left is the old ORS, Purane Zamane ka ORS. Then we have Resomal, it's rehydration solution for malnourished children. And now we have all of you the new ORS all over the world, which is the universal ORS, which is for everyone, for children, for adults. We have a universal ORS for everyone in the world. Children, adults, viral, bacterial, for everyone. We have the same ORS for everyone. Okay. So we have same ORS for everyone. Okay, so remember 50 years back in our country we had cholera. Cholera had huge sodium losses. So the old ORS was based on cholera stools, lot of sodium losses. So that's why we had the old ORS. But now all of you, we have a new ORS, 75 of sodium, 75 of glucose, total osmolarity of 245. So remember 75 of sodium, 75 of glucose, total osmolarity of 245. Okay. 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 Cool. Now remember in malnourished children, you should know, in malnourished children, the total body sodium is high and the total body potassium is low. Okay, in malnourished children, the total body sodium is high and the total body potassium is low. So in Resomal, we give them half the sodium, double the potassium. Okay. 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 We give them more glucose, more magnesium, zinc and copper. Okay. Okay, all of you. Let me see. Okay, noted. So remember, in malnourished children, we give Resomal. Now all of you should know what is the composition of the low osmolarity ORS. Let us talk about what is there in this packet of low osmolarity ORS. 2.6 grams of sodium chloride, 1.5 grams of potassium chloride, and this large organic compound is trisodium citrate. There are 3 sodium and this is citrate, trisodium citrate. Okay. Glucose is 13.5 grams. So total ORS packet, remember, is 20.5 grams. This is what you need to know. Total ORS packet is 20.5 grams. Okay. Total ORS packet is 20.5 grams. So remember, sodium chloride is 2.6 grams, potassium chloride is 1.5 grams, citrate is 2.9 grams, glucose is 13.5 grams. Total ORS packet is 20.5 grams. Okay. Okay, all of you noted? Can you please write noted in the chat box? So remember, 2.6 grams of sodium chloride, 1.5 grams of potassium chloride, 2.9 grams of trisodium citrate, 13.5 grams of glucose, and the total packet is 20.5 grams. So all of you remember, as pediatricians, our passion in addition to this is also zinc. So, we told the world that zinc should be given in acute diarrhea also. Okay, zinc is now endorsed by WHO also. So this was told by India to the world. Okay, this was told by India to the world. ठीक है, चलिए. So in fact, all of you, I'll tell you about myself. My name is Siddharth Sethi, and I take lectures for pediatrics and pediatric nephrology, multiple countries, and in fact, in around India. And few years back, I was taking a round in Egypt for pediatricians of Cairo, and I was taking a round, and I told them, why don't you give zinc in your patients in diarrhea? They all laughed at me. There were so many pediatricians, everyone laughed. They said, what are you talking, doctor from India, telling us about zinc? Then maybe, doctor from India, maybe you should also give cabbage in diarrhea. Now the same year, WHO endorsed that we should give zinc in diarrhea also. So I emailed them back, guys, I told you, zinc has to be given in diarrhea, and you are not giving it. So yeah, they never emailed me back. So that was the last time they invited me to their country. So, but now we know that zinc is our passion. Zinc reduces the overall severity of diarrhea. Zinc reduces the overall duration of diarrhea. Zinc improves the outcome. It improves the outcome of diarrhea. So remember, we have to give the zinc twice the recommended daily allowance for 2 weeks. Twice the recommended daily allowance for 2 weeks. So remember, the dose of zinc for children more than 6 months is 20 milligrams per day for 2 weeks. 20 milligram per kg for 2 weeks. So first studies, came for children more than 6 months. So these were the initial studies which came for children more than 6 months. Then studies came for children less than 6 months, and the dose is 10 milligram per day. Okay. Okay. For a period of 2 weeks. ठीक है जी? Cool. Noted, all of you? Noted? Can anyone say noted in the chat box, guys? इतना सन्नाटा क्यों है? हाँ? Dr. Nazir, Dr. Shelja, Dr. Pawan, Dr. Samiksha, Dr. Aarti, Dr. Nazir, Dr. Koyal, Varun, Sujit, Kao, Pankaj. Ankur, yeah. So let us now take you to malnutrition. Now remember, for your exams, malnutrition is very important, especially the severe malnutrition. So remember, let us talk about how do we classify malnutrition. What are the criteria we use for classification of malnutrition, which is very important. So remember, we are all pediatricians of India, and we are all members of Indian Academy of Pediatrics. So we are all members of Indian Academy of Pediatrics. So we use weight for age as the criteria in our country. Indian Academy of Pediatrics, we use weight for age as a criteria in our country. Weight for age. Okay, it's weight for age. Okay, so remember, normal weight for age is more than 80% of the reference standard. Okay, more than 80% of the reference standard. So what is PEM grade 1? (71 to 80% of the reference standard). PM grade 2 is 61 to 70% of the reference standard. Grade 3 is 51 to 60% of the reference standard, and grade 4 is less than or equal to 50%. Okay. Grade 4 is less than or equal to 50%. Remember this. Now, if there is edema, you add a suffix K, because remember, edema is a bad marker for mortality. So if there is edema, you add a suffix K. Okay. So if there is edema, you add a suffix K. Okay. Now, when I took all of your names, you all wrote in the chat box. Okay. So whenever I'll ask a question, I'll name you all. Okay. Now let us talk about how do we classify malnutrition according to WHO. So that is the most important classification you need to know according to WHO. So remember, WHO classifies malnutrition into two. But before that, WHO says that you should classify malnutrition into children who are underweight. And what is underweight? It is weight for age less than -2 SD. Underweight is weight for age less than -2 SD. So WHO classifies malnutrition into moderate or severe. Moderate or severe malnutrition. Based on three criteria. First criteria is height for age. What should be your height normally? It should be more than 90% of the reference standard. So normally your height should be more than 90% of the reference standard. Okay. So what does your height tell you about? Your height tells about your chronic problem. If your height is less, it means it's chronic stunting. So remember, height tells you about chronic malnutrition, which is also called stunting. So 86 to 89% is moderate stunting, which is also called between -2 to -3 SD. Less than 85% or less than -3 SD is severe stunting. Okay. Now the second criteria is weight for height. Weight for height. Now what is weight for height? What is weight for height? So suppose a child is 100 centimeters tall and his weight is 12 kg. He got a diarrhea. So from 12 kg, the weight became 10. Height is same 100 centimeters. So weight for height tells about acute problem. Okay. So normally the weight for height should be more than 80% of the reference standard. It tells about acute problem, which is also called wasting. It tells about acute problem, which is also called wasting. 71 to 79% is moderate wasting. Less than or equal to 70% is severe wasting, which can also be called as between -2 to -3 SD is moderate wasting, and less than -3 SD is severe wasting. And the last criteria is symmetrical edema, and remember, edema is always severe. So last criteria is symmetrical edema. Remember, edema is always severe malnutrition. Okay, edema is always severe. Remember this. Okay, edema is always severe malnutrition. Okay, noted? All of you, can you please write in the chat box that have you noted? So what we'll concentrate on is this. SAM. This is our topic which is very important for your exam. It's called SAM. Severe acute malnutrition. SAM is severe acute malnutrition. Okay. SAM is severe acute malnutrition. Okay. Severe acute. Okay. So all of you should know what is SAM. This is the crux of our class right now, is that you should know what is SAM. So remember, according to WHO and UNICEF, SAM is classified in two age groups. So remember, according to WHO and UNICEF, SAM is classified in two age groups. 6 to 59 months and less than 6 months. Okay. Okay. Six to 59 months and less than 6 months. Okay. As any of the following criteria, and all of you, you have to remember this. Weight for height. All of you, I want you to write in the chat box. SAM is equal to weight for height below -3 SD. This is a very important question. Please write in the chat box. SAM is weight for height below -3 SD. So, as any of the following three criteria, 6 to 59 months, weight for height below -3 SD, or bilateral edema, or mid-arm circumference below 11.5 centimeters, or mid-arm circumference below 11.5 centimeters. Okay. Now in children below 6 months, we cannot use mid-arm circumference. In children below 6 months, we cannot use mid-arm circumference. So we use criteria number 1 or 2. So remember, in children below 6 months, we cannot take mid-arm circumference. So we take criteria number 1 or 2. Thank you all of you for writing this in the chat box. Thank you. This will come in your exam, I can tell you. Noted? Noted? Okay. So what I'll do is I'll do a quiz with all of you. I will do a quiz and all of you have to tell me the answer. Okay. So please be fast. Okay. I don't want you to be slow in this one. I'll ask you a quiz. And the quiz goes like this. What is SAM? Everyone in the class, type in the chat box. What is SAM? Okay, all of you have already told. Someone just messaged. It's weight for height less than minus 3 SD. Okay, which is a marker for acute malnutrition? Anyone in the class? Which of the following is a marker for acute malnutrition? What is a marker for acute malnutrition? What is a marker for acute malnutrition? Weight for height. You are completely right, Dr. Ashutosh. Okay, what is a marker for chronic malnutrition? The question for you, what is a marker for chronic malnutrition? What is a marker for chronic malnutrition, which is also called stunting? For chronic malnutrition, the marker is your height. You're right, Dr. Ashutosh. Now, which is a marker for both? So remember, weight for age. Weight for age is a marker for both. Remember, weight for age is a marker for both. So if I ask you, what is underweight? If I ask you, what is underweight? It is weight for age less than minus 2 SD. So remember, weight for age less than minus 2 SD is underweight. So please remember this. Okay, cool. So what we'll do, everyone in the class, is that maybe I'll give you a 10-minute break, and remember, lunch break is from 2 o'clock, but I'll just give you a 10-minute break so that you can just refresh yourself, wash your face, come back, and then we'll start genetics. So all of you, my name is Siddharth Sethi, but let me first tell you that what is our plan. Our plan of the day is this. We'll go on till 9 o'clock. So after the break of 10 minutes, we will be talking about genetics. We'll start about genetics. It is a very important topic. We'll talk about genetics after the break. All of you, don't think that this is just the only class. I'm with you all the time. If you want to ask me any questions, you can ask me on any of these social media platforms. Okay, so I'll see you in 10 minutes. Let's start, guys. And what we'll do in this session is we will be talking about genetics. So remember, in your exam, you will definitely get a question on genetics. And I can tell you, in the last NEET PG, in fact, all of you, there were a lot of questions on genetics. So in this session, we will be talking about genetics and milestones. So let us show you a pedigree. I'll be showing you a lot of pedigrees, the Mendelian and the non-Mendelian. So on your screen, maybe I'll just adjust this for a while on my screen. Just give me 1 minute. So can anyone tell me What is this pedigree showing? So all of you here in the pedigree, affected parents, affected children, all generations are affected. So all of you, if all generations are affected, is this dominant or recessive? Anyone in the class? If all generations are affected, is this dominant or recessive? Anyone? Is it dominant or recessive? Dominant. So remember, if all generations are affected, it is dominant. Okay. So if you ever see a pedigree in which all the generations are affected, it is dominant. Now my question to you is only male affected or female affected? Who is affected here? Only male or female? Both. If both males and females are affected, it is autosomal. So all of you, the first pedigree of the day, autosomal dominant, all generations are affected, males and females are affected equally. So all of you should know, I'm sorry, I'll just adjust this for a while. Just give me 1 minute. Actually, I need to adjust this for your screen. Sorry, it happens sometimes. Yeah. So what are the examples? So remember, the mnemonic of autosomal dominant is dominant. The mnemonic of autosomal dominant is dominant VH3. Dominant VH3. Okay. D stands for myotonic dystrophy, is autosomal dominant. Myotonic dystrophy is autosomal dominant. O stands for osteogenesis imperfecta. O stands for osteogenesis imperfecta. M is Marfan. So this question came in NEET PG 2019. So I'll just keep on telling you which question came when. So NEET PG 2019, Marfan's is autosomal dominant. Intermittent porphyria is autosomal dominant. Noonan syndrome. Noonan, it is a child who looks like Turner syndrome and the karyotype is normal. So Noonan's is a child who looks like Turner syndrome and the karyotype is normal. Adult onset polycystic kidney disease. So adult onset PKD, adult onset polycystic kidney disease. Achondroplasia is autosomal dominant. Neurofibromatosis is autosomal dominant. Tuberous sclerosis. And please add another T here, which came in your NEET PG this year. Treacher-Collins syndrome is autosomal dominant. Treacher-Collins is autosomal dominant. VH3. V stands for von Willebrand disease. V stands for von Willebrand disease. And 3H. Huntington's chorea. Hypercholesterolemia. And hereditary spherocytosis. Okay. Von Willebrand disease and 3H, Huntington's chorea, hypercholesterolemia and hereditary spherocytosis are autosomal dominant. Noted, guys? Noted? Noted? Sorry, I just need to remove this. Yeah, noted. So remember that somehow I can bet on this that every NEET PG has a question from this table. So what I'll do is I'll show you a question from the NEET PG. I'll just open my NEET PG 22 folder. And my question for you is, this. NEET PG 22. Which of the following is autosomal recessive? Anyone in the class? Which of the following is autosomal recessive? NEET PG 22. So rest are autosomal dominant. And Dr. Pavan was the first one to answer. Yes, all these three are autosomal dominant. Sorry. Only cystic fibrosis is autosomal recessive out of these three, out of these four. Okay. Cystic fibrosis is autosomal recessive. Rest are autosomal dominant. Everyone in the class is right. Okay. So every year you get a question something like this. So let's take you to the next pedigree of the day, friends. And I'll present to you the next pedigree of the day. On your screen, all of you, now the parents are carriers. All of you, on your screen, now the parents are carriers. Okay. Now the parents are carriers. So is this recessive or dominant? If I say parents are carriers, is this recessive or dominant? Recessive. So parents are carriers. So this is recessive. Now who is a carrier here on your screen, all of you in the class? Who is a carrier here on your screen? Male is a carrier or female? You know, half black male, half black female. So who is a carrier here, male or female? Anyone in the class? Who is a carrier here on the screen? Male or female? Both. Both males and females are carriers. So there is no sex preference. It is autosomal. If there is no sex preference, it is autosomal. Okay. So I can even make it like this, that these are actually, this couple is actually consanguineous. They were actually like this. If you look at this male, his maternal grandparents, and if you look at this female, her paternal grandparents are the same. So, you know, this couples, iske nana nani, uske dada dadi are the same. So maternal grandparents of the husband and paternal grandparents of the wife are the same. So remember, consanguinity, consanguineous marriages precipitate autosomal recessive traits. Consanguineous marriages precipitate autosomal recessive traits. Okay, remember this. So what are the examples of autosomal recessive inheritance? Remember, so examples are most of the metabolic disorders like cystic fibrosis. This came in NEET PG 22. Cystic fibrosis, alpha-1 antitrypsin deficiency, Wilson's, hemochromatosis, Friedreich's ataxia, Gaucher's. So in fact, all of you in the NEET PG 22, I'll tell you another question which came in this year NEET PG 22. In the May this year, there was a child who had Gaucher's actually. There was a child who had hepatosplenomegaly. And the bone marrow showed macrophages which were filled with crumpled paper appearance. They had a crumpled paper appearance. These are the Gaucher cells. So remember, these are the Gaucher cells which have the crumpled paper appearance. So this question came in your NEET PG this year. A child has hepatosplenomegaly, bone marrow has macrophages filled up with crumpled paper appearance. So why did they ask you this question? Because remember, Gaucher's was the first disease for which enzyme replacement is available. The enzyme deficiency in Gaucher's is beta glucocerebrosidase. The enzyme deficiency in Gaucher's is beta glucocerebrosidase. So remember, this was the first disease for which enzyme replacement was available. Okay? This was the first disease for which enzyme replacement was available. Okay? Remember this. First disease for which enzyme replacement was available was Gaucher's. Okay? Now there are many other autosomal recessive disorders like Tay-Sachs, Niemann-Pick's, Niemann-Pick's. Noted? Noted? Have you noted this, all of you? So these are all autosomal recessive disorders. Now we are talking about enzyme replacement therapy. Remember, enzyme replacement therapy is also available for many other disorders. So you should all know that enzyme replacement therapy is also available for many other disorders. We told you Gaucher's was the first disease. For which enzyme replacement was available. Deficiency of beta glucocerebrosidase. This came in NEET PG this year. Pompe's is another autosomal recessive disorder. Glycogen storage disorder type 2, which involves the heart. Pompe's is glycogen storage disorder type 2, which involves the heart. Now mucopolysaccharidosis, guys. Remember, enzyme is available for Hurler syndrome, mucopolysaccharidosis type 1. Enzyme is available now, so it is costly 1 crore per year. But you know, in our country, there are many institutions like ESI. In ESI hospital, this enzyme is free. You know, many ESI hospitals, it is free. for all the ESI beneficiaries. So many ESI beneficiaries got glucocerebroside enzyme for Hurler. Hunter is X-linked recessive. Remember, enzyme is available for Hunter, which is X-linked recessive. Which is X-linked recessive. Hunter is a male. Yeah, with no offense to ladies attending this class today, Hunter, who killed Black Buck? Who killed Black Buck? Obviously a male, Hunter will be a bhai, no offense to the ladies attending this class. Hunter should be a male. Enzyme is available for mucopolysaccharidosis 4A, 6 and 7. Enzyme is available for mucopolysaccharidosis 4A, 6 and 7. Enzyme is available for Fabry's. Remember, enzyme is available for Fabry's. Fabry's is basically, remember, a boy. Fabry's is a X-linked recessive disorder. Fabry's is a X-linked recessive disorder. Remember, Fabry's is a X-linked recessive disorder. So you have a boy who has got kidney failure and nerve pain. So if you ever have a boy with kidney failure and nerve pains all over the body, think about Fabry's. Okay, kidney failure and nerve pains. Okay, enzyme is available. Okay, noted all of you? Can you please write in the chat box, everyone, that you have noted or not? Okay, so I'll ask you another question which came this year in the NEET PG. This year in the NEET PG, all of you, in the May this year, what happened is they showed you a child. They showed you a child, and they said this child is very floppy. This child is very floppy. हमेशा टुन रहता है बच्चा. So all of you, here is a child who is always floppy. I'll show you a child floppy. Parents came. They said, Doctor Saab, हमारा बच्चा ना हमेशा he has no tone. He's always floppy like this. He's always floppy. So she says, Doctor Saab, my child is always in the bed in a frog-like posture. So my child is always in the bed in a frog-like posture. So this child is always floppy. He's in the bed in a frog-like posture. He has no tone. So what is, and even during pregnancy, guys, even during pregnancy, mother had a history that she had less fetal movements. She never felt the fetal movements also during pregnancy. So there were less fetal movements during pregnancy. So can anyone in the class tell me the diagnosis? Floppy baby. When I say floppy baby, it's usually synonymous with spinal muscular atrophy. So remember, floppy baby, I'll just adjust the page. Sorry for this. So remember, floppy baby is usually synonymous with again an autosomal recessive disorder called spinal muscular atrophy. And the most severe spinal muscular atrophy is type 1, Wernicke-Hoffmann syndrome. Type 1, Wernicke-Hoffmann syndrome. Okay, Wernicke-Hoffmann syndrome. Type 1. Spinal muscular atrophy, type 1, called Wernicke-Hoffman syndrome. This is the most severe. Autosomal recessive की बात कर रहे हैं हम. We are talking about autosomal recessive. This question came in NEET PG this year. So remember, it is a disease of the spinal anterior horn cell. Remember, this is a disease of spinal anterior horn cell. Okay, it is a disease of spinal anterior horn cell. So what will you see on the examination? Lower motor neuron weakness. Lower motor neuron weakness like flaccidity, atrophy, absent reflexes. Okay, flaccidity, atrophy, absent reflexes, and what else is a feature of lower motor neuron weakness? Fasciculations. And you see fasciculations. Another lower motor neuron weakness feature called fasciculations. Fasciculations. Another lower motor neuron weakness. Fasciculations. Okay. Fasciculations. Okay, noted. Okay, fasciculations. So in fact, what question came in your NEET PG this year was actually a patient like this. So what I'll do is I'll show you a video of this child on your screen. So see, I'll show you a video of this child and I'll show you his tongue. See all of you. Can you see some vibrations of the tongue? Can you see some fasciculations of the tongue? So remember, fasciculations in spinal muscular atrophy are classically seen in the tongue. Remember fasciculations? Can you see his tongue? There is some fasciculations here. They're classically seen in spinal muscular atrophy. Look at this. Let's look at his tone. See how is he lying? Bilkul tone. There's no tone. He's always like flaccid. And look at his hypotonia. Now we are trying to look at the hypotonia. He's completely flaccid. See, this child is completely flaccid. He has no tone at all. So let me ask you this question, which came in NEET PG this year. So all of you, my question for you, let me see if I can find this question. Sometimes, you know, it's difficult to find some questions. Okay, I can't find this question. Maybe it was INICT exam. Just give me 1 minute. If I'm not able to find it, anyway, the answer was fasciculations are seen in spinal muscular atrophy. Okay. So if I ask you this question, guys, from AIMS this year, from the INICT exam, can anyone in the class tell me the answer of this question? INICT May this year. Huh? Fasciculations are seen in lower motor neuron weakness. So which of the following will have fasciculations? Students? And of course the answer is B. Yeah, all of you showed us the DAMS, symbol, which is victory. So yeah, fasciculations are seen in spinal muscular atrophy, an autosomal recessive disorder called spinal muscular atrophy. You're right. So all of you, why am I talking about this today? You will say, Arey, Aaj, why did I take you to SMA? Because remember, now there is a single novel gene therapy available for this. There's a single injection which can cure this child. Okay, and the name of these injections are nusinersen, onasemnogene abiparvovec. Yes, you have to write the name. Likhna hai naam. I know when I write this on the e-medicos, you say, sir, likhna hai ya? Dekho, all of you, this is not a video, a Netflix series going on. Whatever I am telling you, you have to write. Because this is important. This is the revolution. That now we have a treatment for SMA, a single injection. Nusinersen, onasemnogene abiparvovec, which is also called Zolgensma. Risdiplam, okay, Risdiplam. So it's a single injection. It is the costliest drug. This Zolgensma is the costliest drug in the whole world. Single injection is 16 crores. 16 crore रुपए की दवाई है. 16 crores. It is the world's costliest drug. But don't worry. Even in India, we have given it to many. In India, we have Farah Khan. So if anyone has this problem, they just tag Farah Khan on Instagram or Twitter, and Farah Khan will go to their home, make a YouTube video, and collect 16 crore rupees. So yeah, Farah Khan is the brand ambassador for Zolgensma. You can check this on line. Let's go further. And now let's take you to my favorite pedigree. And on your screen, I will show you my favorite pedigree. On your screen, I'll show you my favorite pedigree. Can anyone tell me now? Now the parents are carriers. Let's take you to the next inheritance. Now the parents are carriers. Boys are affected. Anyone in the class? Diagnosis? Parents are carriers. Boys are affected. Parents are carriers. Boys are affected. Only females are carriers. Only females are carriers here, and poor boys are affected. Dr. Sujit, please look at it carefully. Females are carriers and poor boys. There's only boy. There is a sex preference, all of you. क्या हो गया आप सबको? All of you, what has happened to all of you? All of you are wrong. What happened to you guys? Females are carriers, so this is recessive. Only females are carriers and poor boys are affected. X-linked recessive. Dr. Coyle is completely right. This is X-linked recessive. Only poor boys are affected. So if you look at this boy, his maternal uncle, mummy ka bhai, his maternal uncle is affected. His maternal granduncle is affected. If you see here, his maternal uncle is affected. Maternal granduncle is affected. Maternal cousins are affected. So remember, there's a history of affection on the maternal side. So remember, in X-linked recessive inheritance, boys are affected, and there is history of affection on the maternal side. Okay? X-linked recessive. Now, what are the examples of X-linked recessive inheritance? Let's talk about what are the examples of X-linked recessive inheritance. Duchenne's muscular dystrophy, Becker's, hemophilia A, hemophilia B, So Duchenne's, Becker's, hemophilia A, hemophilia B, G6PD deficiency. This question came in NEET PG 2 years back. G6PD is X-linked recessive. Wiskott-Eldridge came in NEET PG 2 years back. NEET PG 2020, Wiskott-Eldridge. Color blindness is X-linked recessive. Lesch-Nyhan syndrome. Chronic granulomatous disease is X-linked recessive. Chronic granulomatous disease is X-linked recessive. Okay, noted all of you? Noted? Can anyone write? Noted? Okay, so all of you, what I'll do is I'll show you a boy who has a weakness. On your screen, I'll show you a video of a boy who has some weakness and you have to tell me the diagnosis. Okay, so here's a boy. We asked him to get up from sitting position. See how is he getting up? How is he getting up? He's climbing on himself. We are asking him to get up from sitting position. See how is he climbing? He's climbing on himself and he's getting up. So what is this sign? This is a Gower sign. G-O-W-E-R. This is a positive Gower sign. G-O-W-E-R. It's a positive. He's climbing on himself. See, I'll just pause it for you. See, he's climbing on himself and he's getting up. This is called a positive Gower sign. Okay. This is a Gower sign, remember? This is a Gower sign, remember? It is a sign of proximal muscle weakness. Remember, Gower sign is a sign of proximal muscle weakness. So remember, it does not mean that this child is having Duchenne's muscular dystrophy. It just means this child has proximal muscle weakness. Okay. No, Dr. Ankur, this does not mean he has DMD. It means he has proximal muscle weakness. Okay. It's just a marker of proximal muscle weakness. Remember this. So remember, Duchenne's children, specifically Duchenne's. Let's talk about Duchenne's muscular dystrophy. Duchenne's is the most common. Remember, Duchenne's is the most common hereditary neuromuscular disease. Duchenne's is the most common hereditary neuromuscular disease. Duchenne's is the most common hereditary neuromuscular disease. And what can you see here, guys? What can you see here? Pseudo hypertrophy of the calf muscles. Remember, Duchenne's is the most common hereditary neuromuscular disease. And what you can see here is pseudo hypertrophy of the calf muscles. It is not true hypertrophy, it is pseudo hypertrophy of the calf muscles. Pseudo hypertrophy of the calf muscles. There is fat infiltration. It is not a true hypertrophy. There is fat infiltration in Duchenne's. So in fact, the most common muscle to be affected in Duchenne's is gastrocnemius. Okay, so remember, the most common muscle to be hypertrophied in Duchenne's is gastrocnemius. Okay, gastrocnemius is the most common muscle to be hypertrophied. So all of you, what I'll do is I'll take you to NEET PG 22 and I'll just show you a picture from NEET PG 22. I'll just move myself from here, and this question came in NEET PG. Can anyone tell me the answer of this question? NEET PG 22. The question is, a 2-year-old boy has proximal muscle weakness, frequent falls. So a 2-year-old child has proximal muscle weakness, has frequent falls, is not able to get up from sitting position, and this is his muscle biopsy. Okay, so on your screen is his muscle biopsy picture. Okay, so can anyone, so a lot of students came to me after this NEET PG and they said, sir, I don't know what, there was a muscle biopsy picture in the NEET PG and there were a lot of neutrophils in the muscle biopsy. So can anyone tell me the diagnosis? Can anyone tell me the diagnosis? Everyone in the class? So all of you, let me first take you to the muscle biopsy. What is this muscle biopsy showing? So on your screen is the muscle biopsy, and you can see a lot of, interfibril connective tissue. Within the muscle fibers, there's a lot of connective tissue. This is called, in Duchenne's, initially, there is increased interfibril connective tissue. And this connective tissue ultimately becomes fat. Ultimately, so all of you, I'll show you another picture. After a few years, what will happen? Can you see a lot of fat globules? So ultimately, all of this connective tissue is converted to fat later on. Okay, so yes, the answer was Duchenne's in this NEET PG question. And remember, children with Duchenne's do not survive beyond teens. So they do not live in fact more than 20 years also. So remember, they do not live beyond teens. They all die in their teenage life. They all die in their teenage life. So this was the answer of this question. Remember, there are some gene therapies available, but they are not very successful in it. So they're not very successful. It is X-linked recessive. It is not an infective disease. This is Duchenne's muscular dystrophy. Can we go further? Cool? All of you enjoying? Okay, cool. So remember, this question which came this year was actually a Duchenne's muscular dystrophy. So let's show you the next inheritance of the day. And all of you, I'll show you this pedigree and you have to tell me what is this pedigree showing. Suppose this red is the disease. Suppose this red is the disease. Okay, suppose this red is the disease. Can anyone tell me? Of course, all the generations are affected. Red, 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 red. This is dominant. All the generations are affected. This is dominant. My question to you is there a sex inheritance or is there a sex preference? See, an affected father gives the disease to all daughters. Look at any affected father. He gives the disease to all daughters. An affected father gives the disease to all daughters. It is X-linked. So how did I recognize this? I said an affected father gives the disease to all daughters. A father gives X chromosome to all his daughters and none of his sons. An affected father gives the disease to all daughters, none of his sons. Okay? None of his sons. Okay? X-linked dominant. Okay, how do you identify this? No father to son transmission. Remember, no father to son transmission. Remember this. No father to son transmission. Remember this. Okay, no father to son transmission. Let's go further. So what are the examples of X-linked dominant inheritance? Let's talk about what are the examples of X-linked dominant inheritance. Rett syndrome, Rett syndrome. I'll start with hypophosphatemic rickets. So remember, all of these disorders are again severe in males. They are again severe in males, like hypophosphatemic rickets. Rett syndrome, inconsentia pigmenti, Aicardi syndrome, okay. So if I ask you, all of you, this question also came in NEET. I'm sorry, but yeah, this NEET PT had 7 questions on genetics. The question was, which syndrome is only seen in girls? And the answer was Rett syndrome. NEET PG 22. Which syndrome is only seen in girls? And the answer is Rett syndrome. Because these 3 syndromes, Rett's, inconsentia and Aicardi, they are lethal in male fetuses. They are lethal in male fetuses. Okay, so remember these 3 syndromes, Rett's, inconsentia and Aicardi syndrome, are lethal in male fetuses. So they are only seen in girls. Okay, so if I take you back here and I show you a very sad pedigree. On your screen is a very sad pedigree. I can only see girls here. I can only see girls here. So this is a typical X-linked dominant inheritance, which is, can you see a lot of abortions here? These must have been males who got aborted. So remember, this is something like a Rett syndrome, an X-linked dominant inheritance, which is lethal in male fetuses like Rett's, Aicardi, inconsentia pigmenti. Okay. 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 So remember, there's a doubt from a student here, Dr. Prafulla. Only these 3 syndromes are like this, in which if a male gets the abnormal X chromosome, he dies. Okay. So on your screen is only females who survive. Rest male die. Only these 3 syndrome, Rett's, inconsentia and Aicardi syndrome. Okay, so that was all about the Mendelian disorders. Let me take you to some non-Mendelian disorders. Let me take you to some non-Mendelian disorders. Can we take you to the non-Mendelian disorders, all of you? Okay, so let's first show you the first non-Mendelian disorder of the day. And first of all, what we'll do is, all of you, I will be talking about deletions. I'll be talking about chromosomal deletions. So chromosomal deletions can be of two types. They can be major deletions of the chromosomes or micro deletions of the chromosomes. So all of you, on your screen, I'll show you a karyotype. Can anyone tell me what is this karyotype showing on your screen? Look at this karyotype. Can anyone tell me what can you see in this karyotype on your screen? Fifth chromosome. 5p deletion, you're right. So this was a karyotype of 5p deletion. Short arm of the fifth chromosome is gone. इसको कहते हैं cry do chat syndrome. These children, they cry like cats. So remember, these children, they cry like cats because they have abnormal larynx. So these children, they cry like cats because they have abnormal larynx. So we can diagnose major deletions by a routine karyotype. We can diagnose major deletions by a routine karyotype. Let's talk about micro deletions. Let's talk about micro deletions. Now, micro deletions is just, for example, the most important question which came in your NEET PG in 21, Williams syndrome. It's 7q11.23 deletion. This question came in NEET PG 21, Williams syndrome, 7q11.23 deletion. D. George, which is also called velocardiofacial syndrome, 22q11 deletion. Just one exon is missing, D. George, velocardiofacial syndrome, 22q11 deletion. Absent thymus, absent parathyroids. So in D. George, there is absent thymus and absent parathyroids. Another syndrome which is microdeletion, very important, called the Prader-Willi syndrome, or the Angelman syndrome, 15q11 to 13 deletion. Okay, Prader-Willi syndrome is 15q, 3 exons are missing, 11, 12, 13, 15q11 to 13 deletion. Okay. Okay, 15q 11 to 13 deletion is micro deletion. Okay, so how do you diagnose micro deletions? So remember, to diagnose micro deletions, we do a FISH. We do fluorescence in situ hybridization. So remember, to diagnose micro deletions, we do a FISH, which is called fluorescence in situ hybridization. Okay, which is called fluorescence in situ hybridization. Okay, fluorescence in situ hybridization. Okay, fluorescence in situ hybridization. So this is very important, guys. So you should know about these micro deletions, favorite of your examiners. So let's first talk about the Williams. Williams is very important. So your examiner in your NEET PG 21, they asked about Williams. So on your screen is Williams. It's a supravalvular aortic stenosis. I would again emphasize 7q is the favorite chromosome of your examiners. Williams syndrome, it is a supravalvular aortic stenosis. Supravalvular aortic stenosis. Supravalvular aortic stenosis. They also have peripheral pulmonary stenosis. Okay. So they also have peripheral pulmonary stenosis. Peripheral pulmonary stenosis. Okay. So remember, these children also have peripheral pulmonary stenosis. Okay. Okay, all of you. Peripheral pulmonary stenosis. And they have ELF-like face. So remember, they have hypercalcemia and they have ELF-like face. They have hypercalcemia and they have ELF-like face, elfin facies. Elves का face कैसा होता है? You know, these are the short people who help Santa Claus distribute all the gifts during Christmas. So all of you, this month, they will come to your home. You know, Santa Claus is busy, you know, he cannot go everywhere. But he loves everyone. So Santa Claus will send this elf to your home. So remember, this is the typical elf. Their upper lip is thick. Their upper lip is thick. So remember, this is how we differentiate elves from fetal alcohol. Fetal alcohol में upper lip is thin. Elf का upper lip is thick and absent philtrum. And they have absent philtrum. Okay. Okay, all of you. Noted? Okay, I'll just open my app. And I'll check. Can we go further, all of you? I'll just open my app, just 1 second, and then I'll take you further. So I was just checking the connection. So this is fine. So all of you should know about these syndromes. They are very important, especially the microdeletion syndromes. They are very important for your exam. So what I'll do is I'll show you one more question which came in your INICT exam. I think in May this year. I'll just open a May question of the INICT. And my question for you is this. And you answer me, okay? A child has absent thymus and absent parathyroids. What will you think of? A child has absent thymus and absent parathyroids. What can you think of? You'll think about DiGeorge syndrome. So all of you should know this, that the inferior parathyroid and thymus are formed from the third pharyngeal pouch. Okay, so remember that the inferior parathyroid and thymus are formed from the third pharyngeal pouch. Superior parathyroid from the fourth pharyngeal pouch. So what is DiGeorge? Absent thymus, absent parathyroids. Hypoplasia of the third and the fourth pharyngeal pouch. Hypoplasia of the third and the fourth pharyngeal pouch. Okay? Okay, done? Hypoplasia of the third and the fourth pharyngeal pouch. Let's show you another inheritance, all of you. And now all of you have to tell me the diagnosis, okay? I'll show you an inheritance which comes in every exam of yours. And now you tell me, all of you, what can you see here? What can you see here? Anyone in the class? Now I will take you to non-Mendelian inheritance. Now I will take you to non-Mendelian inheritance. And can you tell me, what can you see here? What can you see here? If mother is affected, all children are affected. If mother is affected, so on your screen, yes, Dr. Koyal is right, mitochondrial. Maternal inheritance, if mother is affected, all the children are affected. That's called mitochondrial inheritance. If mother is affected, all the children are affected. That's called mitochondrial inheritance. So remember, maternal inheritance is mitochondrial. So remember, maternal inheritance is mitochondrial. Okay? Maternal inheritance is mitochondrial. Cool? Noted? So let us talk about what are the examples of mitochondrial inheritance. I'll just put it on your screen, the examples of mitochondrial inheritance. Let's look at what are the examples of mitochondrial inheritance. MERRF, so myoclonic epilepsy and ragged red fibers, MELAS, MELAS is mitochondrial encephalopathy, lactic acidosis, and stroke-like episodes. So MELAS is mitochondrial encephalopathy, lactic acidosis, and stroke-like episodes. Okay? And stroke-like episodes. Okay? Leber's hereditary optic neuropathy is mitochondrial. Leber's hereditary optic neuropathy is mitochondrial. Lee's disease, Keene-Sayre syndrome, NARP is NARP also a favorite of your examiners. Neuropathy, N stands for neuropathy. A stands for ataxia, and RP stands for retinitis pigmentosa. So RP stands for retinitis pigmentosa. Okay. Another syndrome called Pearson syndrome, which is also mitochondrial. Another syndrome which is mitochondrial is chronic progressive ophthalmoplegia. Chronic progressive ophthalmoplegia is mitochondrial. Last but not the least, deafness because of aminoglycosides. Deafness because of aminoglycosides. It's not just aminoglycosides. There is a genetic risk also. So deafness because of aminoglycosides is also inherited mitochondrially. Okay, so deafness because of aminoglycosides is also inherited mitochondrially. Okay. Okay, so remember this. Noted, all of you? Noted? Okay, so now I will be telling you the most important inheritance which is non-Mendelian, important for your exams. Let's take you to the most important inheritance, non-Mendelian, for your exams, which is called genomic imprinting. All of you need to know a deletion called 15q11 to 13 deletion. All of you should know this deletion called 15q11 to 13 deletion. याद रहेगा सबको? 3 exons are missing. 11, 12, 13. Okay, so 3 exons are missing from on the long arm of 15th chromosome. So remember, if you get this deletion, I'll just put it on your screen. If you get this deletion from your PA, chromosome number 15, child becomes Prader-Willi syndrome. And if you get the same deletion from your Ma, child becomes Angelman syndrome. So all of you please write in your copies. Paternal inheritance of the deletion causes Prader-Willi syndrome. Paternal inheritance of the deletion causes Prader-Willi syndrome. And maternal inheritance of the same deletion causes Angelman syndrome. Maternal inheritance of the same deletion causes Angelman syndrome. This is called genomic imprinting. What is genomic imprinting? It is defined as differential expression of the genetic defect. Mendel never taught us this. It is differential expression of the genetic defect based on the parent. Differential expression of the genetic defect based on the parent. You got it from your father or from your mother. It's differential expression of the genetic defect based on the parent. You got the defect from, so expression is dependent on the parent of origin of defect. So expression is dependent on the parent of origin of defect. Okay. For example, on your left is the most common genetic obesity. Prader-Willi is the most common genetic obesity all over the world. And on your right side is the happy puppet syndrome. Angelman, which is also called, they are always laughing, they are known for their laughter, happy puppet syndrome, Angelman syndrome. So Prader-Willi is a genetic obesity. So even like, I showed you SMA today, a floppy baby. So even Prader-Willi can also have neonatal hypotonia. So even Prader-Willi can be, small, completely hypotonic at birth, neonatal hypotonia, obesity, small hands and feet, and mental retardation. Severe neonatal hypotonia, obesity, small hands and feet, and mental retardation. Okay, so severe neonatal hypotonia, obesity, small hands and feet, and mental retardation. Okay. Okay. On the other hand, Angelman is completely normal at birth and subsequently develops seizures, mental retardation, and ataxia. So remember, Angelman is completely normal at birth, subsequently develops seizures, mental retardation, and ataxia. Remember, Prader-Willi eat a lot. That's why, they are fat. Because they have increased renin in their body. So they have increased appetite in their body. So they eat a lot. Remember, Prader-Willi are short. We give them growth hormone also. So just add 2 more points. Prader-Willi syndrome have increased renin in their body. They have very good appetite. So they eat a lot. And we give them recombinant human growth hormone. Okay. Okay, noted. Noted. So remember, both of these syndromes exhibit genomic imprinting. Okay, so all of you should know that all over the world there are 8 known imprinting disorders. So I'll just tell you 8 important examples of genomic imprinting. I'll just tell you 8 examples of genomic imprinting. Number 1, I talked about Prader-Willi syndrome. I told you, all of you, 70% of the times it's deletion from the PA, which is called genomic imprinting. इसको कहते हैं genomic imprinting. 30% of the times, remember, when we can also say Prader-Willi is unimaternal disomy. So whenever I say disomy, I say the opposite. So 30% of the times Prader-Willi is unimaternal disomy. Okay, please remember this. Of the genes, when I say disomy, I mean the genes. Now I told you Angelman syndrome, 70% of the times it's deletion from the Ma. We call it as genomic imprinting. So whenever we say disomy, we say the opposite. So remember, 5% of Angelman syndrome is unipaternal disomy. So remember, 5% of Angelman syndrome is unipaternal disomy. Okay, number 3, remember, a transient neonatal diabetes mellitus is also genomic imprinting. Transient neonatal diabetes mellitus. Temple syndrome, Wang syndrome, Russell-Silver syndrome, Beckwith-Wiedemann syndrome, and remember, pseudo hypoparathyroid 1B. Pseudo hypoparathyroid 1B is also mitochondrial. So remember, pseudo hypoparathyroid 1B is also mitochondrial. Okay, noted all of you? Noted? Pseudo hypoparathyroid 1B is also mitochondrial. Okay, so all of you, so this is our plan of the crash course today. So let me take you to the plan. So we have done till now all of this, and we will have a lunch break now, and we'll come back in 40 minutes, and I'll take you to the developmental milestones and endocrine system after the lunch break. Okay, so we'll come back with milestones and endocrine system after the lunch break. All of you, my name is Siddharth Sethi. If you have any doubts, these are some of my social media handles. You can tag me at any of these social media handles, and we'll come back in 40 minutes. Okay, so let's start milestones after this. Okay, so go back, freshen yourself, and class is till 9 o'clock tonight. Okay, start all of you. Let's start and let's talk about milestones. And what we'll do in this session is, first of all, we will be talking about milestones before 1 year, and then I'll take you to milestones after 1 year of life. So I will divide this into milestones. Social milestones are of 4 spheres: social, gross motor, fine motor, and language. Okay, social, gross motor, fine motor, language. And I'll show you a lot of children in this session. So let us start with less than 1 year, then I'll take you to more than 1 year. So all of you, on your screen is a child doing something. Tell me what's he doing. Okay, and please, all of you, this video is in Hindi, please don't mind. There are some mothers who go overboard. So let's see what she says.
स्मार्ट बेटो कितना कितना हंस रहा है। हाँ, दवाई में भांग मिला था क्या? हंस रहा है।
So I told you, don't mind what she says. So this is a social smile. So this is social smile. So let's start with the social milestones, everyone. So remember, at 2 months of life is the social smile. So जब आप 2 महीने के थे, जब भी आपकी कोई आंखों में आंखें डाल के देखता था, you used to smile. So remember, social smile is at 2 months of life. Okay, at 3 months a child recognizes his mother and smiles. Okay, so social smile is at 2 months. At 3 months he recognizes his mother and smiles. Okay, at 3 months he recognizes his mother and smiles. Okay, now a child has stranger anxiety at 6 months. So stranger anxiety is at 6 months. Now remember, stranger anxiety is different from separation anxiety. You must have seen some children, who are very clingy, they're very chipku. So clinginess, chipkuness is at 18 months. So remember, clinginess, chipkuness is at 18 months of life. Okay, clinginess, chipkuness is at 18 months of life. We also call it as rapprochement. So we also call it as rapprochement. Okay. Now remember, at 9 months, if you show a toy, suppose I show you a toy, I show a toy to a 9-month-old and I hide it. I show a toy to a 9-month-old, I hide it. Now he remembers this toy when the toy is not there. So remember, object permanence, constancy is at 9 months. Object permanence, constancy is at 9 months. Remember. Object permanence, constancy is at 9 months. Remember this. Okay. Noted? Okay, noted, all of you? Okay, so remember, a child enjoys this game called peekaboo. A child enjoys this game called peekaboo. So suppose you play with a child, he enjoys this game peekaboo at 9 months of life. Okay, a child enjoys this game called peekaboo at 9 months of life. Okay, noted? Noted, all of you? So let's take you to the next milestone. Let's take you to the next milestone. And next, we will, from social, I'll take you to language. Chaliye, let me show you language. I'll show you a child doing something. Tell me what's he doing. What's he doing? Yeah. So this is cooing. So this is cooing. All of you can see. This is cooing. Okay, all of you, this is cooing. So let's talk about language. Let's talk about language now. Let's talk about language. At 3 months, a child starts cooing. Okay, so remember, all of you, at 3 months of life, a child starts to coo. Okay, so cooing is at 3 months. So please remember, cooing is at 3 months. Okay, so please remember, cooing is at 3 months. Okay, will you remember this? So cooing is at 3 months of life. Okay, remember this. Okay, so in a way he is vocalizing. In a way this child is vocalizing. This is what I want you to remember, that in a way this child is now vocalizing. Okay, at 5 months a child starts babbling. At 6 months monosyllables, at 8 months bisyllables. So remember, at 6 months he has monosyllables, at 8 months he has bisyllables. So remember, 6 months monosyllables, at 8 months bisyllables. Okay, okay, so remember, at 8 months bisyllables. A 1-year-old child can speak 2 words with meaning. So please remember, at 1 year a child can speak 2 words with meaning. 2 words with meaning. Okay, at 15 months he speaks 4 to 5 words with meaning. At 18 months a child has a 10-word vocabulary. At 18 months he has a 10-word vocabulary. Okay, at 18 months he has a 10-word vocabulary. Remember, at 2 years his vocabulary suddenly increases. He speaks now almost 50 to 100 words at 2 years. He can speak 2-word phrase at 2 years. So remember, a child can speak a 2-word phrase at 2 years. At 3 years he speaks 3-word sentences. So at 3 years he speaks 3-word sentences. Okay, noted? Noted, all of you? So we talked about language. Let's talk about fine motor milestones now. I'll take you now to fine motor milestones. Okay? Fine motor milestones. Can I take you to fine motor milestones, all of you? Okay. Let's show you the most important fine motor milestone on your screen. So all of you, what I'll do is on your screen, I'll show you the most important fine motor milestone. Maybe I'll just show it here. I have a child doing something. So this is the most important fine motor milestone. Between 12 to 20 weeks, a child is only interested in his hands. So between 12 to 20 weeks, a child is only interested in his hands. He only keeps at looking at his hands. It comes at 12 weeks, goes at 20 weeks. It comes at 12 weeks, goes at 20 weeks. Okay? It comes at 12 weeks, goes at 20 weeks. Okay? Okay? Noted? So let us talk about the fine motor milestones. This is very important. This question came in NEET PG 21. Bite axis approach is at 4 months. Bite axis approach is at 4 months. At 6 months, he has a palmar grasp. He holds everything with his palm. At 6 months, he has a palmar grasp. He transfers objects from one hand to the other at 6 months. Transfers objects from one hand to the other at 6 months. At 9 months, he has a pincer grasp. At 9 months, he has a pincer grasp. This is very important. This came in NEET PG this year. At 1 year, the pincer grasp is mature. Okay? At 1 year, the pincer grasp is mature. Okay? Remember this. Noted this? All of you noted? Now I'll take you to the gross motor milestones before 1 year. Now I'll take you to the gross motor milestones before 1 year. Gross motor milestones before 1 year. Can we go further? So remember, pincer grasp is important. Index finger and the thumb. Mature का मतलब है center of the index finger and center of the thumb. So mature का मतलब है center of the index finger, center of the thumb. Okay. So on your screen, all of you. On your screen, all of you. This is the most important gross motor milestone. Can anyone tell me what is this child doing on your screen? This is the most important, this is the most important gross motor milestone. What is this, all of you? What is this, all of you? Neck holding. So remember, every baby should be able to hold his neck in the plane of the body at 3 months. Okay. Every baby should be able, yes, you're right, neck holding. So let's take you to the gross motor milestones, very important. Let's take you to the gross motor milestones. So remember, at 3 months of life, every baby should be able to hold his neck in the plane of the body. Between 4 to 6 months, a baby can roll in bed. Between 4 to 6 months, a baby can roll in bed. At 5 months, a baby can sit with support. At 8 months, a baby can sit without support. At 9 months, a baby starts crawling. At 10 months, a child can stand with support, and remember, at 1 year, a child can stand without support. So remember, at 1 year, a child can stand without support. At 1 year. Okay, so remember, at 1 year, a child can stand without support at 1 year. Noted, all of you? Noted. So now what I'll do after this is I'll talk about children more than 1 year. Okay, so now I will be talking about children more than 1 year after this. Noted. Can we go to children more than 1 year? Can we go to children more than 1 year, all of you? Okay, so all of you, this table from Nelson's textbook is very important, and yes, you all have to note down this table. So I will just underline whatever is important. I'll just underline whatever is important. Okay, I'll just underline that, and then you can note down what is important. Remember, at 15 months, a child can make a tower of 3 cubes. एक cube per एक cube, tower of 3. So tower of 3 cubes is at 15 months. Okay, tower of 3, एक cube per एक cube, tower of 3 is at 15 months. At 15 months, a child speaks jargon. He responds to his name, indicates desires by pointing, indicates desires by pointing. Remember, at 18 months, a child can make a tower of 4. So, यहाँ हमने कहा 15 months tower of 3, 18 months tower of 4. Remember, at 18 months, we just now told you that he has a 10-word vocabulary. He has a 10-word vocabulary. At 18 months, he can identify one or more parts of the body. So please remember this. Yes, you have to write this, all of you. All of you, you have to write this. I'll just move from the screen. So just note this down. Maybe all of you, this is there on the Facebook, on the DAMS exclusive club also. This is there in all platforms. It's also in the DAMS CRS. This table is important, so please see whatever I've written is important here. Noted? Noted? Can I take you to the next page? Noted? Can we take you to the next page, all of you? All of you, can you please speak up in the chat box? Huh? Dr. Nazir, Samiksha, Aarti, Shelja, Dr. Priyanka, Dr. Pankaj. Okay, so let's take you to the next page. And now next, remember, we'll talk about 2-year-old and 30 months. So remember, at 2 years, a child can run well. So very important, at 2 years, a child can run well. Okay. Now, before I take you to this, all of you, I have a video for you, and I'll come back here. Just tell me, what is this video showing? All of you, just tell me, what are we doing here? What is this child doing?
Yay! You did it. Good job.
So what is this child doing, all of you? He's climbing the stair, one stair at a time. This is at 2 years of life. Remember, climbing stair one at a time is at 2 years of life. Okay. So let's talk about 2 years. So at 2 years, a child can run well. He walks up and down stairs one at a time. Yes, one step at a time. You're completely right in the chat box. So at 2 years, remember, this is a favorite question of your examiners. Tower of 6 or 7? Tower of 6 or 7 is at 2 years. He can handle spoon well at 2 years, I'm sorry. At 2 years, he can handle a spoon well. Now, at 30 months, he goes up alternately. Okay, so now like you climb stairs alternately. At 30 months, a child climbs up alternately. Tower of 9 is also at 30 months. He knows his full name, pretends in play at 30 months. Remember this. Okay. Can we go further, students? So just note it down and let me know when you're done. Whatever I've underlined is very important. Noted? Now I'll take you to 3 years old, 4 years old and 5 years old. I'll talk about 3 ages now, 3, 4, 5. Let's talk about 3 years old. I'll just bring it up. Let's talk about 3-year-old. Now 3 years is a very important milestone, everyone, remember. He can ride a tricycle at 3 years, makes a tower of 10 at 3 years, copies a circle, remember, copies. He can copy a circle at 3 years. Okay? He can make a bridge of 3 cubes at 3 years. He can make a bridge of 3 cubes at 3 years. He knows his age, his gender at 3 years. He knows his age, his gender. Parallel play is also at 3 years. Parallel play is also at 3 years. Okay? Okay, all of you, can we go further? Can we go further, all of you? So I'll just take you to 4 years and 5 years and then we'll move further. Okay, so let's take you to 4 years and 5 years and then we'll move further. At 4 years, a child hops on 1 foot at 4 years. So I'll just slightly zoom it. Child hops at 4 years and skips at 5 years. Child hops at 4 years, skips at 5 years. Okay. Okay. A child can make a gate of 5 cubes at 4 years. He can copy a cross and a square. So this is very important. A square has 4 sides. So a cross and a square is at 4 years. However, triangle is at 5 years. So remember, triangle is at 5 years. Okay. Remember this. A 4-year-old child can tell a story. A 5-year-old can copy a triangle. A 5-year-old can copy a triangle. Name 4 colors. Ask meaning of words. Dress and dress without supervision. So at 5 years he can dress and dress himself without supervision at 5 years. Okay? Note it down. Okay? Noted? Can we go further? Can you please write in the chat box so we can go further, all of you? So yeah, you have to at least, remember whatever is underlined, that is important. You should know. So what we'll do is, I'll just tell you some more important milestones and then we'll move further. Like a child can tie his shoelaces at 5 years. Remember, all of you, that a child, what is anchopraces? Anchopraces means passing stools in clothes after 4 years. Okay, and the most common cause of anchopraces is chronic constipation. Okay, passing stools in clothes after 4 years is called anchopraces, and the most common cause of it is chronic constipation. Okay, so most common cause of it is chronic constipation. Okay, lastly, what is nocturnal enuresis? Nocturnal enuresis basically means a child is involuntarily emptying his bladder at night. At night, what happens is involuntarily he empties his bladder at night more than 2 times a week for a period of 3 months. So a child involuntarily empties his bladder at night more than 2 times a week for a period of 3 months. after the age of 5 years. After the age of 5 years. So 5 years से पहले हम कहते हैं कोई बात नहीं बच्चा है, but after 5 years we say it is called nocturnal enuresis. And remember, the best treatment for long-term remission is alarm therapy. So these are gadgets which are tied to a child's undergarment, and as soon as his undergarment becomes wet, it buzzes. Okay. So this is what is called as, okay, the best therapy. Only when the alarms fail, we go for a desmopressin, a drug called desmopressin. This is a drug which is available in oral forms, inhaled desmopressin, and we also have it available as a melt formulation which melts in the mouth. So it's also available as a melt formulation which melts in the mouth. Okay, so the child doesn't need to drink so much of water with it. Okay, so it's also available as a melt formulation which melts in the mouth. Okay, cool. So let's take you now to some important topics about endocrine system. Let's see if any one of you has written anything in the chat box. Let's talk about some endocrine topics. So those who came late in the class, so all of you, this is our plan of the day, and I will now talk about some important endocrine topics. Okay, now in endocrine topics, all of you, first of all, you should know that, you know, we need to have neonatal screening. So remember, we need to have neonatal screening. Why do we need to have neonatal screening? Should we be diagnosing, all of you, these metabolic disorders at birth? Huh? Should we try to diagnose these metabolic disorders at birth, everyone? Is it? Should I diagnose, say, cystic fibrosis at birth? Should I diagnose, say, hypothyroidism at birth? Should we be diagnosing them at birth? I'll give you an example, all of you. On your screen, I'll show you an example. We will talk about neonatal screening. And on your screen, I'll show you an example. And you tell me what is your diagnosis. On your screen, all of you is a child. He's completely delayed. He's a 6-month-old child. On your screen is a 6-month-old child. He's completely developmentally delayed. He has hypotonia, hypothermia, constipation, hypotonia, hypothermia, constipation, umbilical hernia. This child has prolonged neonatal jaundice. So in the newborn period, this child had prolonged jaundice in the neonatal period. Prolonged neonatal jaundice. Anyone in the class? Diagnosis? Diagnosis? Anyone in the class? Diagnosis? What will you think of if a child comes to you like this, who is completely delayed, hypotonia, hypothermia, constipation, umbilical hernia, a prolonged jaundice in the neonatal period? You'll think about congenital hypothyroidism. You are completely right. So Dr. Ankur is completely right. Ankur, your diagnosis is right. This baby has congenital hypothyroidism. Excellent, Ankur. Congratulations. But it is too late. Now this is too late. You know, now this child will never ever be normal again. Now this child will be never ever be normal again. Okay? He will never improve. Remember this. Because you diagnose it late. We have to diagnose disorders at birth, everyone. Not at 6 months. When this child is already a clinical spotter. So remember, today we'll talk about some disorders which we need to diagnose at birth. And the first I will talk about TMS, tandem mass spectrophotometry. So remember, by doing a heel prick, we basically take a heel prick. We take 2 drops of blood by a heel prick on a filter paper. So for all the metabolic disorders, remember, for all the metabolic disorders, we do TMS. Please remember, favorite question of your NEET PG came in 2019. Now, we told you now that every baby in the world should get a TSH. Now, every baby should get a TSH. Now, TSH alone, or we should also do a T4 with TSH. So, ideally, we should do both. Because, you know, there are some babies who may have, there are some causes, some babies who may have a delayed rise of TSH. So if a baby has got a delayed rise of TSH, then T4 will also help you. Then in thyroid binding globulin deficiency also, TSH may be normal. Remember, in thyroid binding globulin deficiency also, TSH may be normal. Remember that. Okay? Both of them should be done. Now the question is, when, how, why? Question is when, how, why? Let's talk about when. What is the best time to do a TSH? Let's talk about what is the best time to do a TSH. Remember, all babies have a TSH surge. As soon as all the babies are born, within 30 minutes of life, there is a TSH surge. And it comes back to normal in 48 to 72 hours. All babies have a physiologically high TSH. So remember, according to the American Academy of Pediatrics, the best time to do TSH is after 72 hours to 6 days by a heel prick. So remember, according to the American Academy of Pediatrics, the best time to do TSH is after 72 hours to 6 days. Okay, cool. Done? Cool. Now the question is, what is the most common cause of congenital hypothyroidism? Remember, congenital hypothyroidism is the most common preventable mental retardation. Remember, congenital hypothyroidism is the most common preventable mental retardation. You can prevent mental retardation. How? By early thyroxine supplement, by early diagnosis and early thyroxine supplementation. So remember, the most common cause, 85% of congenital hypothyroidism is dys or agenesis of the thyroid gland. Dysgenesis or agenesis of the thyroid gland. Okay. Okay, dysgenesis or agenesis of the thyroid gland. Remember this. Okay, so if the most common cause is dysgenesis or agenesis of the thyroid gland, students, if I ask you a question, all of you, I have a question for you, which came in this year's NEET PG. A question for you on the screen. NEET PG 22. This is my question for you. A 4-day-old baby has a TSH of 100 IU per ml. What will you do? A 4-day-old baby has a TSH of 100. What investigation you'll do to diagnose etiology? We said 85% of congenital hypothyroidism is agenesis or dysgenesis of the thyroid gland. So students, what will you do? Can anyone in the class tell me? I want all of you to answer. Anyone? All of you, can you please tell me? Let's see what are the responses. And someone says B, someone says C. So all of you remember the answer is a radionuclide thyroid scan. So what I'll do is I'll show you a normal thyroid scan on your screen. On your screen, this is a normal thyroid scan. So in a normal thyroid scan, all of you, I'll just get up and show you. This is your thyroid gland, and this is a technetium based normal thyroid scan. So sometimes, you know, these salivary glands also take some technetium. So this is a normal thyroid scan, the nuclear scan. Now remember, 85% is agenesis or dysgenesis of the thyroid gland. So on your screen, all of you, you cannot see a thyroid gland here. So you will have no uptake in agenesis or dysgenesis of the thyroid gland. So answer was, most of you said B. Let me see. Yeah. So the answer was B. So remember, we'll go for a radionuclide thyroid scan. I would like to add one more thing for you, all of you. Remember that if they ask you what is your first step in this child, do not wait for a scan. Start therapy. Don't be late. Otherwise, he will be mentally retarded. So, any baby whose TSH is more than 40, start thyroxine. Any baby whose TSH is more than 40, you should start. You should not wait. You should start thyroxine. Okay? Remember this. Okay? Start thyroxine. Cool? So do not wait for the tests. Start therapy. Now there are many other tests which we can do in neonatal screening, like we can diagnose congenital adrenal hyperplasia. Every baby in the world gets a test for congenital adrenal hyperplasia, which is called 17-hydroxyprogesterone. It is called 17-hydroxyprogesterone. Okay, 17-hydroxyprogesterone. We can diagnose cystic fibrosis at birth these days by a screening test. We can diagnose biotin deficiency. Of course, G6PD should be done in India. An X-linked recessive disorder, G6PD. We can diagnose biotin deficiency at birth these days also by just a simple test. It's a simple 2 drops of blood on a filter paper. Do boon zindagi ke. And we are not talking about polio here. We are talking about screening, neonatal screening. Okay? Can we go further, students? Noted? Noted? So this brings me first to CAH. This brings me first to CAH. Let's talk about an adrenal test disorder which we can diagnose at birth called congenital adrenal hyperplasia. This is 17-hydroxyprogesterone. Remember, this is 17-hydroxyprogesterone. Remember. Okay. Noted? So let's take you to CAH, congenital adrenal hyperplasia. Let's take you to CAH. It is also called CAH, congenital adrenal hyperplasia. The next endocrine topic of the day is congenital adrenal hyperplasia, an autosomal recessive disorder, CAH, congenital adrenal hyperplasia. What is CAH? Remember, it is the most common cause of a female pseudo hermaphrodite. Remember, CAH is the most common cause of a female pseudo hermaphrodite. Most common cause, this question came in NEET PG 4 years back, 2018, of a female pseudo hermaphrodite. Bachcha is a female, XX is the karyotype, but looks like a male. Bachcha is a female, XX is the karyotype, but looks like a male. Autosomal recessive disorder, congenital adrenal hyperplasia. Okay, noted. So what I'll do is I'll take you back to your medical school. I'll take you back to your medical school. In your medical school, everyone, you saw this picture in your medical school in your first chapter of physiology. So let's talk about this. Let's talk about congenital adrenal hyperplasia. Remember, 90% of congenital adrenal hyperplasia is 21 hydroxylase deficiency. Remember, 90% of congenital adrenal hyperplasia is 21 hydroxylase deficiency. 90%. Okay, so it's a block here. Here. 21 hydroxylase deficiency. So all of you, do you want to say something? What is not formed? What is there excess of? If there's a block here at this level, at the level of 21 hydroxylase. So aldosterone is not formed, cortisol is not formed, and there is excess of testosterone. Okay. So if aldosterone is not formed, this child is in shock. Hyponatremia, hyperkalemia. So sodium is lost, guys. Sodium is lost. Aldosterone is not there. This is called a salt wasting crisis. So 70%, remember, 70% of CAH is caused by a salt wasting crisis. 70% of CAH is caused by us, it presents like, so हमने कहा 90% तो is deficiency, but this deficiency mostly presents like a crisis at 2 weeks of life. It's a crisis at 2 weeks of life. If cortisol is not there, glucose is low. Now excess of testosterone leads to females getting virilized. So females get virilized and males get precocious puberty. Females get virilized and the males get precocious puberty. Okay. So remember, females get virilized and the males get precocious puberty. Noted, all of you? So remember, females with CAH, because of the excess of testosterone, get virilized and the males get precocious puberty. Okay, noted? Noted? So all of you, I'll tell you a question which came in my NEET PG. You know, I will not tell you a few decades back how many, in which exam I took my All India PG. In my, so then you'll know my age. Okay, I don't want to tell you my age. So this question came in my All India PG exam. What is this? This is hypertrophic clitoris. Because of the testosterone, the clitoris is hypertrophic. Because of the testosterone, so because the cortisol is low, ACTH rises and leads to pigmentation of the labia. So labia are pigmented like scrotum. Because of the ACTH, all of you, because of the ACTH, all of you, labia are pigmented like scrotum. Labia are pigmented like scrotum. Clitoris is looking like penis. So the girls get ambiguous genitalia. So the girls get ambiguous genitalia. Okay, so girls with CH get ambiguous genitalia. You know, we don't know it's a boy or a girl. This patient actually, they was brought to me and the parent said, Dr. Saab, why don't you keep the name? We don't know it's a boy or a girl. This child has a penis-like structure and the scrotum are empty. And students, in fact, I tried to put this photograph on Facebook on the DAMS exclusive club multiple times, and this photograph doesn't come on Facebook. So it disappears from Facebook. Then when I tried to post it again, I got a message from Facebook that you are posting, you know, indecent content on Facebook. If you'll post this photograph again on Facebook, we will, you know, we'll put you out of the Facebook. So I did not post this photograph again. For Facebook thinks this is indecent, though, you know, this is a very educational photograph for you. Ambiguous genitalia. Okay, in females. So it leads to ambiguous genitalia in females. Okay. So I have a question for all of you. My question for all of you is, which of the following is seen with CH? My question for all of you is, which of the following is seen with CH? Anyone? Which of the following is seen with CH? Anyone? So let us start with the first option. The boys, because of excess of testosterone, get precocious puberty. And yes, you're right. All of you are right. And Dr. Satpathy was the first to tell. ACTH increases the pigmentation. If aldosterone is not there, the renin is high. If aldosterone is not there, the renin is high. Now remember, testosterone causes a premature precocious pubertal spurt. So remember, testosterone causes a premature precocious pubertal spurt and short stature. So there is a premature epiphyseal closure, and excess of testosterone causes short stature. So excess of testosterone causes short stature. Okay, so remember, CH is also a cause of short stature because of premature epiphyseal closure. So this testosterone causes premature closure of the epiphysis. Okay, all of you? Noted? Remember this. So how do we diagnose CH? Let's take you back to this picture and let's see how do we diagnose CH. So we showed you this photograph just a few minutes back. Now what accumulates in CH? This 17 hydroxyprogesterone. So remember, we diagnose CH by estimating the levels of this 17 hydroxyprogesterone. So this accumulates. So every baby in the world gets 17 hydroxyprogesterone. So remember, every baby in the world gets 17 hydroxyprogesterone. These levels are very high in these infants. So remember, these levels of 17 hydroxyprogesterone are very high in these infants. They are in thousands. Normal level is 10, 20, 30 like this. But in infants with CH, the level of 17 hydroxyprogesterone is in thousands. It's 3500 to 5000 nanograms per deciliter. So levels are very high. They're in thousands. 3500 to 5000 nanograms per deciliter. Okay? Okay, cool. Noted. Or 105 to 150 nanomoles per liter. In your exam, if they ask you in nanomoles per liter, it is 105 to 150 nanomoles per liter. Okay? Cool. Let's talk about how do we treat CH. Let's talk about how do we treat CH. So remember, this child is in shock. So the first step is to give a bolus of 20 ml per kg of normal saline. We give a bolus because this child is in shock. So we give a bolus 20 ml per kg. Now, what is the drug of choice for Addison's crisis? This child is in a crisis. He's in a acute adrenal insufficiency. So drug of choice is intravenous hydrocortisone. So any patient who has Addison's crisis, the drug of choice is intravenous hydrocortisone. 100 milligram per meter square of the body surface area per day in 3 divided doses. In 3 divided doses. In 3 divided doses, we give hydrocortisone. We also give fludrocortisone. We also give oral fludrocortisone, a mineralocorticoid called fludrocortisone, in a dose of 0.15 milligrams per day. In a dose of 0.15 milligrams per day. Now these girls actually require a surgery before marriage, like a vaginal reconstruction surgery, or a clitoroplasty. But that's another story, that these girls will never get married because these girls have high testosterone. Okay, so these girls, if anyone has high testosterone, they will not like men. They like females. Anyone who has high testosterone, they like females. So these girls like girls. So they don't like to get married because they have different tendencies. Okay, remember this. So all of you, I'll just share with you a very important mnemonic which all of you should know. I'll share with you a very important mnemonic which all of you should know. Just write, all of you, in your copy, M and T. M stands for mineralocorticoid. Okay. Okay. M stands for mineralocorticoid, and T stands for testosterone. So please write this, all of you. M stands for mineralocorticoid and T is testosterone. Okay, so T is testosterone. और नीचे बड़ा बड़ा लिखो 21, 17, 11. नीचे बड़ा बड़ा लिखो 21, 17, 11. All of you, will you write this? लिखो M and T and नीचे लिखो 21, 17, 11. Okay, now make this one as an arrow. Make this one as an arrow. Make this one as an arrow. Okay, make this one as an arrow. Okay, will you write this? Make this one as an arrow. So it means, all of you, in 21 hydroxylase deficiency, only testosterone is high. In 17, only mineralocorticoid is high. In 17, only mineralocorticoid is high. And in 11, both of them are high. Remember, in 11, both of them are high. Okay? In 11, both of them are high. Mineralocorticoid is also high. Testosterone is also high. Okay? Okay, noted, all of you? So all of you, I want to ask a question to all of you. Can you tell me in which CAH there is hypertension? Anyone in the class? So this is a DAMS only mnemonic. One of the students from DAMS told me about this. So can you tell me in which CAH there is hypertension? There is high mineralocorticoid and there is hypertension. Okay? Can anyone tell me? Okay, can anyone tell me? I'll wait for your answer. Anyone? Bataiye, all of you. Looking at this, tell me which CAH has high mineralocorticoid and it leads to hypertension. 17 and 11. Very good by Dr. Pallavi, everyone. So I have a question for all of you. My question goes something like this. This is a 5-year-old boy and he has suddenly become very tall. He's at 5-year-old. Suddenly, he got a precocious pubertal spurt. He's suddenly the tallest boy of his first standard. His BP is 130/80. His BP is 130/30. So what do you think about 130/80 BP for a 5-year-old? It's hypertension. It's hypertension. So what will be your answer, all of you here? Anyone? Question, answer of this question? This is not the classic CAH. Classic CAH has shock. This is a different enzyme deficiency. This is a different enzyme deficiency. Anyone? Answer? Yes, very good, Chandan. This is 11 beta hydroxylase deficiency, a rare type of deficiency of CAH, a non-classic variety of CAH, which we diagnose by estimating. And I can see everyone is right in the class. Can I give you a round of applause? Very good. It was supposed to be a difficult question. Good, guys. Yes. So this is a rare type of CAH, 11 beta hydroxylase deficiency, a non-classic variety, which we diagnose by 11 deoxycortisol levels, which we diagnose by 11 deoxycortisol levels. Okay, done? Cool? Cool? So let's take you now to short stature. Let's take you to another topic of endocrine system, which is called short stature. So another topic of endocrine system is short stature. So first of all of you should know who is short. Who is short? When do we define it as short stature? So all of you, suppose we have, this is your population of your class. This is your whole class. Some of you are short, some of you are tall. So these -2 standard deviation. So children who are less than this -2 standard deviation below the mean are short. Okay. So children who are less than -2 standard deviation below the mean are short. So the first 3 students of the class. So class के जो पहले 3 बच्चे हैं, first 3 students of the class for that age and sex, first 3 students of the class are short or less than -2 standard deviations below the mean for that age and sex is short. Okay. 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 So let us talk about what are the causes of short stature. So remember, the most common cause of short stature in children is physiological. So most common cause of short stature in children is physiological. Physiological causes of short stature, which is called constitutional. So what is constitutional? When I say constitutional, what is constitutional? Remember, this is the most common cause of short stature in children. It is the most common cause of short stature in children. It means this child was born normally. The birth length of this child was normal. Just that he got a lag at 6 to 12 months of life. After which his growth velocity was completely normal. So after the initial lag, his growth velocity was completely normal. After the initial lag, his growth velocity was completely normal. So what will happen to his final adult height? Normal. So his final adult height is also normal. Okay. So all of you, I'll just show you a typical photograph on your screen, a typical growth curve on your screen. Let's show you a typical growth curve on your screen. Just look here, all of you. On your screen is a growth chart of a child. And can you please look at the blue line? Just concentrate on this blue line, the third line from below. Look at this blue line. This is constitutional short stature. This child was born normally. Just that he got a lag at 6 to 12 months of life. This child was born normally, just that he got a lag at 6 to 12 months of life. And all of you, can you appreciate this? Later in his life, on your right side is his adolescence. And all of you, can you appreciate? Later in his life, he could catch up and he could reach the mean. So later in his life, he could catch up and he could reach the mean. Okay, so he could reach the mean later in his life. So in fact, in English, these children are called the late bloomers. So in English, these children are called the late bloomers. Okay, in English, these children are called the late bloomers. There are some children who will bloom late. There are some children who bloom late, and हम तो शक्ति कपूर के ज़माने के पुराने ज़माने के लोग हैं. हमारे ज़माने में शक्ति कपूर, whenever he would look at someone, he would say, ये कुछ कच्ची कलियां हैं जो देर से खिलती है. So constitutional short stature are the late bloomers. In English, these are the late bloomers who bloom late. Okay. So all of you, so it means they could catch up later in their life. This is constitutional. So if I draw a table for you, so the puberty, so remember the puberty and bone ossification is delayed in these children and they can catch up later in his life. So puberty and bone ossification is delayed in these children and they could catch up later in the life. Okay. Puberty and bone ossification is delayed in these children and they could catch up later in the life. Chaliye, let's take you to another short stature which is called familial. Let's take you to another short stature which is called familial. A physiological short stature called familial. Familial is, a child who is right from the beginning, he's small. So he's small right from the beginning. His birth length is also small. Ultimately also he will be small. There are some children who grow in their own percentile. There are some children, who grow like themselves only. They grow in their own percentile. Okay. So their growth velocity is normal or slightly subnormal. So their growth velocity is normal or slightly subnormal. Okay. Okay, noted. So let us show you a typical growth curve of familial short stature. Let us show you a typical growth curve of familial short stature. So all of you, let's just again concentrate on this growth curve of a child right from his infancy to older life. And let's look at this red line, second line from below. Let's look at this red line, the second line from below. This is familial. Can you see? This child was born small, -2 standard deviation. He was born small. And he always remained small. So in familial short stature, a child is born -2 standard deviation below the mean and he always remains small. Okay. Okay, he always remains small. Okay, noted. So what will happen to the puberty and the bone ossification of this child? Remember puberty, and this is very important point, just highlight this in your notes, that puberty and bone ossification are always normal in familial short stature. Puberty and bone ossification are always normal in familial short stature. Okay? Noted? Noted, all of you? Done? Can we go further? Can you please write noted in the chat box? Please write noted in the chat box. So if you want a break, let me know. We can give you a 5-minute break if you want. How many want a 5-minute break? Let's start. And what we'll do now is we will be talking about the respiratory system. So now in this session, I will take you to respiratory system. Let's talk about respiration. And in respiratory system, students, before I take you to specific disorders from upper airway to lower airway, I would like to take you guys to the IMNCI guidelines. They are very important for your exam. Every exam has a question on IMNCI guidelines. Okay, so let's talk about the IMNCI guidelines. So remember that according to the WHO, the IMNCI guidelines, it classifies all the respiratory illnesses into 2 age groups. Okay, so we look at the respiratory illnesses in 2 age groups, less than 2 months and 2 months to 5 years. Okay, so we classify the respiratory illnesses in 2 groups, less than 2 months and 2 months to 5 years. Okay, less than 2 months, 2 months to 5 years. Let's talk about less than 2 months. Let's talk about less than 2 months. So remember, less than 2 months, we don't say pneumonia. Remember, all of you, less than 2 months, we never say pneumonia. Less than 2 months, we say either it's a serious infection or a local infection. So remember the IMNCI guidelines, less than 2 months says either it's a serious infection or a local infection. Serious or local? Serious infection or local infection? So let us talk about what is serious infection in children less than 2 months. Let us talk about what is serious infection in children less than 2 months. So what is serious bacterial illness in children less than 2 months? Number one, if a baby is not able to feed. If a baby is not able to feed well. Okay, convulsions, respiratory rate more than 60. So remember, convulsions, respiratory rate more than 60. Nasal flaring or grunting. Nasal flaring or grunting. Chest indrawing. Bulging fontanelle. So chest indrawing, bulging fontanelle, 10 or more pustules, 10 or more pustules or a big boil. So remember, 10 or more pustules or a big boil is serious. Hyper or hypothermia is serious. So hyper or hypothermia is serious. Lethargy or unconsciousness is serious. Now according to the IMNCI guidelines, for a child less than 2 months, how do you treat him? By IV MP or oral amox with intramuscular genta. with IVMP or oral amox with intramuscular genta and refer urgently to a higher center. IVMP or oral amox with intramuscular genta and refer urgently to a higher center. Okay, noted? Noted, everyone? Noted? So remember, less than 2 months we say serious or local infection. Let me know when you note it down. Noted? Can we come to local infection now? Less than 2 months, local bacterial infection. Can we, all of you? Okay, so let's talk about what is local infection in babies less than 2 months. So remember, in babies less than 2 months, its umbilicus is red or draining pus. So in babies less than 2 months, if umbilicus is red or draining pus or less than 10 pustules. So remember, less than 10 pustules is local. Okay, so remember, less than 10 pustules is local. For local infection in a child less than 2 months, we give oral amoxicillin for 5 days and review in 2 days. So for a child less than 2 months, we give oral amoxicillin for 5 days and review in 2 days. Okay? Noted? Can I take you now to 2 months to 5 years? So let's talk about 2 to 60 months now. Let's talk about 2 months to 60 months. Can we go to older children? 2 months to 60 months? Okay, so let us talk about, according to the IMNCI, what do we do for children 2 to 60 months? Let's talk about what is the IMNCI guideline for children between 2 months to 60 months. How do we classify the respiratory illnesses in children between 2 months to 60 months? So remember, we say it's green, yellow or pink. So it's green, yellow, pink. Okay, so for 2 to 60 months, it's green, yellow or pink. Okay, so cough and cold is no pneumonia. Okay, so remember, cough and cold is no pneumonia. Okay, cough and cold is no pneumonia. Now for respiratory rates, what is pneumonia? Now we have some cutoffs, guys. Now we have some cutoffs. Okay, we have some cutoffs. we have some cutoffs. For 2 to 12 months, 50 or more. So remember, for 2 to 12 months, the cutoff is 50 or more. 12 to 60 months, 40 or more. So 12 to 60 months, the cutoff is 40 or more. Okay, so remember these cutoffs: 2 to 12 months, 50 or more; 12 to 60 months, 40 or more. And if there is chest indrawing, that is also called pneumonia. So if there is chest indrawing, that is also called pneumonia. Okay, so chest indrawing is also called pneumonia. And remember, according to WHO, the drug of choice for pneumonia is oral amoxicillin for 5 days. So we give oral amoxicillin for 5 days, follow in 2 days. So we give oral amoxicillin for 5 days and we follow this child in 2 days. If saturation is less than 90%, refer the child urgently. So remember, if saturation is less than 90%, you refer the child urgently. Okay? Refer urgently if saturation is less than 90%. Okay? So remember, chest indrawing or fast breathing is pneumonia. So 2 to 12 months, 2 to 60 months, we say pneumonia, severe pneumonia. Now we have some, all of you, now we have some cutoffs. Okay? We have some cutoffs for danger signs. What is a danger sign? Danger sign or stridor in a calm child. Danger sign or stridor in a calm child is severe pneumonia or very severe disease. So danger sign or stridor in a calm child is severe pneumonia or very severe disease. Okay? Vomiting, not able to drink water, lethargy, convulsions, unconsciousness. So lethargy, convulsions, unconsciousness is severe pneumonia or very severe disease. Refer urgently. Give IV, MP or oral amox with the intramuscular genta. Give IV, MP with oral amox with intramuscular genta and refer urgently. Okay? Okay, fine. Okay, can we go further? So please remember this, pneumonia. Okay, noted all of you, this is very important. So please remember the danger signs: lethargy, vomiting, not able to drink, convulsions. Give first dose of MP, IV or oral amox with intramuscular genta and refer urgently. Okay? All of you, can you please write noted in the chat box? Dr. Pankaj, Nazir, Dr. Samiksha, Dr. Pallavi, Dr. Shelja, Dr. Aarti, Dr. Patel, all of you, can you please write noted? Then I'll show you a question which came in your NEET PG 2020. Okay, so what I'll do is I'll show you a question from NEET PG 2020. This question came in NEET PG and the question goes out for all of you. You have to tell me the answer of this question. I'll just put it on the screen. So this is the question on your screen. 18-month-old child weighs 11 kg. 18-month-old child weighs 11 kg. He comes to a peripheral health center. His respiratory rate is 46. So what cutoffs I told you just now? 12 to 60 months, 40 or more. 2 to 12 months, 50 or more. So his respiratory rate is high, okay. Respiratory rate is high. And he is lethargic. Lethargy is a danger sign. What would you like to do? He is lethargic. Lethargy is a danger sign. What would you like to do? That's the question. And let's see what you say. Dr. Priyanka is right. Everyone in the class is right. We will give IV, MP or oral amox with intramuscular genta and refer urgently. So the second option is right. We'll give IV antibiotics and refer to the higher center urgently. So this is the kind of questions, NEET PG asks. Okay. These are common questions previously also asked. So you should know the high risk situations. So now what I'll do is I'll show you a child who has some noisy breathing. Now I'll take you from upper to the lower airway. So all of you, now what is happening is that a child is about to come to your class and this child has a noisy breathing. This child on your screen has fever. This child on your screen has fever and a noisy breathing, and I want you to tell me what is your diagnosis. This is an inspiratory sound called stridor. So remember, this is an inspiratory sound called stridor. Okay, inspiratory sound called stridor. Okay, this is stridor. And now here is a child, all of you, who's got fever and stridor. Okay, so here is a child who has got fever and stridor. So let us talk about what are your differential diagnoses if a child comes to you fever and stridor. See, stridor means upper airway obstruction. So stridor always means upper airway obstruction. Okay, Dr. Shelja, this is stridor. So remember, the most common cause of fever with stridor is croup, which is also called laryngotracheobronchitis. So the most common cause of fever with stridor is a croup called laryngotracheobronchitis. Croup is viral. It is caused by a virus called parainfluenza. It's caused by a virus called parainfluenza. So here is a child who got a viral prodrome of khasi, zukam, bukhar. He had a viral prodrome of cough and cold. And now this child got a stridor. So now he got a stridor. Okay, now he got a stridor. Okay, prodrome, now he got a stridor. Now remember, barky cough is a very classic feature of croup. It doesn't happen in any other illness. Barky cough is very classic of croup. It means croup. Now remember, if you do an X-ray AP view on the airway, it shows a very important sign called the steeple sign. X-ray AP view of the upper airway shows a very important sign called the steeple sign. So on your screen, guys, on your screen, students, is a typical steeple sign. So what you can see on the screen, all of you, is a typical subglottic narrowing. So on the screen, what you can see is a typical subglottic narrowing, which is a feature of croup. You can see a typical, suddenly the airway, these arrows are showing this airway has suddenly become, small. It's a typical subglottic narrowing. Now remember, before I talk about the treatment, all of you should know What are the markers of severity of croup? What are the markers of severity of croup? So if a child is having stridor at rest, if a child has stridor at rest, retractions, desaturation, cyanosis, desaturation, he's desaturating, he's got central cyanosis. Last but not the least, drooling. If he's drooling saliva, it means his upper airway is completely blocked. Okay, so look for these key words in your question. Don't just say on my, on the Facebook every time, you tell me, sir, stridor at rest is severe. Beta, look at the whole patient also, no? Look at the retractions, whether he's having desaturations or not, cyanosis, drooling or not. Now, remember that the drug of choice for mild croup is dexamethasone. It's a high dose dexa, 0.6 milligrams per kg, single dose dexamethasone. And drug of choice for moderate to severe croup is nebulization with racemic epinephrine. Nebulization with racemic epinephrine. Okay. Okay. Okay, cool. So all of you, I'll ask you a very important question which comes in your exam every time. Noted, all of you, I'll show you a question, a very important question for your exams. So here's a question on your screen. A 2-year-old boy, this question has come 3 times in your exam. A 2-year-old boy comes to you at 3 a.m. in the morning. He has a barky cough. Stridor is only when he cries. It's not at rest. Only when he cries, he gets a stridor. Okay, only when he cries. He has fever, 39.6, high grade fever, but room air saturations are fine. So all of you, can you tell me the diagnosis and the treatment? Can you tell me the diagnosis and the treatment? Diagnosis and the treatment. Yes, all of you are right. This is mild croup. This is not moderate to severe. This is mild croup. And for which we will give him high dose dexa. So remember, for this we'll give a high dose dexa, 0.6 milligrams per kg of high dose dexa. Cool, everyone in the class is right, and I want to give you a round of applause. Everyone is right, guys. I'm happy for you. Okay, let's go further. So our topic, our syndromic approach here is basically a child who has got fever and stridor. So basically we are talking about approach a child has fever and stridor. So what I'll do is I'll show you a child who has fever and stridor, and you tell me the diagnosis. On your screen, is a child who's got fever and stridor. And this child has got a bull neck and a white throat in his, has got a white membrane. A white membrane in his throat. What is your diagnosis? What will you think of if a child comes to you with a bull neck and a white membrane? And a white membrane. What will you do? Laryngeal diphtheria. So let us talk about diphtheria. Diphtheria is very important, even diphtheria. So immunization history is very important. If a child comes to you with fever and stridor, diphtheria, immunization history is very important. So you should know, how do we treat diphtheria and how do we prevent diphtheria? Okay. So remember, the drug of choice for diphtheria is 2 dawaiya, diphtheria antitoxin. Along with that, we give antibiotics, erythromycin or penicillin for 7 to 10 days. So we give antibiotics with antitoxin. Erythromycin or penicillin for 7 to 10 days. Erythromycin or penicillin for 7 to 10 days. Now remember, this is a very important question for your exam. What is the minimum protective level in the body of diphtheria antitoxin? Anyone? What is the minimum protective level of diphtheria antitoxin in the body? 0.01 to 0.1 IU per ml. So remember, this is the minimum protective level of diphtheria antitoxin in the body. 0.01 to 0.1 IU per ml. Okay. Now another question, and this is the classic question of your exam, that suppose there is an asymptomatic child in the family and he got exposed to this child. This child got exposed to diphtheria. Suppose a 3-year-old child, and this is the question which came in NEET PG 21. A 3-year-old child got exposed to this white membrane in the throat child. What will you do? So remember, you should know from the Nelson's textbook, you should know that according to the Nelson's textbook, a child, any patient, any child who gets exposed to diphtheria, we should monitor him for 7 days. We should monitor him for 7 days, do serial cultures. Do serial cultures. Okay, so do serial cultures and give a single dose benzathine penicillin or erythromycin for 7 to 10 days. So for at least for 10 days. Okay. So in fact, this was the answer of the question in NEET PG 21. You will give erythromycin for 7 to 10 days. Okay. You will give erythromycin for 7 to 10 days. Okay, noted all of you? Noted? Done? Now the question is, when do we give DT vaccine? This was also an option in the NEET PG 21. When do we give DT vaccine? So remember, DT vaccine is only given to children who have not received a booster in the last 5 years, who have not received a booster in the last 5 years. Okay, who have not received a booster in the last 5 years, or not received the 4th dose, or not received the 4th dose. Okay. Okay, noted. So this is the question. So in fact, in NEET PG 21 question came, a 3-year-old completely immunized child. What will you do? He got exposed. So the answer in NEET PG 21 was erythromycin for 10 days. Okay, remember this. Noted, all of you guys? Done? Cool. So yeah, fever with stridor, diphtheria is one of the differential. So fever with stridor, you should think about laryngeal diphtheria as one of the differential diagnosis. Another differential is epiglottitis. Another differential is epiglottitis. Epiglottitis. So all of you should know about another bacterial illness called epiglottitis. Remember, epiglottitis is bacterial. Now remember, all over the world, it is because the H influenza vaccine is used. So strep pyogenes is the most common cause of epiglottitis all over the world, followed by strep pneumoniae, followed by Staph aureus. Okay. 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 Okay, all of you. Now in India, H influenza is still there. Remember, in India, H influenza type B is still there. So here is a bacterial illness. So short history, you have a child who's got short history of fever. He is toxic. Stridor, he is sick. Fever, toxic, stridor, he is sick. Drooling saliva, he is drooling saliva. Now if you do an X-ray of the epiglottitis child, if you look at the lateral view of the X-ray of this child, I'll show you a typical X-ray of epiglottitis on your screen, guys. And the typical X-ray is a thumb sign. So on your screen you can see a thumb sign, a classic thumb sign you can see on the screen. What you can see here are the swollen epiglottic folds. Okay, swollen epiglottic folds. Thumb sign is classic of epiglottitis. Okay. So remember, the treatment for any patient with severe stridor is always airway first. Remember, airway always comes first. He may require an emergency tracheostomy. Okay, he may require an emergency tracheostomy. So we give a third generation cephalosporin. It's a bacterial illness. So we give a third generation cephalosporin, ceftriaxone with sulbactam, to cover the ESBL organisms. So we give ceftriaxone with sulbactam to cover the ESBL organisms, the extended spectrum beta lactamase producing organisms. So to cover the extended spectrum beta lactamase producing organisms, we give sulbactam. Okay, noted? Noted? So this stridor is initially inspiratory. Of course, stridor is always initially inspiratory, but in serious illnesses, it can be biphasic stridor also. Dr. Satpathy has asked a question. So remember, in serious conditions, it can be biphasic also, but initially it's inspiratory. Okay. Can I go to the vaccination schedule first? So before I take you to pneumonia, all of you, can you please write noted in the chat box? Can you please write noted in the chat box? Okay. So what I'll do is I'll first take you to the vaccination schedule, which all of you should know, because there have been questions in your exam recently on the vaccination schedule. So you have learnt in the PSM class, but what I'll do is I will tell you the schedule which we follow as the pediatricians of the country. We are around 30,000 pediatricians in India, and we follow the IAP schedule. It's the Indian Academy of Pediatrics vaccination schedule 2021. So what we do is we follow the Indian Academy of Pediatrics vaccination schedule 2021. BCG, OPV, HBV1, BCG, OPV, hepatitis B1, at 6, 10, 14, remember, at 6 weeks, 10 weeks and 14 weeks, we give DPT, okay, we give DPT. So it can be whole cellular pertussis or acellular. So remember, we give acellular. Pertussis can cause seizures, remember. So pertussis can cause seizures. So remember, we give acellular if a child has progressive epilepsy or seizures. Okay, if a child has got progressive epilepsy or he has got seizures, we give him acellular pertussis. This is AP, acellular pertussis. Okay, noted? You give IPV, as our country is going from the polio to eradication of polio. We give inactivated polio. H influenza, pneumococcal conjugated vaccine, so PCV 123 and rotavirus 123. So we give PCV 123 and we give rotavirus 123. So all of you, I have a question. This question came in NEET PG 21. My question is, which vaccine used to have a side effect of intussusception? Anyone in the class? Which vaccine used to have a side effect of intussusception? Anyone in the class? Which vaccine, NEET PG 21, which vaccine used to have a side effect of intussusception? Anyone? Rotavirus, you're right. The previous versions of rotavirus vaccine used to have a side effect of intussusception. However, the rotavirus which we use in our country, the risk of intussusception is very less. So remember, the benefit is more than the risk. So similarly, like if I tell you about COVID vaccines, everyone, in the America, they have mRNA vaccines. They have Moderna, Pfizer vaccines. So mRNA vaccines can cause myocarditis in adolescents. mRNA COVID vaccines can cause myocarditis in adolescents, but the benefit is much more than the risk. So we give mRNA vaccine to children, adults, everywhere in the US. Now all of you, at 6 months of life, we give influenza 1. At 7 months, we give influenza 2. Six to 9 months, we give typhoid conjugated vaccine. So 6 to 9 months, we give typhoid conjugated vaccine. At 9 months, we give MMR1, and all of you should know this, that you know currently what is happening in Mumbai. In Mumbai, there is a very big epidemic of measles going on. So many children did not get measles vaccine in all over the country. So in Mumbai, suddenly, you know, small children like 6 months old, 7 months old have started getting measles. More than 50 children have died in Mumbai because of measles epidemic. So, you know, MMR now we are considering, maybe, you know, we should think of early MMR now. So MMR is at 9 months. Remember this. This is what is going on in the country right now. MMR 1. At 12 months, we give hepatitis A. 15 months, MMR 1, varicella 1, PCV booster. At 16 to 18 months, we again give DPT booster, whole cellular or acellular, with Hib or IPV. At 18 to 19 months, we give hepatitis A 2 and varicella 2. At 4 to 6 years, we give DPT booster, IPV booster, MMR3. So remember, this is very important. And in fact, so remember, at 4 to 6 years, we said we give DPT booster, IPV2 and MMR2. Okay? Noted? Sorry. Okay, all of you, okay? Fine. So this is a question which came in NEET PG 21. In NEET PG 21, the question which came was, which vaccine can be given to a 10-year-old boy? So remember, to a 10-year-old, we give TDP. T, small d, and acellular pertussis. Okay, T, small d, and small ap. Okay, noted? Okay, okay, T, small d, and small ap. T, small d, and small ap. Okay. Noted, all of you? This is only for India. We are talking about India. America is different. Okay, can we go further? Can we go further? Now I will take you to pneumonia now. Friends, I will take you now to pneumonia. Let's talk about what are the causes of pneumonia in children, age-wise and country-wise. So let's talk about what are the causes of pneumonia in children, age-wise and country-wise. So this is very important. Let us now, from IMNCI, I will take you to the exact causative organisms of pneumonia, age-wise and country-wise. So remember, less than 8 weeks, the causes of pneumonia all over the world is group B streptococci. It's group B stept, followed by E. coli. But remember, in India, infections are mostly caused by Klebsiella first. So if they ask you what is the most common cause of pneumonia in India, it's Klebsiella. Now 8 weeks to 4 years, 8 weeks to 4 years. Okay, according to the Nelsons and even according to our Indian textbooks, remember, pneumonias are mostly viral, and RSV is the most common cause of pneumonia between 8 weeks to 4 years. So remember, pneumonias are mostly viral between 8 weeks to 4 years. There are many other viruses. I will not go into all those viruses, but the viral pneumonias are followed by bacterial. And the most common cause of bacterial pneumonia is strep pneumoniae. Okay, so the most common cause is strep pneumoniae. After 4 years, whether it's India or the world, like like I have some mild cough. So older children, like I am an older child, so in older children, atypical organisms are more common, like mycoplasma. So they should take azithromycin, macrolides, followed by strep pneumoniae, followed by chlamydia, So these are the causes of pneumonia in older children. Okay, noted. Noted. Can we go to the next topic of recurrent pneumonia now? So from pneumonias, let's take you now to recurrent pneumonia. Can we take you to recurrent? So let's talk about recurrent. Let's talk about recurrent pneumonia. What is recurrent? So remember, at All India Institute, this definition was made, and it's very important for all of you. Remember, recurrent pneumonia is defined as 2 episodes of radiographic pneumonia in 1 year. So if a child has got 2 episodes of radiographic pneumonia in 1 year, so in 1 year, if he gets 2 pneumonias, this is recurrent. Or 3 episodes in any time frame, any time in the life, if a child gets 3 episodes, this is also recurrent. So 3 episodes in any time frame is also recurrent. Okay. What is persistent? It's persistence of symptoms and X-ray abnormalities for more than a month. It's been a month. This child is having persistent fast breathing and X-ray is persisting for more than a month. Okay. This is called persistent pneumonia. Okay. Noted? So now we will be talking about, a very important cause of recurrent pneumonia, which is called cystic fibrosis. So remember, cystic fibrosis is the most common lethal genetic disorder in Caucasians. So remember, cystic fibrosis is the most common lethal genetic disorder in Caucasians. गोरे लोग होते हैं ना, उनमें होता है. Most common lethal genetic disorder. The prevalence of cystic fibrosis is 1 in 2500 in the UK and Europe. So prevalence of cystic fibrosis is 1 in 2500 in the UK and Europe. The gene CFTR is on 7q. The gene CFTR is on 7q, 31.2 locus. So the gene CFTR is on 7q, 31.2 locus. So students, let's take you to a very important topic of cystic fibrosis. Okay, let's take you to a very important topic of cystic fibrosis. Now this is very important, all of you. I'll show you in the last 5 years, every NEET PG had a question on cystic fibrosis. So let us write, first let us talk about the genetics of cystic fibrosis, then we'll talk about the clinical features of cystic fibrosis. So let us first talk about the genetics of cystic fibrosis. Remember, it is the most common lethal genetic disorder in Caucasians, you know, गोरे लोगों में, in Caucasians. Remember, it is autosomal recessive. The CFTR gene is on the locus 7q, favorite question of your examiners, 31.2 locus. So it's on 7q 31.2 locus. Okay. Now, 3 weeks back in your NEET PG, I'm sorry, in your INI-CT exam, remember the CFTR gene codes for a chloride channel. It codes for a chloride channel. Now remember, which is the most common mutation? This question came in your INI-CT 3 weeks back. Which is the most common mutation in cystic fibrosis? Remember, 70% of Caucasians have delta F508. 70% of Caucasians have this mutation called deletion of the phenylalanine. So this was the question in INI-CT. They asked phenylalanine at 708 number position. Is it 508? So this is what they asked. Remember, there is deletion. There is a codon called TTT. There is a codon called TTT. Okay. So there is deletion of this codon TTT. Okay. So remember this, deletion of the codon TTT. Okay. Now it's very fascinating. See how this mutation led to what are the changes in the function of at the level of cell. Remember this mutation, delta F508, is a class 2 mutation. It's a class 2 mutation. What do I mean by class 2? Basically, you know, protein is made up on endoplasmic reticulum, and then the protein, you know, then the protein goes to the cell wall and makes the chloride channel. Now the protein is misfolded. The protein is misfolded and is not able to go to the cell membrane. It causes a trafficking defect. It causes a trafficking defect. Okay, so the protein is not able to go to the cell surface. Why are we talking about this? Because all of you, there is a lot of changes. There's a lot of new drugs which have happened in cystic fibrosis. Now we have some new drugs which are called CFTR modulators. We have some development of the new drugs called CFTR modulators. So there's a lot of things which have happened which are new in the field of cystic fibrosis called CFTR modulators. So let me first take you to the history. And this question came in your INI-CT exam 3 years back. There was a mutation called class 3 mutation. What class 3 mutation does is, because of this mutation, the chloride channel closes early. Because of this mutation, the chloride channel closes early. So for this, the first drug, this mutation, class 3 mutation, I'll give you an example. Example is G551D mutation. G551D mutation. So the first drug which came in the world for opening the chloride channel is called ivacaftor. It's a CFTR potentiator. So the first drug which came in the world was a CFTR potentiator. Now all of you know the most common mutation is delta F508. Now, what is the treatment of delta F508? If you go to the America, if you see on the Google, you'll see the treatment is a triple therapy. It's a combination therapy. It's called a triple combination therapy. Combination of one potentiator and two correctors. One potentiator and two correctors. So there's a drug potentiator, which I told you, ivacaftor. And now we have two trafficking correctors. They correct the trafficking defect. They correct the trafficking defect. They are trafficking correctors, and the name is Alexa, Alexacaftor, and Teza, and Tezacaftor. So the name is Alexacaftor and Tezacaftor. So these are the new drugs which are CFTR modulators. They are correctors. Okay, available in the US and also available in our country, but they're very costly. They're worth crores of rupees. They're very costly drugs. So we talked about the genetics. Let us talk about the clinical features of cystic fibrosis. Let's take you now to the clinical features of cystic fibrosis. Let us take you to cystic fibrosis clinical features. Clinically. Before I take you to the clinical features, I will take you to the chloride channel. And on your screen, all of you, on your screen, I will show you the typical cystic fibrosis chloride channel. On your screen, I will show you a typical cystic fibrosis chloride channel. Remember, it is a cyclic AMP regulated chloride channel. So remember, CFTR is a cyclic AMP regulated chloride channel. It's a cyclic AMP regulated chloride channel. So sodium on your screen are two channels, a normal and cystic fibrosis. So on your screen you can see two channels, a normal channel on the left and cystic fibrosis. So sodium goes from the lumen to the mucosa, chloride also goes from the lumen to the mucosa. As you can see here, sodium goes from the lumen to the mucosa, chloride also goes from the lumen to the mucosa. Now, because of cystic fibrosis, the chloride channel closes early. Remember, because of the cystic fibrosis, the chloride channel closes early and more sodium goes from the lumen to mucosa. So remember, all of you, more sodium goes from the lumen to the mucosa. More sodium goes. And whenever sodium goes, water goes. So more water goes from the lumen to the mucosa. More sodium goes from the lumen to the mucosa. So the airway lumen secretions become dry. So the airway lumen secretions become dry. Okay, so this brings me to what are the clinical features of cystic fibrosis. So it is all about mucus. The secretions become dry. It is all because of mucus. So in children less than 5 years, the most common manifestation is exocrine pancreatic insufficiency. The most common presentation is exocrine pancreatic insufficiency. So these children get steatorrhea. They get steatorrhea, fat malabsorption. So if a child ever comes to you with foul smelling bulky stools, what will you think of? Cystic fibrosis. So if a child ever comes to you with foul smelling bulky stools, think about cystic fibrosis. So all of you, okay? Okay? So let me ask you a question. I'll show you some NEET PG questions of the last 10 years. So all of you, let us start with this NEET PG question of 2012. My question for all of you is, a 1-year-old girl comes to you with fever, cough, foul smelling bulky stools, 4 attacks of bronchitis in the past, what will you think of if a 1-year-old girl comes to you with fever, cough, foul smelling bulky stools and 4 attacks of bronchitis in the past? Guys, what do you think is the answer? Of course, Dr. Patel is right, cystic fibrosis. So any child, the most common cause of exocrine pancreatic insufficiency, most common cause of exocrine pancreatic insufficiency all over the world is cystic fibrosis. And the treatment is lipase, the pancreatic enzyme supplementation. So the treatment is pancreatic enzyme supplementation. So we supplement these patients with pancreatic enzymes. So treatment is pancreatic enzyme supplementation. Cool? Can you please write cool in the chat box? Can you please write cool in the chat box? Okay, so let's take you to the second and the most important system which is affected in cystic fibrosis, which is called, mostly after 5 years, respiratory. These children get pneumonia. Now remember, these are mucus filled airways. Remember, these are mucus filled airways. ये mucus भरी गलियां है. इन गलियों में normal लोग नहीं जाते, कुछ अलग ही लोग रहते हैं इन गलियों में. So you know, these are different airways, different organisms live in these airways. Okay, so less than 5 years, the most common organism causing pneumonia in cystic fibrosis is Staph aureus, followed by H. influenza. So less than 5 years, it's Staph aureus followed by H. influenza. 5 to 18 years of cystic fibrosis, again Staph aureus followed by Pseudomonas. So as they grow, Pseudomonas starts to increase. As they grow, Pseudomonas starts to increase. And after 18 years and overall, it's Pseudomonas. Mucoid followed by non-mucoid. So this Pseudomonas becomes mucoid in these airways. It undergoes a mucoid transformation. It makes a kavach outside himself and becomes mucoid followed by non-mucoid. Okay. Now remember, they have some specific organisms which can affect cystic fibrosis. There's an organism called Burkholderia capacia. Burkholderia capacia. Remember, it is a very specific organism, only lives in these airways. It causes a fulminant pneumonia. It causes a fulminant pneumonia in these children. It causes a fulminant pneumonia in these patients. Now you should know how do you treat Burkholderia capacia. Remember, the drug of choice for mild Burkholderia capacia is oral cotrimoxazole. Drug of choice for mild Burkholderia capacia is oral cotrimoxazole. Drug of choice for moderate to severe Burkholderia capacia is IV meropenem with a combination of oral cotrimoxazole or doxycycline and even ceftazidime. Remember this third generation cephalosporin, ceftazidime. This organism is also sensitive to ceftazidime also. Very important. Okay, noted. Okay, noted. So let's take you to the next system. Let's take you to the next system affected in cystic fibrosis. So let's from respiratory system, let's take you to the next system affected in cystic fibrosis. And before I go further, all of you, I have a question for you. My question for all of you is this: which is the most common organism in these airways? Anyone in the class? Which is the most common organism in these airways? इन म्यूकस भरी गलियों में कौन रहता है जो सिर्फ इन्हीं गलियों में रहता है और कहीं और नहीं रहता? So which organism stays in these airways? And Dr. Mansi is right. So the fastest student to answer was Dr. Mansi Srivastav. Good. So it's Pseudomonas. Overall, the most common organism in these airways is Pseudomonas, mucoid followed by non-mucoid. Mucoid followed by non-mucoid. Okay, cool. Can we go further? So no, Dr. Priyanka, it's Burkholderia is specific, but it is not the most common. Okay, Dr. Shelja, Dr. Nazir, Burkholderia is specific but not the most common. Let's take you to the other systems affected in cystic fibrosis. Let's take you to the endocrine. So these children after the age of 35 years may get diabetes mellitus. In the GI system, infants may get meconium ileus. Infants may get meconium ileus. So this meconium and mucus blocks the ileum. So this meconium and mucus blocks the ileum. Okay. Okay. Now these children, when they grow older, when they become adolescents, they get a condition called DIOS. So when they become older, they get a condition called DIOS, distal intestinal obstruction syndrome. Distal intestinal obstruction syndrome. Okay, DIOS is distal intestinal obstruction syndrome. So they get pain abdomen and they get distal intestinal obstruction syndrome. So all of you, let me ask you a question. Every NEET PG has a question. So all of you, I have a question for you which came in NEET PG last year, 21. I'll just open the NEET PG 21 folder for you. And my question for all of you is, a 9-year-old boy comes to you with recurrent infections and greasy stools. A 9-year-old boy comes to you with recurrent infections and greasy stools. A 9-year-old comes to you with recurrent infections and greasy stools. What is true for an adolescent with greasy stools and recurrent infections? So all of you are right. Yes, distal intestinal obstruction. Remember, sodium is always less throughout the life in cystic fibrosis. Sodium and chloride is always less, always throughout their life. Okay. Remember, rectal prolapse is nowadays rare. After using the enzyme, the pancreatic enzyme therapy, rectal prolapse has become rare after we have started using the pancreatic enzyme supplementation. So remember, rectal prolapse is rare. Okay? Noted? Noted? Very important. So let's take you to the last system called the genitourinary system. The genitourinary, and remember, men with cystic fibrosis have azoospermia because of congenital bilateral absence of vas deferens. So remember, men with cystic fibrosis have azoospermia because of congenital bilateral absence of the vas deferens and epididymis. So congenital bilateral absence of the vas deferens and the epididymis. Okay, very important. So this brings me to another question. Just came this INICT this year. Let me ask you a question, students, which came in just this INICT exam. Let me see if I have that question with me. Yeah, I have. My question is, this May in INICT exam, the question came to all of you, and the question is, congenital bilateral absence of seminal vesicles and vas deferens is seen in which syndrome? CBAVD, congenital bilateral absence of the vas deferens. CBAVD is seen in which disease? Huh? Are? Okay, yeah, all of you are right. Yes, this is cystic fibrosis. Okay, so remember, they have CBAVD. Okay, so I always tell you this in my exam. So all of you can see two Siddharth Sethi. Let me show you a double role in the class. This is me in the eMedicos app taking the same class. Okay, so I tell this in the eMedicos, very commonly I tell this in the eMedicos. Okay, so this is very common. Okay, you should know this. So all of you should know throughout the life. Okay, throughout the life, maybe I'll just zoom it for you. I'll just zoom it for you. Throughout the life, these children have low sodium. Throughout the life, this is very important. So please note here, I'll just highlight it for you. Throughout the life, hyponatremia, hypochloremia, DIOS, CBAVD, intussusception. So what I am seeing in the last few years is that they have started asking you about the life cycle, that what happens in infancy in cystic fibrosis, what happens in adulthood in cystic fibrosis. So this is the kind of questions they have started asking you nowadays. So as you can see on the right side, that later in their life they can have they may need a liver transplant because of biliary fibrosis and cirrhosis. Please look at ABPA. ABPA is a very important point. This question also came this year in NEET PG, that children with cystic fibrosis may have ABPA, allergic bronchopulmonary aspergillosis. Allergic bronchopulmonary aspergillosis. This is a very important diagram. All of you, can you please write, once you write cool in the chat box, we'll go further. All of you, noted? Noted? Noted, guys? So we said males are mostly infertile. But remember, females may also have fertility issues. So females with cystic fibrosis can also have fertility issues because of mucus in their cervix. So females with cystic fibrosis may also have fertility issues because of mucus in the cervical glands. Very well done. And I'm happy I could cover with all of you important points about all the important stuff for your exam. This is what comes in your exam. This is the pattern of your exam. So let me just tell you the diagnostic criteria for cystic fibrosis. Let us talk about the diagnostic criteria for cystic fibrosis. Diagnostic criteria. So remember, you have a patient who you have a typical case plus the sweat chloride is more than 60 milliequivalents per liter on 2 occasions. Okay, that's cystic fibrosis. If you have a typical case and the sweat chloride shows 60 milliequivalents per liter on 2 occasions, that is cystic fibrosis. End of story. Okay, that's the end of story. Normally it is less than 40. Okay, or so suppose this sweat chloride is not there, it is very equivocal, then you look at 2 known CFTR mutations. Then you look at any 2 known CFTR mutations. Remember, all of you, this single gene CFTR has 1800 mutations. I've just told you one mutation today. But remember, this single gene CFTR has 1800 mutations. So many mutations. 1800. 1800 mutations. Okay, so the single gene CFTR has 1800 mutations. So remember, just delta F does not make you cystic fibrosis. You need to have 2. So my question to all of you is, suppose delta F is negative. Does it mean this child is not having cystic fibrosis, all of you? Suppose delta F is negative. Does it mean this child is not having cystic fibrosis? Suppose delta F is negative. Does it mean he's not having cystic fibrosis? He can still have cystic fibrosis. So suppose mutation also does not give you anything. So now you go to a gold standard. And remember, the gold standard is actually finding either a diagnostic nasal electrode potential difference, finding a diagnostic nasal electrode potential difference, or gene sequencing, or a complete gene sequencing. Okay, or complete gene sequencing. Okay. Okay. Okay, all of you noted? So this is the gold standard. Noted? So I'll just ask you a question, give you a 10-minute break before we go to CVS. So just the last question of this session of the respiratory system is this. My question to you is, it's a child who has a sweat chloride 132, 142, and you're suspecting cystic fibrosis. So which of the following tests can exclude cystic fibrosis? So this is my question to you. How can you exclude cystic fibrosis? Anyone? How can you exclude cystic fibrosis in any patient? That's my question to you. Repeating a sweat chloride, doing a nasal electrode, and all of you are right. A nasal electrode potential difference or a whole gene sequencing. Remember, just one delta F does not give you anything. Remember, one delta F does not give you anything. Okay? It is just 1 out of 1800. So remember, one delta F does not give you the answer. You need to sequence the whole gene, guys, to diagnose cystic fibrosis. You need to have any 2 mutations to diagnose cystic fibrosis. So that brings us to the end of this session on respiratory system. Students, today our plan is something like this. We started with neonatology and we are here. So what we'll do is we'll take a break for 10 minutes and then we'll take you through system in this session. So we will be starting with cardiovascular system in this session, and we'll first, what we do is we will start with the fetal circulation, which is very important for your exams. So we'll start with the fetal circulation, and what I'll do is I will make a sketch on your screen. I like to sketch, so I'll make a sketch on your screen about the fetal circulation. Okay, so I'll make a sketch on your screen about the fetal circulation. About the fetal circulation. Okay, so number 1, remember, this is the placenta which oxygenates the blood during the fetal life. So during fetal life, placenta oxygenates the blood. Unoxygenated blood comes to placenta via 2 umbilical arteries. Via 2 umbilical arteries, the unoxygenated blood comes to the placenta via 2 umbilical arteries. Placenta oxygenates the blood. Okay, it oxygenates the blood. Okay, and it goes via umbilical vein. It goes via umbilical vein to the IVC. Okay, it goes to the umbilical vein to the IVC. Okay, so remember, the oxygenated blood is in the umbilical vein. Remember this, it is in the umbilical vein. Please remember this. Okay, so please remember this. Okay, now remember that there is a liver here. There is liver here. Remember, here is the liver. So umbilical vein joins a channel called ductus venosus in the liver, and so there is a channel here called ductus venosus in the liver, and then it joins the inferior vena cava, and then it joins the inferior vena cava, which joins, of course, the right side of the heart, which of course joins the right side of the heart. Okay. Now remember, the PO2 in the umbilical vein is 30 to 35 millimeters of mercury. The PO2 in the umbilical vein is 30 to 35 millimeters of mercury. And the PO2 in the IVC is 28 to 30. So the PO2 in the IVC is 28 to 30 millimeters of mercury. 28 to 30 millimeters. So remember, this is the oxygen which is going around in the child's body, 28 to 30 millimeters of mercury. Okay, remember this. So remember, fetus lives in a hypoxic environment. A fetus lives in a hypoxic environment, and this is the oxygen he's getting, guys. 28 to 30. That's it. 28 to 30. Okay, that's it. He's getting 28 to 30. Now, superior vena cava joins the right side, and most of the blood goes directly to the right ventricle. Okay, so the superior vena cava blood directly goes, and most of it joins the right ventricle straight away. Okay, this is the pulmonary artery. This is the ductus arteriosus joining the pulmonary artery to the aorta. So all of you, I want to ask a question. Why am I asking you this here? Because in your NEET PG always, you get a question on fetal circulation. What if I ask you a question from NEET PG 2020 on fetal circulation? What if I ask you this question? NEET PG 2020. My question is, in a fetus, highest oxygen is in which vessel? Anyone in the class? In a fetus, highest oxygen is in which vessel? Can you tell me? Shoot. All of you, please shoot your answers. And yes, all of you are right. It's inferior vena cava. So umbilical vein followed by Dr. Priyanka. No, it's umbilical vein has the maximum oxygen followed by inferior vena cava in the fetal life. Okay, that's extremely important. Umbilical vein followed by inferior vena cava. Let's go further. Let's see what happens to the heart once the blood reaches the right side. Now, a part of this blood crosses to the left side, goes to the ascending aorta, goes to the upper part of the body, the brain, and coronaries. So it goes to the upper part of the body, the brain, and the coronaries. Okay, so remember, from the left ventricle, the blood goes to the ascending aorta, goes to the upper part of the body, brain, and coronaries. Okay, let's talk about what happens to the blood. A part of the blood also goes to the right ventricle. A part of the blood also goes to the right ventricle. So can anyone tell me what happens to the blood in your body from the right ventricle? So remember, if we talk about the right ventricle, only 5% of the blood goes to the lungs during fetal life. So remember, during fetal life, only 5% of the blood goes to the lungs. During fetal life, only 5% of the blood goes to the lungs, and the rest, 95%, is shunted to the descending aorta. The rest, 95%, is shunted to the descending aorta. Okay? So remember, rest, 95%, is shunted to the descending aorta. Okay? Okay, descending aorta. Okay? Noted? So the descending aorta blood goes to the lower part of the body of the fetus and back to the placenta. So descending aorta via ductus arteriosus. Descending aorta via ductus arteriosus. So this is a channel, all of you remember, this is a channel which joins the pulmonary artery to the aorta. So descending aorta via ductus arteriosus goes to the lower part of the body of the fetus and back to placenta. Goes to the lower part of the body of the fetus and back to placenta. Okay. Okay, all of you noted? Cool? All of you cool? Cool? Now let's see what happens. So I'll just again repeat for you. From IVC, a part of the blood goes to the left side, ascending aorta, upper part of the body of the baby, brain and coronaries. The blood which goes to the right ventricle, only 5% goes to the lungs, and the rest is shunted back to the descending aorta via ductus. And it goes to the lower part of the body of the fetus and back to placenta. So all of you should all know about ductus arteriosus closures. You should all know about the ductus arteriosus closures. It has two closures, physiological and anatomical. It has two closures, physiological and anatomical. Physiologically, ductus arteriosus closes, remember, within 10 to 15 hours of life because of vasoconstriction. As soon as the child takes his first breath, as soon as the child reaches, the PO2 becomes more than 50. Okay, as soon as the PO2 becomes more than 50, the ductus vasoconstricts. Okay, ductus vasoconstricts. Okay, ductus vasoconstricts. Anatomically, remember that ductus lumen closes forever, according to O.P. Ghai, within 10 to 21 days of life. So remember, anatomically, the lumen closes forever within 10 to 21 days of life. Remember this very important fact. So what we'll do now is we'll talk about acquired heart disorders, we'll talk about congenital heart disorders. Okay, we'll talk about acquired and congenital heart disorders. But before all of this, I will also take you to some cardiac emergencies. And the first important emergency I will talk about is about cardiac arrest. How do we manage cardiac arrest in children? And this, whenever I talk about this, students, I always end up, sharing, whenever we take long classes, we end up talking about ourselves. When I was a PG, guys, when I was a second year PG, there was a PG in medicine. I used to like her. She was a second year PG in medicine. And I always wished, someday I will be on night duty. She will also be on night duty. And I'll just say hi to her, maybe ask her for a coffee. So once it happened, she was on a night duty. And I went to her emergency in the medicine. I said hi. As soon as I said hi, there was a patient who came in the emergency. She started defibrillating him. She said, give me 5 minutes. I'll just defibrillate and come. She went, she defibrillated. She came back. She said, yeah, you were about to say something. I opened my mouth and suddenly another patient came in the emergency and she defibrillated again. So she kept on defibrillating. So that night, I understood that in cardiac arrest, we have to look at whether the rhythm is shockable or not. Which rhythm is shockable? Ventricular fibrillation or a pulseless VT. So which rhythm is shockable? Ventricular fibrillation or pulseless ventricular tachycardia, for which you defibrillate. Now remember, this is more common in adults. बच्चों में होता है, कम होता है. Adults usually die of fibrillation. So yeah, I waited for her that night for 2 hours. She kept on defibrillating patients. I kept on waiting. That was the last time we met. I know she's a cardiologist somewhere. I'll not tell you where she is, but yeah, that was the end of my story. So yeah, all stories are not happy endings. Okay, so real life, I think, I'm not sure. Not many people have happy endings. Anyway, can we talk about something else? So in children, if which rhythm is not shockable, asystole, and which is common in children. So remember, children usually die of asystole, for which we do CPR and IV epinephrine. For which, so remember, whenever, ideally, whenever you do cardiac arrest uh, on the road, ideally you should put a defibrillator. Look at the rhythm. Rhythm is shockable or not. Ideally, this is how you need to approach. Okay, you cannot just blindly just keep on doing CPR and stuff. You need to look at whether the rhythm is shockable or not. So this brings me to a case. This is what how we manage these patients. I'll show you a video where we'll look at the rhythm is shockable or not. Let's look at the rhythm is shockable or not. See what this guy is doing.
Hey kid, you okay? Kid's unresponsive.
So this is a kid unresponsive on the highway. Let's see.
Hey kid, you okay? Kid's unresponsive. He's not breathing. Nurse, call a code. Hey, this kid doesn't have a pulse. Hey, get over here with that AED. I'm starting compressions. You go right to 15 to 2.
Place electrode.
The AED's here.
Place electrode.
That's on him.
Place electrode. Do not touch patient. Analyzing rhythm. Do not touch patient. Analyzing rhythm. Check pulse. If no pulse, give CPR.
Kid's got no pulse.
So did you see the AED? The AED was looking at the rhythm. The AED found the rhythm was not shockable. So AED said continue CPR because the rhythm is not VF or pulseless VT. So this is how you need to approach your patients whenever you go on the highway, and you must be seeing a lot of Netflix series. On highways, a lot of people die on the highway. So please look at the how to resuscitate these patients. Okay, so let's take you further to another cardiac emergency. Before I take you to the cardiac emergency, I have a question for you guys, which will definitely come in your exam. So I have a question for you. This question. A 5-year-old girl, everyone, a 5-year-old girl is unresponsive on the highway and she is pulseless. 5-year-old girl is pulseless. This is the ECG. What is this ECG showing and what is your treatment? A 5-year-old girl is unresponsive on the highway. What will you do? What is the ECG? What is the treatment? unresponsive, pulseless on the highway. You come on. It's not asystole. It is not asystole. Doctor Saab, this is not asystole. On your screen, all of you are wrong, guys. What has happened to you guys? This is ventricular fibrillation on the screen. And for ventricular fibrillation, defibrillate. Okay, so remember, for ventricular fibrillation, defibrillate. So the first dose of defibrillation is 2 joule per kg. If there's no response, you go to 4 joule per kg. And the maximum dose of defibrillation is 10 joule per kg. Okay, so the first dose is 2 joule per kg. The second dose is 4 joule per kg. Okay. Okay. Cool. Cool. So let's take you to, so remember, if it's fibrillation, defibrillate. Okay. That's very important. Let's go further, all of you, and let's take you to another cardiac emergency called tachyarrhythmia. Let's take you to another cardiac emergency called tachyarrhythmia. Tachyarrhythmia, a patient is coming to you with tachyarrhythmia, fast heart rate. You look at the QRS. So first step is to look at the QRS. Whether it is more than 0.09 seconds or it is less than or equal to 0.09 seconds. Okay. If QRS is more than 0.09 seconds, it means the problem is ventricular. It means the problem is ventricular. It can be ventricular tachycardia. So it can be ventricular tachycardia. So you now look at whether the child has cardiovascular compromise or not. Whether the child has cardiovascular compromise or not. What do I mean by cardiovascular compromise? I mean this child is in shock, CHF, or altered mental state. Shock, CHF, or altered mental state. If yes, he's in cardiovascular compromise, now you give him a synchronized electric shock. It's called synchronized cardioversion. Yeah, you give him now a synchronized electric shock. It's a synchronized electric shock with the R wave on ECG. Okay. The dose is 0.5 to 1 joule per kg. If there's no response, you go to 2 joule per kg. If there's no response, you go to 2 joule per kg. If this child is not in a cardiovascular compromise, no, he's stable, the first drug which you'll give him is adenosine. The first drug which you'll give him is adenosine. Okay, noted all of you this limb? All of you, have you noted this limb? Noted? Noted? So today you saw defibrillation is a big electric shock for pulseless VT or VF. Synchronized electric shock is a small dose of electric shock at the R wave of ECG. This is given at the R wave of ECG. It's a small electric shock given during the vulnerable phase of the cardiac cycle. 0.5 to 1 joule per kg. Let's take you to the left limb. Now, QRS is less than 0.09 seconds. Now, all of you, the QRS is less than 0.09 seconds. So, it can be sinus or the most common arrhythmia in children, supraventricular tachycardia. Supraventricular tachycardia is the most common arrhythmia in children. Heart rate is usually more than 180 in older children and more than 220 in infants. Heart rate is usually more than 180 in older children and more than 220 in infants. The P waves are absent or inverted. The P waves are absent or inverted. Okay? P waves are absent or inverted if the QRS is less than 0.09 seconds. So I have a question for all of you. And my question goes something like this. A baby is very fussy. A 3-day-old baby is very fussy. This baby is not taking feeds well. A 3-day-old baby is very fussy, is not taking feeds. Heart rate is 250. For a 3-day-old baby, heart rate is 250. There are no P waves. Heart rate is 250. What will you do? No P waves. QRS is normal. QRS is normal. Yes, all of you are right. This is supraventricular tachycardia. This child is not feeding because he has gone into CHF. Heart, dil bhi kya karta, wo thak gaya. So heart has gone into CHF and he has got unexplained CHF. That is why he's not feeding well. So remember, any patient, any infant, heart rate more than 220, you should get an ECG to look for arrhythmia. This brings me to the treatment of supraventricular tachycardia. How do we treat supraventricular tachycardia? So the first is always a vagal maneuver. So you try to do vagal maneuvers to treat supraventricular tachycardia first. So try to do vagal maneuvers. So carotid massage, Valsalva maneuver. So do carotid massage, Valsalva maneuver. Ice packs over eyes. There are many girls, who go to parlors, put cucumbers on their eyes. Why do girls put cucumbers on their eyes? To stimulate their vagus. So you put ice packs over eyes. Valsalva, carotid massage, ice packs over eyes. Now, if he's still not improving, see whether this child is in cardiovascular compromise or not. What do I mean by cardiovascular compromise? I just now told you. Shock, CHF, altered mental state. Shock, CHF, altered mental state. So if he's sick, yes, he is sick, give him a synchronized cardioversion. If he's stable, you give him adenosine. If he's stable, you give him adenosine. Okay? If he's stable, you give him adenosine. Remember, the first dose of adenosine is 0.1 milligram per kg with a maximum dose of 6 milligrams. If there's no response, the second dose of adenosine is 0.2 milligram per kg with a maximum dose of 12 milligrams. So first dose is 6 milligrams, maximum 0.1 milligram per kg, maximum dose of 6 milligrams. If there's no response, the second dose is 0.2 milligram per kg with a maximum dose of 12 milligrams. If adenosine fails, and this is the question which commonly comes in your exam, if adenosine fails, again you go for synchronized cardioversion. If adenosine fails, again you go for synchronized cardioversion. Okay? Cool? Noted? This algorithm is very useful, I can tell you. Somehow, they will end up reaching the cardiac shock in these patients. Very useful algorithm for you guys. Cool? Can you please write cool in the chat box? Let's take you now to the acquired heart disorders. Let's take you now, all of you, to acquired heart disorders. And I'll show you a child, a very common child in this part of the era. And this is a child, this is a 2-year-old child who came to me with fever, conjunctival inflammation, swollen palms and soles, a rash. So guys, what will you think of if I show you a 2-year-old child with fever, conjunctival inflammation, swollen palms and soles, and a strawberry tongue? What will you think of, guys? If a 2-year-old comes to you with conjunctival inflammation, swollen palms and soles, a rash, and a strawberry tongue. Kawasaki disease, you're right. So let's take you to the most common acquired heart disease in US, Japan, and Chandigarh. Let's talk about the most common acquired heart disease in US, Japan, and Chandigarh. Kawasaki. It is common in US because of awareness. It is common in Japan because Dr. Kawasaki is a Japanese doctor. So there's a lot of awareness. So all of you, let us remember Dr. Kawasaki today. His name is Dr. Tomisako Kawasaki. He died in COVID in June 2020. He lived in a very small city of Japan and he lived for almost 95 years. He described Kawasaki disease in 1967. So remember, Kawasaki is the most common acquired heart disease in US, Japan, and Chandigarh. Most common acquired heart disease in US, Japan, and Chandigarh. Remember, it is the most common medium-size vasculitis in children. Remember, it is the most common medium-size vasculitis in children. Okay? It's a vasculitis in children. Most common, overall नहीं बोला, मैंने कहा most common medium-size vasculitis in children. Why am I talking about Kawasaki disease today? Because of this. On your screen is a coronary angiography. And what can you see? Coronary artery aneurysms. Remember, 20 to 25% of patients of Kawasaki disease have aneurysms. Okay? 20 to 25% of patients with Kawasaki disease have coronary artery aneurysms. Okay? Coronary artery aneurysms. Okay? Okay? Coronary artery aneurysms. Which means thrombus in the coronary. Which means MI. Which means, there can be thrombus in this coronary. It can cause MI. Okay? So thrombus in the coronary can cause MI. Okay, so remember, we are talking about Kawasaki because it can cause MI later in life. It can cause MI later in life. So let us talk about what are the diagnostic criteria of Kawasaki disease. So let us talk about, all of you, the diagnostic criteria, and the most important diagnostic criteria is fever. So Dr. Kawasaki, also told about this in Japan, that these children had unexplained fever for 5 days. Today morning I told you about MIS-C, COVID in children. And they also had, unexplained fever for 3 days when we diagnose MIS-C, multi-systemic inflammatory syndrome in children with COVID. So fever at least 5 days and any 4 of these 5. Fever at least 5 days and any 4 of these 5. Changes in the extremities, acute or subacute. So changes in the extremities, acute or subacute. Erythema of palms and soles, edema of hands and feet, subacute. Remember, this is very important, all of you. This is very important, all of you. This question is asked in your exams, that the peeling of the skin, NEET PG 2016. So 6 years back in NEET PG they asked, peeling of the skin is seen in the 2nd to 3rd week of illness. So peeling of the skin is seen in the 2nd to 3rd week of illness. A polymorphous rash, which is not vesicular, it is not chickenpox. It's a polymorphous rash, which is not chickenpox. Bilateral conjunctivitis, erythema and cracking of lips, with or without strawberry tongue. So they may have erythema and cracking of lips, with or without strawberry tongue. Erythema of the oral and pharyngeal mucosa. Unilateral lymph node. This is very important, guys. Cervical lymph node. This is unilateral mostly. So remember, cervical lymph node is mostly unilateral, more than 1.5 centimeters. So cervical lymph node is mostly unilateral, more than 1.5 centimeters. Okay, noted? All of you please write noted in the chat box. I want 10 people to respond to noted. Then only we'll move to the treatment. How to prevent the aneurysms. So noted. Okay, so you have noted this. Thank you. So now that a lot of you have written noted, let me talk about how do we prevent aneurysms. Okay, so remember, the drug of choice to prevent aneurysms is IVIG. So remember, we prevent the coronary artery aneurysms by a drug called IVIG. So the treatment of Kawasaki disease is IV immunoglobulin, 2 grams per kg. You have to give it during the acute phase within 10 days of illness. So you have to give IVIG 2 grams per kg during the acute phase within the 10 days of illness. It reduces the risk of aneurysms to 4 to 6%. It reduces the risk of coronary artery aneurysms to 4 to 6%. Okay, and you will also give oral aspirin, a very high dose of oral aspirin, which is 100 milligram per kg per day. So you give oral aspirin, which is 100 milligram per kg per day for 2 weeks till fever responds, So we give 100 mg per kg per day for 2 weeks. And we discharge this child on oral aspirin. We discharge this child on oral aspirin. A very low dose oral aspirin, 3 to 5 milligrams per kg per day. So this is what we do in MISSI also. In MISSI also, we discharge all the patients of MISSI on low dose aspirin. Okay. 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 On oral aspirin. Okay. Remember this. Cool. Okay. Now, since we have talked already about Kawasaki disease, let me show you another vasculitis. On your screen, everyone, I will show you another vasculitis from Haryana. So today morning, guys, what happened is a child just got up in Haryana. He just got up in the morning and we found that his lower limbs were full of these palpable purpura. So can you tell me what is this? Child just got up in the morning and his lower limbs, his extensors, his shins were full of palpable purpura. Yes, this is the most common vasculitis in children. Overall, the most common vasculitis in children, Henoch-Schönlein purpura. Now we call it as IgA vasculitis. Now we call it as IgA vasculitis. IgA vasculitis. Okay, so the most common vasculitis in children is Henoch-Schönlein purpura. Now the new name is IgA vasculitis. On your right side is an immunofluorescence of IgA, and you can see IgA deposition. And you can see IgA deposition in the vessels of the dermis. So friends, you can see here deposition of IgA in the vessels of the dermis. Okay? Noted, all of you? Noted? So let us talk about Henoch-Schönlein purpura. So all of you, let us talk about the Henoch-Schönlein purpura. Let us talk about the Henoch-Schönlein purpura. What is HSP? Remember, HSP is the most common vasculitis in children. HSP or IgA vasculitis is the most common vasculitis in children. Okay? Okay? It is the most common small vasculitis, the most common small vessel vasculitis in children. It is the most common leukocytoclastic vasculitis in children. It is the most common leukocytoclastic. What do I mean by leukocytoclastic? Means WBCs are invading the vessel wall. WBCs are invading the vessel wall. Neutrophils especially. Neutrophils, okay? WBCs, by which I mean neutrophils are invading the vessel wall. Okay? Neutrophils are invading the vessel wall. Okay? Noted? So all of you should know what are the diagnostic criteria of Henoch-Schönlein purpura. So all of you should know what are the diagnostic criteria of Henoch-Schönlein purpura. So remember, now we follow the Euler criteria. Now we follow the latest classification. The diagnosis of HSP is by the Euler criteria. Euler. What is Euler? You need to have palpable purpura. Any patient, any child or adult, it can even be seen in adults, any child or adult with palpable purpura without coagulopathy or thrombocytopenia. So there is no bleeding, there is no petechiae. So palpable purpura without DAC, just a healthy child, got up with palpable purpura, and one of these. Okay, what are these? Pain abdomen, arthritis, pain abdomen. This is the typical diffuse colicky pain abdomen, which is because of mesenteric ischemia. So students, this question came in NEET PG 2016. This pain abdomen is because of mesenteric ischemia. Arthritis or arthralgia. And the biopsy shows IgA deposition. And the biopsy shows IgA deposition. The biopsy shows IgA deposition. Okay. You may have kidney involvement in the form of hematuria, proteinuria. So kidney can be involved in the form of hematuria, proteinuria. Noted? All of you? Noted? Anyone? Have you noted this down? Okay. So let us talk about how do we treat Henoch-Schönlein purpura. Let's talk about, this is not a cardiac disease, but since we are talking about vasculitis, I am talking about HSP here. So how do we treat HSP? And I would like to call it as IgA deposition or IgA vasculitis. So how do we treat? Usually the treatment is supportive care. We don't give steroids usually. But remember, these patients may get HSP nephritis. What do I mean by HSP nephritis? Remember, 30 to 50% of these children may get HSP nephritis within 6 weeks of disease. Within 6 weeks of disease, 30 to 50% of these patients may get HSP nephritis. Okay, and what do we see? Some microscopic hematuria, some RBCs in the urine, with or without proteinuria. So some RBCs in the urine plus minus proteinuria. Okay, plus minus proteinuria. RBCs with or without proteinuria. Now remember, if this child has got nephrotic range proteinuria, a lot of protein in the urine, nephritic picture, we give oral prednisolone. We give oral prednisolone. So all of you should know what do we see in the biopsy of HSP? What do we see in the kidney biopsy of this child who's got HSP? So all of you remember on your screen what I'll show you a glomeruli, and all of you I'll show you that within the capillary loops, can you see a lot of these pinkish cells? Can you see this? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Can Can you see a lot of these pink cells? They're mesangial cells. So please write in the chat box. HSP is a mesangial-proliferative disease. Mesangial cell proliferation. And on your screen is an immunofluorescence. And you can see IgA is deposited in the mesangium. Remember, IgA is deposited in the mesangium. Okay, so remember, IgA is deposited in the mesangium. Remember the word mesangium. Okay, now very rarely 1 to 2% of these patients may get a rapidly progressive glomerulonephritis, RPGN. We call it as rapidly progressive glomerulonephritis. What do I mean by rapid progression? It means that there is a rapid deterioration of the kidney function over days to weeks. So there is a rapid deterioration of the kidney function over days to weeks. And on the biopsy, we see crescents. So if you see crescents, we give high dose steroids for it. So if you go for crescents, we go for high dose steroids, IV methylprednisolone. For crescents, we give IV methylprednisolone. Okay? Noted? Okay? Noted? So on your screen, I will show you a crescent. On your screen is a glomeruli, and can you see this glomeruli is, encircled by a fibrocellular crescent. So there are some cells, there's some fibrous tissue also. So this is a typical crescent. This glomeruli is encircled by a fibrocellular crescent. What are crescents actually? They are proliferation of the parietal epithelial cells. So remember, crescents are proliferation of parietal epithelial cells. Okay, so let's go further and let us ask you a question which came in NEET PG this year. My question to all of you. This is the question for all of you. 11-year-old boy has palpable purpura and pain abdomen. What is the treatment? Anyone in the class? An 11-year-old boy has palpable purpura and pain abdomen. What is the treatment? And all of you are right. If this cell has got, severe pain abdomen. So remember, we give steroids for severe pain abdomen. Nephrotic picture. So if you have a nephrotic kind of lot of protein in the urine, nephrotic picture, we give oral prednisolone. So I see a lot of these children these days from North India, severe pain abdomen, nephritic picture, we give them prednisolone. Okay. Chaliye, let's go further and let us take you now to more acquired heart disorders. And let us talk about India, guys. Why are we not talking about India? We talked about, everywhere in the world, but now we will be talking about India. And the most common acquired heart disease in India is rheumatic. The most common acquired heart disease in India is rheumatic. Rheumatic, is caused by group A beta hemolytic streptococci. So remember, rheumatic fever is caused by group A beta hemolytic streptococci. Strain M, group A beta hemolytic streptococci. Strain M, type 135618. Type 135618. Okay, type 135618. Okay, type 135618. Okay. Okay. Okay, noted. It occurs after 3 weeks of a sore throat. So it occurs after 3 weeks of a sore throat. It's common after 5 years in areas of low socioeconomic status, overcrowded areas. So it occurs after 3 weeks. So remember, what happens in these 3 weeks is an autoimmune process. One of the postulation is molecular mimicry. So one of the postulation is molecular mimicry. So our body attacks the myocardial protein instead of the strep M protein. Our body attacks the myocardial protein. So the drug of choice is anti-inflammatory drugs for 12 weeks. High dose aspirin or prednisolone for 12 weeks. So remember, the drug of choice is high dose anti-inflammatory drugs for 12 weeks. Okay, high dose anti-inflammatory drugs for 12 weeks. Aspirin or prednisolone. Aspirin or prednisolone. Okay. So remember, all of you, actually 2015 there were new Jones criteria. They were modified. The Jones criteria were modified in 2015 because of two reasons. Number one, now we divide the areas into risk areas. Now we divide the areas into risk areas, low risk or high risk. Now we define areas as risk areas, low risk, high risk. Okay, like India is a high risk, America is a low risk. Number B, now is the era of echocardiography. So nowadays cardiologists, their stethoscope is echo. So now we have a new major criteria called subclinical carditis. So now we have a new major criteria called subclinical carditis. So if a cardiologist based on echo says this child has subclinical aortic regurgitation, subclinical mitral regurgitation. So based on, if clinical criteria and echocardiography criteria. Okay. So we say this is a major criteria. So all of you, now we have a new major criteria called subclinical aortic regurgitation or mitral regurgitation. A subclinical criteria. Okay. Okay. So let us talk about what are the new Jones criteria in the low risk and the high risk. So now all of you remember, now we classify areas into low risk or high risk. So what are low risk areas? Let us talk about what are low risk areas. So low risk areas for rheumatic fever are areas where acute rheumatic fever incidence is less than 2. Areas where acute rheumatic fever incidence is less than 2. per 1 lakh school population. Okay. Or the prevalence of the RHD is less than 1 per 1,000 population per year. So the prevalence of RHD is less than 1 per 1,000 population per year. Okay, incidence of acute rheumatic fever or prevalence of RHD is less than 1 per 1,000 population per year. Okay, noted? Okay, so let us talk about what are the Jones criteria in the low risk and the high risk areas. So first of all, we will be talking about the Jones criteria in the low risk areas. Let us talk about the Jones criteria in the low risk population, like America. So whatever I am writing in red stars is new. So remember, the new major criteria in the low risk population is subclinical carditis based on the echocardiography. It is subclinical carditis based on the echocardiography. Okay, based on the echocardiography. Carditis, polyarthritis, chorea, erythema marginatum, and subcutaneous nodules. Okay. Okay. Noted? Major criteria in the low risk. Cool. Let us talk about the minor criteria in the low risk population. Let us talk about the minor criteria in the low risk population, like America, polyarthralgia. So polyarthralgia, fever, the definition is 38.5. So fever, the definition is 38.5 degrees Celsius. ESR is 60 and CRP more than 3 milligrams per deciliter and or CRP more than 3 milligrams per deciliter. Prolonged PR interval as per age. So we look at the prolonged PR interval as per age. Okay. Prolonged PR interval as per age. So if you have taken carditis above, you don't take, PR interval below. Okay. If remember, if you have taken carditis above, you don't take PR interval below. Okay. Very important. Can I go further? To the high risk population. Okay, let us talk about the major criteria in the moderate and the high risk population. Let us talk about the major criteria in the moderate and high risk population. Major criteria. So whatever I'm highlighting in red is important. These are the new ones which were added, like subclinical carditis. Monoarthritis is a new major criteria in India. Say, for example, India, overcrowded place. Polyarthalgia is a major criteria. Okay, rest are the same as we know. Rest is the same. Can we go to the minor criteria in the high risk population? Let's take you to the minor criteria in the high risk population. Again, monoarthralgia is a minor criteria. Polyarthralgia is a major criteria in the moderate and high risk population. Monoarthralgia is a minor criteria. Fever 38. ESR is 30 in the high risk, 60 in the low risk. So ESR is 30 in the high risk, 60 in the low risk. With or without CRP of 3. Prolonged PR interval. Okay, noted. Noted, all of you? Cool. So remember, you need 2 major or 1 major plus 2 minor criteria. 2 major or 1 major plus 2 minor to call it as a rheumatic fever. 2 major or 1 major plus 2 minor to call it as rheumatic fever. So we have already discussed with you how do we treat rheumatic fever. We'll now concentrate more on prevention. Yes, subclinical carditis is a major criteria in both population. Low may be, high may be. So let me just write for you. I just told you that the treatment of rheumatic fever is bed rest till all the acute phase reactants subside. We give aspirin high dose 100 milligram per kg per day or prednisolone or oral prednisolone for 12 weeks. Both of them are for 12 weeks. But remember, oral prednisolone is only given if there is a severe heart involvement, a severe carditis or CHF. So oral prednisolone is only given if we have severe heart involvement or CHF. Okay. Okay. Now, how do you prevent? Let's talk about prevent. Before that, remember one more point. Remember, in treatment of rheumatic fever, also we give crystalline penicillin G for 10 days. But this is not for prevention. This is basically because he's colonized. His throat is colonized with 1, 3, 5, 6, 18. His throat is colonized. So, for this, we need to give him, eradicate the colonization to prevent the spread. So this is basically given for the colonization, not for treating the sore throat, which has already happened 3 weeks back. Remember, if he's allergic to penicillin, we will give macrolides like erythromycin. So if he's allergic to penicillin, we give macrolide like erythromycin. Okay? Remember this. Let's go further and talk about prevention of rheumatic fever. Let's talk about prevention. Can we prevent rheumatic fever? So remember, prevention of rheumatic fever is of two types: primary and secondary. Primary means, before it happens, primary, which means, you have sore throat like I have, you do a throat swab, isolate streptococci, and to every streptococcal sore throat, you give penicillin. You give crystalline penicillin. Within 9 days of illness, remember, it has to give, antibiotics should be given within 9 days, and then you can prevent rheumatic fever. Now, what is secondary prevention? In India, we believe in secondary prevention, like we eradicated COVID by कि हम सबको हो गया. We don't believe in primary prevention. So secondary prevention is for high risk individuals. It's for high risk individuals. So if an individual has got already once a rheumatic fever, he is at risk of recurrence. So if a child is at risk of rheumatic fever, he is at risk of recurrence. Okay. So to children who are at risk of recurrence, we give them a longer acting penicillin called benzathine penicillin. So children who are at risk of recurrence, we give them a longer acting penicillin called benzathine penicillin. 6 lakh international units for children less than 60 pounds. So this is secondary prevention. एक बार हो गया. Once he had. So now you give 6 lakh international units for children less than 60 pounds, or 1.2 million units for children more than 60 pounds. Okay, or 1.2 million units for children more than 60 pounds. Every 4 weeks in the US, and 3 weeks in the developing countries. So we give this injection every 4 weeks in the US and every 3 weeks in the developing world. Every 3 weeks in the developing world. Okay. Okay. Intramuscular injection. Also, you can also give oral penicillin V or oral sulfas. So you can also give oral penicillin V or oral sulfadiazine or sulfasoxazole for prevention. So you can also give oral penicillin V or oral sulfadiazine or sulfasoxazole. Noted? Noted? Now the question is still how long? Remember, if he's allergic to penicillin or sulfas, we give macrolides. Remember, if a patient is allergic to penicillin or sulfas, we give macrolides. Noted? So the question is for how long? This injection will be given every 4 weeks in US, every 3 weeks in India. For how long? Can you please write in the chat box, guys? Okay, so let's talk about the duration of antibiotics. So remember now, according to the American Heart Association, there are specific guidelines for the duration. Let us talk about the duration, very important. If a child has just got joint involvement, heart involved नहीं हुआ, only joint involvement. So he has got rheumatic fever without carditis. So we give it for 5 years or till 21 years of life, whichever is longer. So we give it for 5 years or 21 years of life, whichever is longer. Okay, remember this word, whichever is longer. Number 2, if he has got reversible carditis, heart में reversible lesion, reversible carditis, 10 years or 21 years of life, whichever is longer. Okay, whichever is longer. If he has got permanent lesion in the heart, residual MS or MR, so suppose he has got residual mitral stenosis, residual mitral regurgitation. So if he has got a permanent lesion in the heart, a residual MS or MR, 10 years or 40 years of life, whichever is longer. Ideally lifelong. If someone has mitral stenosis, he should be on lifelong prophylaxis. Okay, cool? All of you, if you write cool 10 times, 10 of the students respond, I'll take you to a NEET PG question which came this year. So remember, no heart involvement, reversible carditis, irreversible carditis. There are different durations for no heart involvement, reversible, irreversible carditis. Okay, so this brings me to a question which came in NEET PG this year, guys. Let's take you to the NEET PG question of this year. So this question came in NEET PG this year. 11-year-old boy has fever and sore throat. Heart is normal. How long will you give him benzathine prophylaxis? Which is the closest answer? 11-year-old child has sore throat, fever, heart is normal. How long will you give him benzathine prophylaxis? Which is the closest answer? Which is the closest answer? If heart is not involved, how long should we give this injection? You're right. The first option is the most probable answer. And all of you, I've been teaching this in DAMS since last 20 years. This is me on the eMedicos app. And all of you, can you see a double roll here? I'm here. I'm here. So you can see two Siddharth here on the same screen. So I always tell, if heart is not involved, 5 years or 21 years. So ideally, you should have at least two. Okay. So this is a better answer actually. 5 years or at least till 18 or 21 years of life, whichever is longer. Remember, whichever is longer. So this brings me to congenital heart disorders. We'll not take a break now. Okay, we will not take a break now. Class will be till around 9:10. Okay, let's start congenital heart disorders and how do we classify congenital heart disorders. Let's talk about congenital heart disorders and how do we classify congenital heart disorders. So remember, congenital heart disorders are of two types, acyanotic and cyanotic. So let us first start with acyanotic congenital heart disorders. Let us first start with A, cyanotic, in which there is no cyanosis. Remember, most of the acyanotic defects are left to right shunts. So remember, most of the acyanotic defects are left to right shunts. Okay, left to right shunts of the heart. Which can be at the level of atrium, ventricle, or ductus. So they can be atrial septal defect, ventricular septal defect, or patent ductus arteriosus. So they can be ASD, VSD, or PDA. So they can be ASD, VSD, or PDA. So what are the clinical features of acyanotic defects? So here is a child who is not thriving well. Mother says, Dr. Saab, my child is not thriving well. He has a history of failure to thrive. Now, because of the left to right shunt, the pulmonary blood flow is increased. The pulmonary blood flow is increased because of the left to right shunt. Remember, in the lung there is plethora. So remember, the pulmonary blood flow is increased. So they have failure to thrive, these children, because of the increased blood to the lungs. They get recurrent pneumonia. Feeding difficulties. Now, this feeding difficulties, we call it as diaphoresis. Feeding difficulties is also called diaphoresis. What do I mean by diaphoresis? So I mean by diaphoresis, I mean that this child is in CHF. So he sucks for a while, he gets tired, he takes rest. Again he starts sucking. So इसकी माँ बोलती है डॉक्टर साहब मेरा बच्चा तो दूध ही पिए जाए सारा दिन डॉक्टर साहब थोड़ी देर दूध पिए फिर उठे फिर दूध पिए. So he has this suck rest suck cycle. And this child typically comes to us with CHF at this age 6 to 10 weeks of life. So this is the typical time, guys, when this child come to us with CHF at 6 to 10 weeks of life. 6 to 10 weeks of life. Okay. 6 to 10 weeks of life. So all of you, now this brings me to cyanotic heart defects. The second type of heart disorders which we'll talk about are cyanotic. Let us talk about cyanotic heart defects. Cyanosis. Now cyanosis can be further classified based on the pulmonary blood flow. Based on the pulmonary blood flow, we can classify cyanosis into those children who have increased pulmonary blood flow or those children who have reduced pulmonary blood flow. Increased pulmonary blood flow is called plethora. Reduced is called oligemia. So the first example of cyanosis with increased pulmonary blood flow, the first example is truncus arteriosus. Truncus arteriosus. What is truncus? It's a single vessel above our heart. So truncus arteriosus is a single vessel above our heart. So there is no differentiation into aorta or pulmonary artery. It's a single vessel above our heart. There is no aorta, no pulmonary artery. Okay, no aorta, no pulmonary artery. So all the blood gets mixed, cyanosis. Aorta's blood goes to the lungs, plethora. The second example is TGA plus VSD. In fact, students, 3 weeks back in your INICT exam, this question came in the INICT exam 3 weeks back. The question was, which cyanotic heart disease has plethora? This question came in INICT exam 3 weeks and the answer was TGA. The third example is TAPVC, totally anomalous pulmonary venous connection. So the pulmonary venous connection is totally anomalous. So can I just take you to another page for a while and we'll come back to this algorithm. So remember, in total anomalous pulmonary venous connection, the pulmonary veins are anomalous. Totally anomalous pulmonary venous connection. Totally anomalous pulmonary venous connection. So this is our heart, all of you, the left and the right. Superior vena cava, inferior vena cava, coronary sinus behind the heart. This is the portal vein draining into the IVC. This is the diaphragm. Now, the pulmonary venous connection is totally anomalous. It's totally anomalous. So the pulmonary veins may join the superior vena cava when we call it as supracardiac, where the pulmonary veins join the superior vena cava. They may join the coronary sinus when we call it as cardiac, or they may go down the diaphragm and they join the portal vein, which is called infracardiac TAPVC, which is called infracardiac TAPVC. So remember, TAPVC is mostly of 4 types: supra, cardiac, or infracardiac when they go down to the diaphragm and they join the portal vein. All the blood gets mixed. Cyanosis. So much of blood is going to the lungs. Plethora. Now remember, how do these children survive? Remember, all of these children have a right to left shunt at the level of atrium. That's how they survive. Remember, all of these children survive because they have a right to left shunt at the level of atrium. That's how they survive. They have a right to left shunt at the level of atrium. So students, I've been seeing that there are a lot of questions coming up in your exams on X-rays and on physiology. So let me ask you a question which came in the INICT exam. in November, 1 year back. I have a question for you. Just give me 1 second. I'll show you a question. November 2021. The question goes like this. In which congenital heart disease all the chambers of the heart have same oxygen saturation? Anyone in the class? In which congenital heart disease all the chambers of the heart have same oxygen saturation? Anyone? In which congenital heart disease all the chambers of the heart have same oxygen saturation? So actually, if you look closely in TAPVC, all the chambers of the heart have the same oxygen saturation. On your screen is a supracardiac, pulmonary veins are joining the superior vena cava, and all the chambers of the heart have same oxygen saturation, 85%. So the answer of this question is all of you are right. Yes, you guys are amazing. And Dr. Coyle was the fastest finger here. You are right. TAPVC. All chambers of the heart have same oxygen saturation. Now remember, the most common TAPVC 50% of the times is supracardiac. In which heart has a figure of 8 appearance, or a snowman's heart, or a cottage loaf appearance. So in supracardiac is the most common, in which the heart has a figure of 8 appearance, a snowman's heart, or a cottage loaf appearance. Figure of 8, snowman, or cottage loaf. So this reminds me of another question which came last year in your NEET PG 21. So all of you, I'll show you a question which came in NEET PG 21. Here is the question on your screen, guys. Shoot your answers. Last year in the NEET PG, this question came. A 12-year-old boy has cyanosis. Here is the X-ray. A 12-year-old boy has cyanosis. Here is the X-ray on your screen. So can anyone tell me the diagnosis? And everyone is right. You guys are amazing. You're right. Supracardiac TAPVC has a snowman's heart. Supracardiac. So this is a snowman's heart, or a figure of 8 appearance. So this is a snowman, or like a, Christmas is coming. A snowman or a figure of 8 appearance. Everyone in the class is right. Supracardiac TAPVC. Remember, the most severe TAPVC, which can present with cyanosis at birth, is infracardiac, because the pulmonary veins get obstructed here. So remember, the most severe TAPVC, which can present with cyanosis at birth, most severe TAPVC which can present with cyanosis at birth is infracardiac, because the pulmonary veins get obstructed here. So because of the obstructive pulmonary venous hypertension, infracardiac is the most severe. Where the X-ray looks like a ground glass, it looks like a ground glass or a white out, because of pulmonary venous hypertension. So please remember, in infracardiac, the X-ray looks like a ground glass or white out or obstructive pulmonary venous hypertension. Okay. Noted? All of you, have you noted this? Noted? So you should remember, all of you, in your exam, they may show you two types of x-rays like this. On one side, you may have a snowman's heart. So remember, snowman's heart is supracardiac. But if they show you a whiteout lung, if they show you whiteout ground glass lungs, it's infracardiac. Okay? Infracardiac is whiteout ground glass appearance. Okay, infracardiac is whiteout ground glass appearance. Okay, cool? Remember this. So let's take you back to the algorithm of classification. I'm sorry, I took you to TAPVC for a while, but let's take you back to the algorithm of classification. Now, oligemia will further divide it into children who have massive cardiomegaly, Remember, left ventricular hypertrophy with cyanosis is seen in tricuspid atresia. Left ventricular hypertrophy with cyanosis is seen in tricuspid atresia. And a very big heart, a box or a balloon-shaped heart, a massive heart, is seen in Epstein's anomaly. So these were some of the options also in the INICT exam 3 weeks back. Okay. Okay. So 3 weeks back, there was a match the following. Remember, Epstein's has a massive heart because of the maternal lithium. So if mother takes lithium in the pregnancy, it causes Epstein's anomaly in the baby. And in fact, 3 weeks back in your INICT exam, there was a match the following. Maternal lithium, Epstein's anomaly. Maternal thalidomide. So there was a drug which was initially used for morning sickness in pregnant females. Thalidomide. It used to cause phocomelia. So thalidomide used to cause phocomelia. Okay. Remember this. Now let's take you to oligemia. Before this, remember they have a massive heart. I have to show you a massive heart of Epstein's anomaly, and on your screen is a massive box or a balloon-shaped heart of Epstein's anomaly. So remember they have a box or a balloon-shaped heart of Epstein's anomaly. Okay? Okay? Remember this. Massive heart. A box or a balloon-shaped heart. Let's take you to oligemia. Okay? 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 Oligemia is seen in Fallett's physiology. That's called Fallett's physiology. So this can be tetralogy of Fallett. TOF means tetralogy of Fallett. TOF means tetralogy of Fallett. Double outlet right ventricle plus pulmonary stenosis. Okay. Double outlet right ventricle plus pulmonary stenosis. Okay. TGA with VSD with pulmonary stenosis. TGA with VSD with pulmonary stenosis. Single ventricle with pulmonary stenosis. Single ventricle with pulmonary stenosis. Okay, single ventricle with pulmonary stenosis. Okay. Okay, noted all of you? So remember, this is called Fallett's physiology, where you have tetralogy of Fallett, DORV with pulmonary stenosis, TGA with VSD with pulmonary stenosis, single ventricle plus pulmonary stenosis. Okay, remember this. So let's just talk about tetralogy of Fallett, the most common cyanotic heart disease worldwide. Overall, okay, tetralogy of Fallett, the most common cyanotic heart disease worldwide, and after the first year of life. Okay, most common cyanotic heart disease after the first year of life and worldwide. Cyanosis. So there are 4 points. It's a subvalvular pulmonary stenosis. It's a subvalvular pulmonary stenosis. Subvalvular. So it is, this stenosis is below the pulmonary valve. It's subvalvular. Right ventricular hypertrophy. So suppose I draw a heart for you. This is pulmonary stenosis. Because of this, there is right ventricular hypertrophy. Now, number 3, aorta is overriding the septum. Aorta septum के ऊपर है. So remember, overriding of aorta. Aorta is overriding the septum. Okay. Aorta is overriding the septum. And lastly, because of this pulmonary stenosis, right ventricular pressure increases. Right ventricle का pressure बढ़ गया because of pulmonary stenosis. Now it, okay. Okay. So the shunt becomes right to left. Okay. 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 So right ventricular pressure increases. It is more than the left side. And the shunt becomes right to left. Okay. So remember, there is a perimembranous VSD. So now there is a perimembranous VSD. Okay. Perimembranous VSD. Okay. Okay. So right to left means cyanosis. Impure blood goes to the system X. There is pulmonary stenosis, so there is reduced pulmonary blood flow. Okay. So remember, during infancy, these children with tetralogy of Fallot during infancy, they have cyanotic spells or tet spells or hypopneic spells. Okay. Okay. Or hyperpnic spells. So this child suddenly becomes, breathless, suddenly becomes more cyanosed, and this child has a history of increased squatting. So this child has a history of increased squatting. He squats on the floor. So you should all know how do we treat a spell. Suddenly he becomes more breathless. Remember, clinically it has been seen on examination. During the time of the spell, the systolic murmur of tetralogy of Fallot disappears. So you should all remember, during the time of the spell, the systolic murmur of tetralogy of Fallot disappears. How do we treat a spell? By giving oxygen, by giving intravenous sodium bicarbonate, we give subcutaneous morphine, we give intravenous propranolol. Remember, intravenous propranolol reduces the pulmonary cyanosis. Intravenous propranolol reduces the pulmonary cyanosis. And lastly, now we do maneuvers which increase the systemic vascular resistance. So now we do maneuvers which increase the systemic vascular resistance. Okay. So we put him in a knee chest position. Like squatting is a knee chest position. So we put him in a knee chest position. We give him intravenous ketamine, phenylephrine. So we give him intravenous ketamine, intravenous phenylephrine. We do all of these things together. So we go for intravenous ketamine, intravenous phenylephrine. Okay. Okay. So this is very important, all of you. I have a question for you. Noted? This question came in NEET PG. It's a favorite of NEET PG examiners. So I'll ask you this question because it is a favorite of NEET PG examiners. And here's the question. We manage cyanotic spell by all except. Anyone? We manage cyanotic spells by all except. You're right. Everybody is right. Okay, everyone is right. You're right. Lovely. So remember, all of you, calcium has no role in the pathogenesis of a spell. Calcium has no role in the pathogenesis of this child's spell. Now remember, the X-ray of this child, it looks like a boot. This question came every time, in the NEET PGs. I will not show you those questions. It's common. So the X-ray shows a boot. And on your screen, I'll show you a boot. This is called coherence abort. So X-ray of tetralogy of Fallot shows a boot. It's called coherence abort. So this is, I'll ask you, what causes the boot? In your exam, they may ask you, what causes the boot? So remember, right ventricular hypertrophy. Right ventricular hypertrophy causes the boot. It causes uplifting of the apex. Right ventricular hypertrophy causes uplifting of the apex. It causes the boot. Okay. Now initially all of you, right ventricular hypertrophy. Now remember initially all of you, this child is getting recurrent spells. This child is getting recurrent spells. Okay. Recurrent spells. So to improve the pulmonary blood flow, we join the subclavian to the pulmonary artery. Okay, this is the most commonly done palliative shunt in these children. We join the subclavian to the pulmonary artery. This is called the Blalock thoracic shunt. Okay, so we anasmose the subclavian to the pulmonary artery. Initially, we used to join end to side, but nowadays, we don't join them end to side. We put a Gore-Tex tube in between. Gore-Tex, G-O-R-E-T-E-X. We put a Gore-Tex tube in between them, and we call it as a modified Blalock thoracic shunt. So we call it as a modified Blalock thoracic shunt. We have put a Gore-Tex tube between the subclavian and the pulmonary artery. This improves the pulmonary blood flow. Okay. Okay, all of you, let's just remember this. So all of you, the next half of the class, I will be taking you to neurology. I'll be taking you to epilepsy. Okay. Okay. So what is epilepsy? Let's talk about what is epilepsy. Remember, let's take you to neurology. So a seizure is abnormal electrical activity of the brain. A seizure is abnormal electrical activity of the brain, and epilepsy is recurrent, at least 2 unprovoked seizures. At least 2 unprovoked seizures, 24 hours apart. Okay, we need recurrent 2 unprovoked seizures. Okay, 24 hours apart. Okay, beyond the neonatal period. So we define epilepsy as recurrent, at least 2 unprovoked seizures, 24 hours apart, beyond the neonatal period. Beyond the neonatal period. Okay, beyond the neonatal period. Okay. Okay. So let's talk about, according to the International League Against Epilepsy, how do we classify epilepsy and how do we treat epilepsy. So according to the International League Against Epilepsy 2017, so remember in 2017, according to the International League Against Epilepsy, we classify it into focal or generalized onset. Focal or generalized onset. Focal onset, on one side it is happening. It can be simple, no loss of consciousness. So it can be simple focal seizure, no loss of consciousness, or it can be a complex focal. In complex focal, there is loss of consciousness. So remember, in complex focal, okay, okay, there is loss of consciousness. You can have an aura. A child may, he may have some premonition that he's about to get a seizure, automatisms, maybe involuntary orofacial movements. So drug of choice for focal onset is oxcarbamazepine and carbamazepine. So remember, the drug of choice for focal onset epilepsy in children is oxcarbamazepine and carbamazepine. The drug of choice, what is generalized onset? It can be tonic, increased tone. It can be tonic, clonic. Clonic matlab rhythmic movements. Okay. Okay. Atonic matlab sudden loss of tone. Spasm. Okay. Myoclonic. Matlab sudden myoclonic, jerks of the muscles. So remember, according to the Nelson's textbook, the drug of choice for generalized onset epilepsy is levetiracetam. So now the Nelson's textbook has also changed. Drug of choice for generalized onset epilepsy is levetiracetam. Okay, followed by valproate. Levetiracetam followed by valproate. Okay. Noted? All of you, maybe 5 of you, if you tell me you have noted, we'll go further. So what I'll do is I'll show you a girl from my state and tell me what she's doing. We are asking her to hyperventilate and see what she's doing. On your screen, I'll show you a girl from my state, Haryana, and here she is.
Excuse me, ma'am. इस तरह होती है जी. I'll go on. जोर से करो. जोर से करो. जोर लगा के, जोर से. अरे नहीं रुकना ना. रुकोगे तो सारा गड़बड़ हो जाएगा.
Can you see she just got a blank stare lasting for a few seconds when we were asking her to hyperventilate? When we were asking her to hyperventilate, she gave a blank stare lasting for a few seconds. Okay, that's a typical absence seizure. There's no aura, no postictal phase, just a blank stare lasting for less than 30 seconds. No aura, no postictal phase, just a blank stare lasting less than 30 seconds. Okay, so remember, on your screen we'll show you the typical EEG of absence seizures, and I'll tell you this in the DVT also. So this is a typical EEG of absence seizures all over the brain, generalized. You can see generalized 3 Hertz spike and wave pattern, 3 per second. all over the brain, journalized, 3 per second. Every second there are 3 spikes and wave pattern. Journalized 3 hertz spike and wave pattern is absent seizures. Okay, generalized 3 hertz spike and wave pattern is absent seizures. Remember this. Okay, let's take you further. Show you another child. Remember, the drug of choice for absent seizures is always ethosuximide. So remember, the drug of choice for absent seizures is always ethosuximide. Let's show you another child and tell me what's he doing. I'll show you 2 children doing, 2 infants doing abnormal movements. I'll show you 2 infants doing abnormal movements.
And his eyes kind of went blank. And it scared us. Zachary would have a cluster of seizures that would last for a total of 5 minutes. And his eyes kind of went blank. And it did scare us. Zachary would have a cluster of seizures that would last for a total of 5 minutes. And his eyes kind of went blank. And
so can you see this child is having clusters of bilateral flexor symmetrical contractions. Bilateral flexor symmetrical contractions. These are called infantile spasms. These are called infantile spasms. Bilateral flexor symmetrical contractions. I can show you one more child doing the same. See, I will show you one more child. Suddenly, bilateral, like a salam. He's doing like a salam. Bilateral flexor symmetrical contractions are called infantile spasms. They're looking like a salam. Okay. So remember, they are called infantile spasms, which occur in infants. Okay, so remember, infantile spasms are only seen in infants, like the name suggests. They're also called salam. They occur in infants between 4 to 8 months. They occur in infants between 4 to 8 months of life. Okay. So you saw they were bilateral, symmetrical. They were looking like a salam, mostly flexor. Now remember, there is a syndrome called West syndrome. It's a triad of the typical EEG, hips arrhythmia, mental retardation, and infantile spasms. West syndrome is a typical EEG, mental retardation, and infantile spasms. Now, EEG is very classic of infantile spasms. So what I'll do is I'll show you a typical EEG of this child, all of you. I'll show you a typical EEG of this child of infantile spasms. So all of you, what you can see on the screen is generalized chaos. So all over the brain, you can see chaotic pattern of high voltage slow waves. So all over the brain, you can see chaotic pattern of high voltage slow waves. Okay. Hips arrhythmia. All over the brain, there are high voltage slow waves, generalized high voltage chaotic slow waves called hips arrhythmia. So remember, hips arrhythmia is the classic EEG which is seen in these children. And this is a very common MCQ these days. The drug of choice for infantile spasms is ACTH. Only for infants with tuberous sclerosis, the drug of choice is a drug called oral vigabatrin. Only for infants with tuberous sclerosis, the drug of choice is oral vigabatrin. Okay, please remember this. Okay. Okay, please remember this. Okay, let's show you another child, all of you, on your screen. What I'll do is I'll show you a girl, and you have to tell me, this adolescent girl is coming to you, talking to you, and you have to tell me what is she talking about. Okay, so a young girl, I'll give the stage now to a young girl. She will talk to you. Tell me what she's talking about.
Figured it's good time. Just woke up from a nap and figured it's good timing. Well, not good timing, it always isn't. It's never good timing for myoclonic seizures, especially when it's 4:03 in the afternoon. I took a nap for a few hours, and I woke up like 10 minutes ago. Well, maybe long, maybe like 20 minutes ago. And like, I started having my jerks. And 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 basically, this is what happens when myoclonic seizures. I usually never catch them on camera because they usually happen in the morning. In the morning, I'm tired and all I want to do is eat breakfast and get dressed and get ready with my day. But it's really not that bad. I mean, now that I'm on Keppra, it's not too bad. As it was, I was dropping things, throwing things before. Now, like, I don't really get them anymore, or unless I just don't notice them at all, which if I don't notice them, that's great, but I'm noticing them now for some reason. I don't know.
So this adolescent is typically telling you the history. She's giving you the typical history that she used to drop things in the morning. She was giving you the typical history of juvenile myoclonic epilepsy. So this girl typically told you that, guys, she's an adolescent. She's an adolescent. And she has juvenile myoclonic epilepsy. She has juvenile myoclonic epilepsy. This is the most common generalized epilepsy syndrome. This is the most common generalized epilepsy syndrome in adolescents and young adults. In adolescents and young adults. Okay? 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 She told you that in the morning, she used to drop things in the morning. She used to get myoclonic jerks in the morning. Okay? Remember, 90% of them present to the doctor with GTCS. Okay? Okay. Present to the doctor with GTCS. Okay. Remember, 1/3 of them can also present to the doctor with absent seizures. Okay. Okay. Now the EEG is very specific. I'll show you a typical EEG. EEG is very specific. On your screen is a typical EEG. It's a generalized polyspike and wave. Polyspike and wave. Okay, multiple spikes and wave. Polyspike and wave. Okay, 4 to 6 hertz. Remember, 4 to 6 hertz. Okay. Okay, generalized. Polyspike and wave. It's a faster spike. Remember this. Okay, stimulated by the photic stimulation. Now, what is the drug of choice? Remember, before I go to the drug of choice, remember that it is polygenic in inheritance. Okay. Okay. Multiple genes, most of them are on 6p. Okay. Remember this. And the drug of choice is levetiracetam. Levetiracetam is the drug of choice. Remember, there are some drugs which are contraindicated in jerks. There are 3 drugs which are contraindicated in jerks, which should never be given. They are phenytoin, carbamazepine, and oxcarbamazepine. Phenytoin, carbamazepine, and oxcarbamazepine. Okay. Okay. Okay, can we go further, all of you? So before we go further, all of you, I would also like to tell you guys, you should know the drug of choice for status epilepticus. Okay. Okay. It's lorazepam. Intravenous lorazepam, remember, is the drug of choice for status epilepticus. Remember that. Now what I'll do is I'll take you back to some infections of the brain. I'll take you to, okay, meningitis and encephalitis. So let's talk about infections of the brain. Okay. Okay. Let us talk about the causes of infections of the brain in the world and in India. And I've been telling you, since morning, that the most common, cause of meningitis in children, in neonates all over the world, is group B and D strep, followed by E. coli. Okay. In India, it's Klebsiella. Okay. After 2 months, it's strep pneumoniae. Remember, I should not write here after 2 months because we have a classification. So right here, 2 months to 3 years and after 3 years. So yes, all over the world it's simple. After 2 months it's strep pneumoniae followed by Neisseria. So all over the world it's simple. It's strep pneumoniae followed by Neisseria. However, in India, guys, remember we have H influenza. In India, it's H influenza between 2 months to 3 years. In India, we have H influenza type B. Okay. 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 After 3 years, it's strep pneumoniae followed by Neisseria. Okay. Okay. Remember this. Noted, all of you? Noted? Noted, all of you? Okay. So let us talk about encephalitis now. Encephalitis means inflammation of the brain parenchyma. Encephalitis is defined as an acute onset fever and altered mental state. Suddenly, someone has gone into coma, he had fever and altered mental state. Now remember, all over the world, the most common encephalitis, all over the world, 80% is enteroviruses. All over the world, the most common encephalitis is enteroviruses. Okay. Now, which is the most common sporadic encephalitis? Most common sporadic encephalitis is herpes. Remember, herpes involves the temporal lobes, and on CT, the temporal lobes are more black. They look, hypodense. So on CT, temporal lobes are more black. They are called hypodense. So, of course, the investigation of choice for any encephalitis will be PCR of the CSF. CSF PCR will be the investigation of choice for any encephalitis. The drug of choice is intravenous acyclovir. The drug of choice will be intravenous acyclovir. Now, which is the most common encephalitis in India? Remember, in India, it's Japanese encephalitis, which is common in rice fields in children who are 5 to 15 years old. So in India, remember, Japanese encephalitis is more common, okay? Common in rice fields in 5 to 15-year-old children. Okay, all of you, any doubts? I'll give you 2 minutes now to type something. How's the class going on? Are you understanding? Do you want to say something? I'll give you 2 minutes. And then I'll take you to nephrology. Anyone, you want to say something? I'll give you 1 more minute and then we'll take you to nephrology, the last topic of the day. Okay, Pawan wants to read about febrile seizures. Remember, Pawan, febrile seizures are the most common seizures during childhood. Remember, Pawan, febrile seizures are the most common seizures during childhood, which happen between 6 months to 5 years. So, Pawan, remember, febrile seizures are the most common seizures during childhood, which happen between 6 months to 5 years. So, you should know, Pawan, what are the risk factors for recurrence of febrile seizures? So, there are major and minor criteria for recurrence of febrile seizures. In fact, this question came in INICT exam 3 weeks back. Question tha, risk factors for recurrence are all except. Okay? Major and minor criteria. So, these are the 3 major criteria for recurrence. Okay? Age less than 1 year. Duration of fever less than 24 hours. Fever 38 to 39. Minor criteria are family history of febrile seizures, family history of epilepsy, complex febrile seizures, daycare, male gender, low sodium at the time of presentation. So remember them. This is very important, especially for the INICT exam though. Okay. So if there are no risk factors, 12%. If there's one risk factor, 25 to 50%. If there are 2 risk factors, 50 to 59%. Okay. Three or more risk factors, 73 to 100%. 3 or more risk factors, 73 to 100% is the risk of recurrence. Okay, 3 or more risk factors, 73 to 100% is the risk of recurrence. Okay. So remember, rarely febrile seizure can cause epilepsy. You should know, rarely. Rarely febrile seizures can cause epilepsy. You should know. There are some risk factors for epilepsy of febrile seizures. Okay. So you should know, rarely there are some risk factors which can cause epilepsy. So you should know this. Okay. If it's simple, what do I mean by simple febrile seizure? By simple febrile seizure, I mean that duration of fever, duration of seizure is less than 15 minutes. So simple febrile seizure. Okay. Okay. Only one seizure in a day is simple. So the risk of epilepsy is 1%. So risk of epilepsy is 1%. Recurrent febrile seizures 4%. Recurrent febrile seizures 4%. Complex, by which I mean duration is more than 15 minutes, multiple times in a day, 6%. If fever within 1 hour and he gets a seizure, 11%. Okay. Family history of epilepsy 18%. Complex focal, बच्चा बेहोश हो गया, it was focal 29%. And neurodevelopmental abnormalities or mental retardation 33%. So neurodevelopmental abnormalities or mental retardation 33%. Okay. Okay. Noted? All of you, please tell me noted. So remember, if someone has a developmental delay or mental retardation, 33% is the risk of epilepsy lifelong. Noted, all of you? Please write noted in the chat box. So let's talk about how do we treat febrile seizures. Thank you, Pawan, for asking us to take this topic, because you should know how do we treat febrile seizures. So remember, the drug of choice is midazolam now. Now we teach the parents, if the duration is more than 5 minutes, you should give nasal midazolam. If the duration is more than 5 minutes, you should give nasal midazolam. Okay? To treat febrile seizures. Per-rectal diazepam can also be given, but it has, its own social concerns. Per-rectal diazepam is also can be given, but it has its own social concerns. So how can we prevent febrile seizures? Let's talk about prevention. Let's talk about prevention. Let's talk about prevention. So normally, American Academy of Pediatrics says there is no need. However, if a child has a recurrence risk, you can give them intermittent prophylaxis to prevent febrile seizures. You can give them intermittent prophylaxis to prevent febrile seizures. What do I mean by intermittent? By intermittent, I mean whenever he gets fever, you give him oral clobazam. It's a clobazam. It's a new benzodiazepine or oral diazepam for 48 to 72 hours. Okay? Intermittent. Whenever he gets fever, give him prophylaxis. So remember, paracetamol does not prevent. Paracetamol does not prevent febrile seizures. Remember this. So clobazam prevents febrile seizures. Okay? Remember this. Okay? Noted? Okay, all of you have noted. Please remember two important complications of febrile seizures. Number one, of course, epilepsy can be a chance, and I told you some risk factors. And the second is children who get prolonged febrile seizures, on the MRI, you see mesial temporal sclerosis. Mesial temporal sclerosis. Okay? Okay? Cool? All of you? Cool? So now I'll take you to nephrology, and in nephrology, I will take you to the latest guidelines of nephrotic syndrome. Because in 2021, I am a pediatric nephrologist, guys, since last 12 years. I'll just maybe briefly tell you about myself. My name is Siddharth Sethi. I'm a peds nephrologist since last 12 years, and this is the hospital where I work in Gurgaon. Since last 12 years, I'm the head of pediatric nephrology, and I look after children with kidney disorders, acute kidney failure, chronic kidney failure, kidney transplants. We do the largest number of the kidney transplants in our country. Okay. So let us talk about nephrotic syndrome in children. The last topic of the day, the new guidelines for nephrotic syndrome for a child. How do you define nephrotic syndrome? According to the new guidelines, we define it as a urine dipstick 3+ or more, or a urine protein to creatinine ratio more than 2, and serum albumin is less than 3, and serum albumin is less than 3 gram per deciliter. So serum albumin is less than 3 gram per deciliter. Remember, if albumin is low, your liver has to work more. So this is the definition now. But if albumin is low, it leads to hyperlipidemia. It leads to hyperlipidemia. Okay. Okay. By which I mean that the serum cholesterol is more than 200 milligrams per deciliter. Serum cholesterol is more than 200 milligrams per deciliter. Now, what is the pathology of nephrotic syndrome in a child? It's mostly minimal change. So on light microscopy, there are minimal changes. Okay. How do you treat nephrotic syndrome in a child? So remember, for the first episode of nephrotic syndrome in a child, remember prednisolone, it is steroid sensitive. So nephrotic syndrome, prednisolone is the drug of choice. There is no doubt about it. 6 weeks daily and 6 weeks alternate day. 6 weeks daily and 6 weeks alternate day. Okay, remember 70% of these children relapse. 70%. Again, so that's the problem. Now, what is a drug of choice according to the latest guidelines for a frequent relapser nephrotic syndrome? So remember, if a child is frequent relapser, now the drug of choice is low dose alternate day long term prednisolone. So we give low dose alternate day long term prednisolone for almost 1 year. If he fails this therapy, we give oral levamisole for almost 1 year. We give oral levamisole for almost 1 year. Now, what is the drug of choice for steroid dependent nephrotic syndrome? What is the drug of choice for steroid dependent nephrotic syndrome? Again, we start with a low dose alternate day prednisolone long term for almost 1 year. If it fails, we go for a drug called oral MMF. MMF is mycophenolate mofetil. So MMF is mycophenolate mofetil. Okay. So MMF is mycophenolate mofetil. No, things have changed, Dr. Satpathy. So that's why I am here today to tell you the new guidelines. So now for steroid dependent, we give mycophenolate. Now, Dr. Satpathy, here in the audience here, if this child is steroid toxic, by which I mean he has got steroid side effects, all the side effects of steroids, steroid toxic, steroid dependent nephrotic syndrome. Now, he's got all the complications of steroids. You know, he's stunted, he's got a cataract, hypertensive. So, stunted, cataract, hypertensive. Okay. Oral cyclophosphamide. So, this is what I mean. If in your exam you have a patient who's got side effects of steroids, and they're asking you what drug you'll give oral cyclophosphamide for 12 weeks. Now, what is steroid resistance? And guys, you know, we changed the definition. I was the secretary of our society till a few years back. What is steroid resistant nephrotic syndrome in a child? Now we define it as no response to prednisolone 2 milligram per kg prednisolone for 6 weeks. So if there's no response to prednisolone 2 milligram per kg for 6 weeks, we say it's steroid resistant. And remember, the drug of choice for steroid resistant nephrotic syndrome is calcineurin inhibitors. Calcineurin inhibitor, tacrolimus, followed by cyclosporine. Tacrolimus followed by cyclosporine. Okay. Noted, all of you? Have you noted this? Please tell me noted in the chat box. Noted? All of you, let me know if you've noted, then we'll take you to the genetics. Noted? Now, few years back at All India Institute, you know, I'm from All India Institute, and few years back at All India Institute, there was a girl, she was doing her PhD in genetics. And the topic of her PhD was genetics of nephrotic syndrome. The day her PhD started, we started asking you questions on the genetics of nephrotic syndrome. So this is nephrin, which binds to podocytic proteins. This is podosin, which is on the top of the podocyte. So we'll talk about which gene codes for which protein and the mutation causes which disease. So there's a gene called NPHS1, which is on chromosome number 19. It codes for nephrin, and the mutation causes the Finnish variety of autosomal recessive. So it was initially seen in Finland. The Finnish variety of autosomal recessive congenital nephrotic. Congenital, I mean nephrotic syndrome in the first 3 months of life. Nephrotic syndrome in the first 3 months of life is congenital. And now the treatment of choice for this is nephrectomy. We remove the kidneys and we do a kidney transplant later on. There's a gene called NPHS2, which is on chromosome number 19. It codes for podosin, and the mutation causes a genetic variety of FSGS, which is called steroid resistant FSGS. It is genetic FSGS called steroid resistant FSGS. Okay. Noted? So if someone has a genetic cause, no drugs work. Remember, if someone has a genetic cause, drugs do not work here. Now this child will not, any drug will not work in a genetic FSGS. So all of you, we normally do not do kidney biopsy in nephrotic syndrome. We only do kidney biopsies if a child is steroid resistant. Remember, we don't do kidney biopsies in children unless they are steroid resistant, and I gave you the definition of steroid resistance. So that was all for the crash course. Students, I have included everything which will come in your exam. I've included everything which will come in your exam. So all of you, do let me know on the Facebook how you like the class. Stay in touch. These are all my handles of social media accounts, and I will see you in DVT. And I will not tell you anything new in DVT. Yes, because DVT is meant for revision. So I will try to revise important concepts with you in the DVT. That was all, and I wish you all the best on behalf of DAMS, and I will see you on the other side when you become a PG. You join my hospital, and I'll be scolding you on the other side. Thank you. Good night, and all the best.